Good afternoon, gentlemen. A very warm welcome from Hyderabad, where we are taking this afternoon revision, courtesy Dr. Bhanu Prakash's YouTube channel. Let me welcome you again. Good afternoon, namaskar, sat sri akal, adab, and salam alaikum to all my students across India, across the world sometimes. Many of you should be waking up and rubbing your eyes, okay, and many other places. So this is what we are going to start today, ophthalmology revision. The exam coming up next month. So what we're going to do is a short and sweet, hopefully, not too short, but very sweet ophthalmology revision, where we'll go over the most important topics. Okay? Kindly listen to me carefully, because this is the meat, the concise, where we have ripped off all the fat. There's no fat here. Clean meat. This is what we're going to present. Please interact with me, and this is ophthalmology revision, which is, see, look at those hypnotic eyes, most beautiful structure in the human body, as I keep telling you. And guiding you through this is your friendly neighborhood ophthalmologist, Sashwat Ray. Those who do not know me. Very well. So now that we've done the introductions, move on to our topic. Lovely eyes. No other structure. So the first we will talk about is embryology. We have these MCQs about embryology, ophthalmology, which is of course a part of anatomy also. All gentlemen, please, can you all hear me? Can you all see me clearly? If not, please write to me on the chat box here. Okay. Please let me know. Yes, I can see some of you are already dissing me as James Bond. Yes, the attitude is very similar, as you know, all know, but that's all that matters. So if you all can hear me and see me, we'll proceed. So embryology, remember, very basic stuff we need to know. We usually get one MCQ, sometimes, not always. The embryology, you know that of the three primordial primordial germ cells, we have ectoderm, endoderm, and now the good thing about ophthalmology is that we do not have any derivative from endoderm. Everything comes from ectoderm, mesoderm, and neural crest. Okay? The ectoderm we divide into two types. Divide into surface ectoderm and neuroectoderm. Surface ectoderm have the questions. Surface ectoderm. Remember, the maximum questions usually asked from surface ectoderm. And to remember them, to mesoderm we have some, and neural crest. Endoderm, there are no derivatives in ophthalmology. So let's look at the ectoderm. And surface ectoderm we divide. Remember how to remember this? Remember, these are memory games. Again, mnemonics. And we are going to speak in English. Remember, I am using one language here, English. For those of you who are not that great English, kindly tell me. So switch to Hindi. But not, unfortunately, to any other South Indian subject, the language. So level, we meant by level. What is level? That is L for lens. Remember, this is the MCQ maximum asked. Lens. They always ask to ask this question. Where is the human lens derived from? It is from the surface ectoderm. Then E for epithelium of all the structures except the iris ciliary body. V for vitreous. Remember, vitreous comes from all the layers of all the three primary layers. And L for lacrimal apparatus, the apparatus which drains the tears into the nose. So L, E, V, L, of which the first and the most important MCQ, remember, always asked, lens derived from surface ectoderm. The second part of the ectoderm was the neuroectoderm. And how to memorize this? By this mnemonic, ROSE. ROSE. And what is that? I had a student like that once, called ROSE. And I remember, so R for retina. Remember, it's neuroectoderm, so that gives us the help. ROSE. R for retina. O for optic nerve, naturally, the neuroectoderm. S for the sphincter and the dilator muscles of the pupil. That's a surprising addition there. And E for the missing epithelium of the iris in the. Remember, we did not have this epithelium in the surface ectoderm, so we have it in the neuroectoderm. So ROSE, ROSE, neuroectoderm. Then comes the mesoderm. The mesoderm we memorize by this mnemonic called meso. The M for muscles, the extraocular muscle. Remember, that means all the 7 muscles: superior rectus, inferior rectus, lateral rectus, etc. E for endothelium of all the ocular and the orbital blood vessels. Endothelium comes from the mesoderm. S for the sclera and the Schlemm's canal. And O is for the, just to complete, ocular vitreous. Just to complete the mnemonic, O stands for ocular vitreous. So remember, vitreous comes from all the three layers. So of this is meso. But rarely do we ask MCQs, mesoderm. And what is left behind is the neural crest. Neural crest. Good afternoon, gentlemen, all of them. We are now giving up. Some of them are calling me boss. Good afternoon, boss. All these things. Keep interacting. If you have any questions, please ask me. We'll get back to you. Neural crest, remember, we have rest of it from neural crest. The corneal stroma and endothelium, of which you can be asked endothelium, but usually not asked. Trabecular meshwork, ciliary muscles, and these are the three most important. But as I said before, the only MCQ they asked from surface ectoderm, mostly they ask about the lens. So I'll be happy if you remember that. So remember, these are the questions from anatomy, embryology of ophthalmology. One question can be asked. Okay, very well. So then we go to the anatomy of the orbit, because we now the next topic is the orbit, the lacrimal apparatus or the adnexa. Rule of 7. Remember, we have 7 rules in ophthalmology here. Rule of 7. 7 bones, which you don't have to memorize. 7 muscles, you have to. 7 nerves, you have to. Okay, but you do not have to remember the bones. And you can see the orbit here with the superior wall, the inferior wall, the medial wall, and the lateral wall. The volume of the orbit is about 30 ml. About 30 ml. So this you might have to remember. But also you have to remember the volume of the eyeball is 6 ml. That means only about 30% of the volume of the orbit is occupied. Okay. What else? And the thinnest wall of the orbit is the medial wall. But remember, it is not the most commonly fractured wall. The medial wall is the most common, is the thinnest wall, because you remember the lamina papyracea is here, is it not? The medial wall contains the lamina papyracea, the paper-like, the paper dosa-like wall of the ethmoid. It is the thinnest wall in the entire orbit. But that is not the most commonly fractured bone. The most commonly fractured, the inferior wall, as we'll discuss a little later. In blood fracture, yes, you're absolutely right. Somebody said blood fracture. Very well. So let's go to the next thing, and here, next topic is the anatomy of the eyeball. Now we did the globe, did the orbit and the globe. You know the 3 concentric layers. You know that the eyeball is 3 concentric layers. One, the outer, the middle, like a series of Matrushka dolls. No, the outer cornea sclera for protection. The middle was the uvea, which consists of iris, ciliary body, and choroid. No? The vascular wall for the blood vessels, and the inner retina. You can see third layer, most important, the nervous layer is retina. 3 layers, 1, 2, the way the eyeball has been constructed. Very well. What next? The next thing is there are 2 avascular structures. Remember, there are 2 structures in the eye which do not have blood supply. Cornea and the lens. You have to, which structure in the eye do not have a cornea and lens. And the total refractive power is plus 60 diopters. Remember, we have 60 diopters power of the total eye, of which 43 comes from the cornea and 19 from the lens. So 70% comes from the cornea and 30% comes from total power of 60. Amazing power of the eye. So then the next thing is to remember certain basic ophthalmic measurements. Remember some important numbers. I always keep stressing this in the class. There are certain numbers you have to memorize. Okay, all of them are not important. So what are these numbers? Let's look at them first. The orbital volume 30 ml. We all know that, and the eyeball volume is 6 ml. These are the numbers we have to memorize. Remember, whatever I mentioned, these 2 slides, basic ophthalmic measurement, memorize. Axial length, you know the distance between the cornea and the retina. Axial length is approximately 24 millimeters. AC depth average is about 3 millimeters. And here I want to remember, critical angle. What is that? The critical angle is 46 degrees. What does that mean? You see, For total, you can see this picture. You see what happens when we want to see the angle. Why we cannot see the angle structures is because of this condition called as total internal reflection. Because the light, it goes from the angle, reflects to the cornea and enters the cornea back again. So that is why we cannot see the angle structures with the naked eye or even with the slit lamp. So this critical angle, when it is more than 46 degrees, if it is less than 46 degree, so that is why it totally reflects internally. When it's more than 46, then it can go out like this. What we do in gonioscopy, remember this is the gonioscope, which is the instrument which is placed on the surface of the cornea, called the gonioscope. So when we place this instrument on the surface of the eye, it creates an angle of more than 46 degrees. So that is why it goes out now and we can see. So for goniosis, critical angle is often asked that more than 46, the angle less than 46. Okay? This is the critical angle of the anterior chamber. The next thing is what is the average corneal thickness. Remember, it varies from 500 to 600 microns with an average of about 540 microns. Okay. Then something very important which I keep stressing, remember that the only thing that is higher in the aqueous humor as compared to blood is ascorbate. The ascorbate is, or vitamin C, is almost 30 times higher than in the blood. So this can be asked in a question, and it does ask questions. Remember, this is not vitreous. I'm so sorry. This is misprint. This is aqueous. Aqueous. So remember that if this can be asked in this question, that which component is higher in the aqueous compared to that of the blood? The answer is vitamin C or ascorbic acid or ascorbate. Okay? The rest of the things are higher in blood. And aqueous formation, remember, 2.5 microliters per minute. We have to remember this figure. We like to ask you this. And the diameter of the optic disc is approximately 1.5 millimeter, and so is the fovea. So remember, we call this as optic disc diameter, ODD. This is 1.5 millimeter. So sometimes they may ask you a question, whereas how much is 2DD? 2DD will be 3 millimeters, and 3DD would be 3 disc diameters, be 4.5 millimeters. So sometimes we like to express the dimensions in disc diameters just to be able to confuse. Okay. The next thing is the visual field. Remember, this is what you see visual field here, which has already come here. The visual field, superior 60 degree, nasal 60 degree, 70 degree inferior, and temporal wider. So we use this mnemonic to memorize this, called SNIT. SNIT. SNIT stands for superior 60, nasal 60, inferior 70, temporal 100. The shortest is superior, can you remember, always asked. Widest is temporal because of anatomical boundaries. Superior frontal bone and the nasal bone, they obstruct the visual field, but temporal bone does not obstruct it. The widest is temporal, the shortest is SN. Very well. So these are some important figures. There's another slide of important figures which you need to see. What is that? This. Remember, what is the definition of high myopia? Is anybody wearing more than -6 diopters? And some of you, my friends sitting here, are highly myopic. More than 6 diopters. Anybody is -6, 6.5, 7, 8, 10. So considers high myopia. Intraocular pressure, normal range, you have to remember 10 to 21 millimeters of mercury. Average of 16 millimeters of mercury. And what is the site of intravillolar? Look at that. It is to be approximately, this you have to memorize, 3.5 to 4 millimeters from the limbus. Okay, so look at that, how we measure it. From 3.5 to 4 millimeters, we measure it like this. Is the site of the pars plana. You want to give an intravitreal injection. You go through this, anywhere through this, but usually we go through the supratemporal area. We take the needle straight in from 3.5 from limbus. This is the surface anatomy of location of the pars plana. The location of the pars plana, to which we have to go when we have to inject a intravitreal. Very well. So this is what we've got. So basic ophthalmic measurements are okay. And now we go to orbit and admit. I'm going a little fast, as you can imagine. But we need to finish this today. We don't have all day. Courtesy Dr. Bhanu Prakash's channel. So we cannot impose on him the whole day. Very well. Now, most common cause, look at the proptosis. You know proptosis means exophthalmic eyeball. What is the most common cause of proptosis? The most common cause of proptosis in adults is the thyroid eye disease. Remember, in thyroid eye disease is the most common cause, unilateral proptosis or bilateral. And then, but however, do remember the most common presentation of thyroid eye disease is not, and I keep repeating this, not proptosis. It is lid retraction. Lid retraction is different. The upper lid gets pulled back like this. Back like this. So this is the most common presentation. The most common presentation is lid retraction of thyroid. Okay. The proptosis comes next. Second common, not the most common. And the next thing is the most common muscle to get restricted in thyroid eye disease, TAD, thyroid eye disease, is inferior rectus. And look at the mnemonic. How do you measure this? I am so lucky. IMSL stands for I am so lucky. Why am I so lucky? Because I have such wonderful students sitting in front and watching me across the world, across India. So this stands for inferior rectus as the first muscle, then medial rectus, superior rectus, and lateral rectus. The rule, the inferior rectus is always the first muscle to be restricted. Means why does it get restricted? Remember, in thyroid, the muscle fibers, they get replaced by fatty tissue. Then the muscle fiber cannot contract. It cannot contract. The muscle cannot get restricted. Okay, so it cannot move the eyeball here and there. That is called as muscle restriction. Okay? The first muscle to kindly get is inferior rectus. Please remember this. If you make a mistake, ladies and gentlemen, I will not forgive you. Remember, wherever you are in the world, I will come. Okay? Please do not forget this. Very well. What next? And remember the sign of thyroid eye disease. You know what we call. What happens is, I told you, the muscle gets infiltrated with fat. What happens? The muscle, if this is the muscle fiber, the muscle becomes like this. It becomes enlarged, and it becomes enlarged like this, and with sparing of the tendon. So this is the tendon which gets spared, but the muscle belly, okay, and the muscle. Excellent. Somebody has told me the Dalrymple sign, Pratyusha. Too good. I don't want to give you the names to confuse you, but she's the correct name. That's right. So look at the muscle enlargement. It is always the muscle belly and with sparing of the tendon, and that is why there is proptosis. You see, because there's enlargement of the muscle belly, so there is no space in the orbit, and this pushes the eyeball out, which is what causes the proptosis. And this sign, it is the radiological sign of thyroid eye disease. Remember, you can, even radiologists can tell us by looking at the scan that this particular enlargement is called the Coke bottle sign, because like a bottle of Coke, which you can see here, okay, this very smooth, very sinuous and very seductive looking outlines of the Coke bottle. This is the Coke bottle sign, also Coca-Cola. Very well. This is about thyroid. Next is what about the orbit? Now we come to the blowout fracture. The blowout fracture, this, somebody asked, this session useful for NEET PG? Also, yes, please, it is also useful. It is also useful for NEET PG. Those of you who are looking for also. So, this is the blowout fracture. What is the blowout fracture? It's blowout like that. And the blowout fracture, the most common fracture, we mentioned this, is the inferior. Why is that? The medial wall is the thinnest. Then why does the inferior wall fracture? Because I told you, or tell you why. Because you see, the medial wall, even though the thinnest, is supported by the air cells of the ethmoid. The ethmoid is full of, and you've just had a ENT session, so you know the ethmoid air cells, they are compartmentalized like this, honeycomb, and because of the honeycomb structure, it gives a lot of strength to the overlying medial wall with the lamina papyrus. But the inferior wall, even though it's stronger, does not have a very strong support, because what lies beneath is the maxillary sinus, does not have air sinus, and it is a cavernous or cave-like structure, hollow. So the hollow maxillary sinus cannot support the inferior wall. That is why it fractures more. Okay, so that's a very important thing. We diagnosed by the classic triad of diplopia, infraocular anesthesia, and enophthalmos. Call it die, not that death, not damn death. We all have to die one day, but not today. Diplopia, double vision, infraorbital anesthesia. So here we'll get anesthetic because there's a nerve here called the infraorbital nerve that gets damaged. Touch it with the pin, you feel it. You touch the burning matchstick, infraorbital anesthesia. And enophthalmos means sunken eyeball goes inward, okay, or sunken inward. This is how we diagnose the blowout fracture. The famous teardrop sign, where you see the orbital contents herniating into the maxillary sinus like a drop of tears. Look at that. Can you see the teardrop? This is the teardrop sign. You see this is intact here. You see the orbital content herniating like this, and you can see the hollow maxillary sinus, but you see the medial wall is intact because of the air cells of the ethmoid sinus. What is the moral of this? Remember, the moral of this, ladies and gentlemen, is that however strong you are, important to have a very strong supporting structure also. Be careful, many of you are very strong and you pride yourself on your strength, mental and physical. But remember, your support structure is also important. Your friends, parents, faculties are equally important. Okay? Remember, support structure is very important. Right, so what else? We go to the next important topic of the office, orbital tumors. And orbital tumors are forming a very important source of MCQs nowadays. The most common primary tumor of the children. Now remember, here we have to have three important. First, we have to look out, are they asking questions about the orbit or are they asking questions of the eyeball? There are two different things. Orbit, the bony cavity, eyeball is the soft tissue. We've got a question. Is the sound okay, ladies and gentlemen? I've got a query here. My sound is lagging behind. So we'll just look at that. And a PDF, yes, you will get a PDF of this at the end of the class, however, not now. This is the dermoid cyst. And remember, when you ask the question, most common primary tumor, first you remember it's primary or secondary. Secondary means metastasis. Primary means primary. Is it orbit or is the eyeball? Second. And third, is it children or is it adult? Be careful. The answer changes as soon as you change any of them. Primary or secondary, orbital or eyeball, children or adults. The first question is primary tumor of the orbit in children. The answer is dermoid cyst. Remember, this is a benign tumor on the supratemporal aspect. This is the most common tumor of the orbit, children. Orbit in. Remember, if I ask the same question of the eyeball, then the answer would become most common primary tumor of the eyeball in children become retinoblastoma. It's not. Then, what about the secondary tumors? The secondary tumors, remember, would be metastasis to the pediatric orbit, and this is famous neuroblastoma. Remember, neuroblastoma, which is a tumor from the renal gland. This is the commonest tumor to metastasize to the pediatric orbit, where you see the famous, look at the famous raccoon sign. Look at these ecchymotic patches under the eye. These are ecchymosis or bleeding from the orbital vessels, from the eyelid vessels. This is the famous raccoon sign because the child looks like a raccoon. And those who have not seen a raccoon, kindly see Kung Fu Panda 4, the latest one, okay, where you see Master Shiva looking like a raccoon. Okay. The next thing is, what is the most common primary tumor of adults? The tumor of the orbit we're talking about. It is cavernous hemangioma, a tumor of the orbital blood vessels. What are the orbital vessels? Cavernous hemangioma occurs, a benign tumor, occurs in young ladies between 20 to 50. Most common tumor. What about the secondaries then of the orbit in adults? This is secondaries from a tumor which is the most common tumor in females. You all know that. What is that? That is breast cancer. Remember, number one metastasis to the orbit comes in adults from breast cancer. Number two are lung cancer. If you get overall most common, you get breast cancer, and if you said only males, then lung cancer. The two most common metastases. And then we go to the most common orbital tumor to cause enophthalmos. Now that's an important MCQ which has been asked of late. Remember, the question is the most common orbital tumor to cause enophthalmos, which means eyeball coming in. Then the answer becomes breast cancer again. Remember, I just told you that breast cancer causes metastasis. Now the funny thing is this, is that you would expect a metastasis to push the eyeball out and cause proptosis, isn't it? But no, it doesn't. When the breast cancer metastasizes, it causes fibrosis of the extraocular muscles and it pulls the eyeball in. pulls the eyeball in, and that is why it. This is a very important MCQ. They have been asking this of late in NEET PG, FMG also. Remember, also very favorite question of the NEET people. The commonest orbital tumor to cause ophthalmos metastasis from breast cancer. Very well. So, sound is fine. Thank you very much, friends. So, this is the next. Come to the next one. Ptosis. First, you have to remember that is not called ptosis, my friends. It is not called ptosis. This is ptosis. The P is silent. And drooping of the upper. You know that ptosis means drooping of the upper eyelid. So, what is that? We divide into two. Congenital from birth onwards, and so we call it congenital if the ptosis occurs right from birth onwards within 1 year of age, called congenital. If it occurs after 1 year of age, we call it as acquired. So there is usually a maldevelopment of the levator palpebris superioris. Child is born with a development or anomaly or congenital anomaly of the LPS, so it cannot contract and pull the lid up. Causes ptosis. This is congenital. And acquired if it comes after 1 year of age. We divide this to 4 different types. Acquired. One is the aponeurotic ptosis. The most common example is a senile ptosis. Look at that, ladies and gentlemen. You may have grandparents, So the old people, usually above 70, this is, you can see, the left eye more, but even the right eye is slightly ptotic. This is called the example of senile ptosis. Also post contact lens. Those of you who wear contact lens for more than 15 years, you may land up with ptosis. Okay. Both of these are examples of aponeurotic ptosis, also called as involutional. Involution, because involution means shrinkage of tissue, atrophy, disuse, or anything. Whenever any tissue shrinks, called involution. This involutional ptosis for people, old people, develop ptosis after many years of post contact lens wear. Okay. What else? We have ptosis, but you can have ptosis when there is a myogenic ptosis, like when any of the muscles are damaged, like it cannot pull the LPS. So this could be myasthenia gravis, myotonic dystrophy. Know that myasthenia gravis occurs to young ladies, old men. Myotonic dystrophy, very common dystrophy. There's ptosis because of the weakness of the LPS. Then you have neurogenic ptosis, where the nerve is damaged. So it cannot contract and cannot pull the lid up. And neurogenic ptosis, we call it neurogenic ptosis. The examples being third nerve paralysis. That third nerve supplies the LPS, it's paralyzed, so LPS cannot contract. Okay. And Horner syndrome, remember, is paralysis of the sympathetic, oculosympathetic paralysis, OSP. Call it oculosympathetic paralysis is the given Horner syndrome. And this Horner syndrome, the sympathetic plexus, it causes innervation of the Mueller's muscle. The Mueller's cannot contract. Ptosis. Okay? So this is the Horner syndrome. And then we have the fourth kind of ptosis called mechanical ptosis, where some lid mass, could be chalazion, could be a lid tumor which pushes the lid down and causes a mechanical ptosis. There are 4 different types. Now, what is the management of ptosis? It's always a surgical management, no medical management here, no medical management. And so what we do, operate on the LPS, because LPS is the most important muscle. But before operating the LPS, we have to find out whether the LPS is weak or is it strong. You see, if you operate on a strong muscle, it becomes stronger and it can work. If you operate on a weak muscle, it will not help. So first we have to assess the strength of the LPS. How do you do that? Look at that, LPS function. So if it's good, we do LPS dissection. If it's poor, LPS dissection is not going to help. So how do we that determines surgery of cells. How do we assess the strength? We ask them to look down like this, put a scale here, and then we ask them to look up. See, suppose I look down like this, scale is here, you can see the picture here. So it will come something like this. So you will see the patient looking down, you put a scale here, and you tell him look up. When he looks up, you see, measure how much is the scale at the tip of the at the eyelid. So look down, this is scale 0, look up. The maximum that you can look up like this, measure the millimeters. The excursion, LPS, millimeters. And normal is 15 millimeters. Anything more than 12 millimeters, good. Anything less than poor, 4 millimeter is poor. If it's good, then we do LPS resection. What is that? That is the surgery. When we have good LPS, we cut the LPS and we stitch the muscle back again. So the good LPS is very powerful, it pulls the muscle up. Okay? So this is the most common surgery. You have to remember this particular name, LPS resection. This contributes for almost 85% of ptosis surgeries. So if I'd be happy if you remember this one, this is the most important. You can see that this case here where you see this is the original ptosis and post LPS the eye looks fine, is it not? However, if it's a poor LPS, then this is not going to work. We have another surgery which we call as frontalis suspension. So you don't have to remember this name, but for poor LPS, this is asked often sometimes in NEET PG, frontalis suspension for poor LPS and LPS dissection for good. So this is the surgery. We have done our ptosis also. Next thing after ptosis is going to be the lacrimal drainage. Okay? You know the lacrimal drainage consists of 7 parts, not the anatomy. There are a system of 7 pipes or very short tubes and holes which make up the lacrimal drainage system. Let's quickly review that. You see, okay. Remember the lacrimal gland? So lacrimal gland, this is a big gland, almond shaped on the 2 supratemporal areas of the orbit. Supratemporal. So you have these big glands. So these 2 big glands, they secrete the tears into the temporal part of the, and then the lid blinks. Okay, the lid blinks and they transfers the tears to the nasal part of the eye. Remember, the lids, it is the blink that is so important that will transfer the tears from the temporal to the nasal. They cannot transfer themselves because of high surface tension. So if you have a poor lid blink, if we are blinking less, that is why it will not drain into the nasal half. It is important for the tears to drain into the nasal half because that is where the drainage apparatus is waiting with wide open jaws like a crocodile, like a saltwater crocodile waiting. On the nasal half of the 2 lids, you see 2 small holes in the upper lid and the lower lid. We call them lower punctum and upper punctum. Lower punctum and upper punctum have small holes, and the tears drain down the lower punctum through a very short tube called the lower canaliculi, and the upper punctum through the upper canaliculi. Remember, canaliculi, not canal. Very minute, very thin pipes. These 2 canaliculi join together for a short time into the common canaliculi. Then the common canaliculi opens up into lacrimal sac. Sac is a pouch, okay, where the tears can rest a bit, and then the sac is here, pouch here, and then from the pouch it drains down these 2 fine tubes called the nasolacrimal duct, and finally it drains into the inferior meatus of the nose. So remember the final drainage of the tears, the inferior meatus of the nose, and this is where we have a territorial fight. The ENT surgeons who object to our studying the inferior meatus because they say that's a part of the nose, but we have to fight them. We say, my friend, we are talking about the tears, which is an ophthalmic zone, is it not? But we have this territorial fight, the ENT and the ophthalmic surgeon in the inferior part of the nose. Look at these 7 tubes and pipes together. We start with the lower punctum, upper canaliculi, lower canaliculi, common canaliculi, lacrimal sac, nasolacrimal duct. Okay, so finally into the inferior meatus. 7 stations as it passes through. And remember, there is a valve here. There is a valve here which guards the flow of tears from the eye to the nose. But it will not allow the reverse backflow. Now, why not? Because you don't want the mucus stained tears to go back into the eye. So this is a very protective valve which opens only one way into the nose. Okay? So it allows the tears to come into the nose but not reverse backflow. Okay? And this valve, unfortunately, it gets blocked. Okay? This valve unfortunately gets blocked sometimes, and as it gets blocked, so we get to the next topic, which is what is important for your MCQ is the congenital nasolacrimal duct obstruction, NLDO. This is the thing that happens from birth onwards, where the nasolacrimal duct gets obstructed because the valve is not open at birth. This valve is not open. So let's look at that. What would happen is this condition occurs to children and almost 6%. Now remember, you might think 5 to 6, small figure, but in a country of 1.4 billion people, 6% can be a hell of a lot, is it not? So these kids, what happens? The valve is not open at birth. For some reason, it is closed. So this valve name you have to memorize. We call it the valve of Hasner. Is called a persistent. So it's not open. No, it's closed. As it closes, it does not allow the tears to drain through the nose. So these tears, they collect at the lacrimal sac. Remember, there's a pouch, and they get infected. This child comes to us with tears watering down his cheek, called as epiphora. Okay. So remember that. Otherwise, it should normally drain into the nose, but since it is closed, it goes down the eyelid like this, which is called as epiphora. So drainage of tears down the cheeks is called as epiphora. And you see this classic triad, as you can see, epiphora discharge because it gets infected, and as discharge dries up, we call it crusting. Crusts. You have these three things. We have epiphora, discharge, and crusting. Look at the crust here, the dried up discharge, and we can see the discharge and the tears would rain down. So it's a very unhappy patient. The mother gets to us, but this is not an uncomfortable child. Remember, that's important to see comfort levels. He may be unhappy, but he's not uncomfortable, because that is very important. Remember, because this epiphora, this watering of the eyes, is a very important sign of another dangerous condition, which is called as congenital glaucoma, and that is our differential diagnosis. Kindly remember, this is a differential diagnosis. We need to see right away. So when we have kids coming down with watering of the eyes, two important differential diagnoses. One is congenital NLDO, the second is congenital glaucoma, of which glaucoma is more dangerous, obviously. So we have to see that it is not glaucoma. How do you know that? Because child is comfortable, he is not photophobic, and does not squeeze his eyes, because in glaucoma he will have blepharospasm as well as he will have photophobia. Okay, so in NLDO he doesn't have that. Okay, so 90% of these kids improve spontaneously, but 10% do not, and for them we do this sac massage. What is that? Well, digital sac massage. You push a small, ask the mother to push her finger on the sac here very gently, remember, and stroke it down like this. It goes down the nasolacrimal duct gently, very gently, remember, because the nasal bones are very fragile. Okay, so we ask them to massage. This is called digital sac massage, which works well for 6 months till 1 year of age, maximum 1 year of age. After that, it won't work because the valve becomes calcified. Okay, keep stroking this about 10 strokes every time. So 1, 2, and if you have both eyes, then you stroke it like this. 1, 2, 3. Remember, we always tell the mother, we don't want the father with his thick sausage fingers, to pushing into his. If he pushes his child's nose, it's very likely that the finger might come out from the other side of the nose also. So we have to be careful about that. Okay, very well. So up till 6 months, 1 year. But suppose it doesn't work, or the child comes to after 1 year of age, then there is no point doing sac massage. We have to do a probing. You take a very fine probe, very fine bit of titanium. Okay, and this is the NLD probe. This is the, look at that. So we put a probe right into the lower canalicula, into the lower punctum, upper punctum, and we go right into the sac. Okay, so the probe goes, you can see the picture, to the lower punctum, lower canaliculi, common canaliculi, sac, and right into the NLD, where you can see that it does that. It just push it down there. We push it down and break the valve. It works very well. So this is the NLD. We do probing after that. So probing is number 2. But probing should be done as fast as possible. The later you do it, it becomes more difficult. So after, suppose probing sometimes also doesn't help, because it's so stiff. In that case, we have to go to the third, which is called DCR, dacryocystorhinostomy. So this is called DCR, which you may have read in ENT, which is done only after 3 years of age, after the growth of nasal bones. What we do in DCR is, look at that, we connect the lacrimal sac straight into the middle meatus by passing the NLD, because NLD is fibrotic, it's not going to work. So we connect the sac straight into the middle meatus, and that is why it is called as dacryocystorhinostomy, into the nose. The MCQ, remember, in DCR is that we connect to the middle meatus, not the inferior meatus. That was the original site of the drainage of tears. Now we connect to the middle meatus. Okay, so that can be asked as a question, which you may have read in ENT also. This is the thing. So what are the MCQs which can be asked? Remember the Hasner, the name, the triad of fora, epiphora, discharge and crusting, and the most important MCQ is the differential diagnosis of glaucoma. You differentiate because glaucoma will have photophobia and blepharospasm, and the sac massage is sometimes asked too, particularly for NEET PG and NEET. You can get a DCR after 3 years also. Okay, gentlemen, I hope the speed is okay, and don't listen to it carefully, take notes as you possible. But if you can't take notes, don't worry, the PDF will be delivered to you by post as ASAP. Okay, very well. So that was the one thing that we do. Then the next thing, so that's enough about orbit. Orbit is over. Now we go to cataracts. Let's do the cataract. Remember the lens, opacification of the lens and capsule, is cataract. The world's most common cause of blindness. Not the most common cause of blindness, but remember, most common cause of blindness means almost 70% of the world's blind are because of cataracts. 70% are because of the cataracts. Okay, somebody's written, Harshita has written syringing. Remember, syringing is not the treatment of the syringing. We do put a syringe, but that is not the treatment of the blockage. Let me go back to here. The treatment of the NLDO is these steps. First, sac massage, then probing and DCR. Syringing is done to find out about the site of blockage. Where is the site of blockage? Is it in the upper canalicularis, lower canalicularis, into the lacrimal sac or NLD? Okay, the syringing is correct, but it is not a treatment. It is locating the site of blockage. Very good, Harshita. The next question. So we have cataracts, and cataracts we have, remember, 70% of the world's blind are because of cataract, and cataracts are 70% worldwide, but India is almost, India is worldwide 70%. I'm so sorry for the figure. Worldwide blindness 50% is cataract. Indian blindness 70% is cataract. Number 2 cause of blindness in the worldwide is glaucoma. But what is blindness actually by definition? By definition, it is less than 3/60. Less than 3/60. This is the cause of blindness. So remember that if you are standing 3 meters away from the Sneller's chart and being able to read only one line, the top line, you can't even read that line, less than 3/60, then you're supposed to be blind. And this is the this is the blindness less than 3/60 according to NPCB and according to WHO, less than 3/60. But remember, it's in the better eye, okay, not the bad eye. So that means that supposing you have one eye 6/6, the other eye 1/60, this is not blindness because the better eye is 6/6. Okay, it's always is the better eye. And with the BCV, what is BCV? BCV stands for best corrected visual acuity. Okay, that means wearing glasses, wearing contact lenses. Okay, so supposing it has to be checked with the glass for those of us who are wearing glasses. Okay, those of us who are not, that's fine. For those who are wearing glasses, the vision wearing glasses or contact lenses, if it's less than 3/60 in the better eye, this is blindness. Okay, so that is the blindness. Next thing is most common cataract. What is that? It is the age-related cataract. These are people who are above 55 to 60 years of age. Older people. Remember, 80% of all cataracts are older people. Okay, so these are older people who develop cataracts. This is the world's most common type of cataract, but there are many others also, as we know. Okay, and why do older people develop cataracts? Remember, the most common cause is ultraviolet, UV light. Okay, remember, UV light is the single most common cause of older people developing cataracts. So all of you, my friends, I suggest start wearing sunglasses. Okay, sunglasses, because India is a country of sunlight, a lot of UV light damaging the lens proteins, causing denaturation of the proteins. So sunglasses, remember, and those of you who've seen me in live classes, you know that I keep wearing sunglasses even in the class sometimes, which is a little bit of a, well, maybe going to far extremes, but such is the aura of sunglasses that ophthalmology, we keep it always on. Okay, very well. What are the 3 types of cataracts according to, the morphological classification? Nuclear, cortical, subcapsular. So you see, this is a lens. So we have 3 zones. If this is the nuclear, if the nucleus becomes opaque, we call it a nuclear cataract. No, and If it's the cortical, this is the cortical areas, cortical, so this is the cortical cataract. And subcapsular cataract, posterior subcapsule, this is the capsule. If this is the posterior subcapsule here, then this is the posterior subcapsular cataract. Okay, we have three distinctly different types of cataracts. Let's look at the MCQs here. The nuclear cataract, you can see here, look at the color, the amber yellow color, okay. We call it the actual color, it's yellowish, but we actually call it amber color. So this is the color of nuclear cataract. It has three MCQs, remember, it's called hemeralopia. Remember, hemeralopia is the term for day blindness, is it not? So this is a patient who cannot see in the daytime. So hemeralopia, these patients suffer from. Why daytime blindness? Well, you see why? Because in the daytime pupil constricts. The pupil constricts, what will happen? The rays of light will come only from the center. But the nuclear cataract is in the center only, so they cannot see. So they have day blindness, called hemeralopia. But during the night time, the pupil dilates. Now, pupil dilates. As the pupil dilates, the rays can go to the periphery. The periphery of the lens is clear. Remember, it's a nuclear cataract, is it not? The periphery is clear, so rays can focus on the retina. That is why they have hemeralopia, which is day blindness. So kindly remember, this is very specifically seen only nuclear cataracts, not any other kind. Index myopia, remember, index myopia, it causes index myopia because it increases the refractive index. See, what happens? This is a refractive index here. The rays of light normally focus on the retina, isn't it? Like this. So normally when you have a cataract like this, what it does, it increases the refractive index. The normal refractive index of the lens is approximately 1.4. But when you develop a cataract, because of all the lens fibers get compressed together, it increases the refractive index to 1.42. And as increased refractive index, what will happen? This increased refractive index will bend the rays of light more. Look at these. Now these rays of light, they focus here in front of the retina, and by definition, anything in front of the retina is myopia. So they have myopia, and that is the MCQ. Remember, ladies and gentlemen, the question often asked, which type of cataract causes myopia? The answer is a nuclear cataract. Which cause cataract causes nuclear cataract? And the second side is a very important MCQ, which somebody has already written here. Harshita has written again. Very good. Called second sight. Okay. What is second sight? Second sight, remember, is a unique phenomena which occurs only to nuclear cataracts because the near vision improves. Okay. So nuclear, because of the myopia. Okay. See, the same thing happens because of the index myopia. The distance rays comes in front of the retina. The near rays comes on the retina. So this patient, paradoxically, their near vision improves and their distance vision worsens. This is called a second sight, and this is seen only in nuclear cataract, which Harshita has answered very correctly. And good afternoon, Dr. Pavan. Good afternoon to you too. Please, those of you who are joining me, those of you who are waking up late, various parts of the countries, hello to you, my friends. Know your own friendly neighborhood ophthalmologist, Sashwat Ray. So kindly remember three questions. So second, what is second sight? Remember, second sight is defined as recovery of near vision in an old patient after developing a nuclear cataract. Okay? Remember, in nuclear cataracts, the distance vision and the near vision do not worsen together. The distance vision becomes worse, the near vision improves. So that is why it's called as second sight. He's recovered his vision again after many years, after he became presbyopic at 45. Okay? Nuclear cataracts. Next question is cortical cataracts, and cortical cataracts are cuneiform cataracts. Okay, remember, these are, we call them cuneiform because they look like wedge-shaped. So these are wedge-shaped cataracts. So sometimes, remember, the question can be asked, which cataracts are called as cuneiform? We'll say cortical cataract. And posterior subcapsular cataracts, our favorite cataracts, cause the maximum visual handicap. Remember, locate close to the nodal point of the eye and causes maximum glare. You know, I've just shown you the glare. This is glare. Look at the glare of the oncoming headlights. Remember, glare is very typically seen in posterior subcapsular cataracts. It is seen very typically in posterior subcapsular cataracts. So let's look at that. And so let's go back to this one. Yeah. So what are the three questions of PSCs? Remember, it has the maximum loss of vision. So of all three cataracts, remember, posterior subcapsulars have the maximum loss of vision. Why? Because they are the located closest to the nodal point of the eye, and because they have the maximum glare. So they have a maximum loss of vision because they have maximum glare, which we saw just now. What is glare? Like this, light which is not focusing on the retina, but bouncing off various parts of the retina. And why they have the maximum glare? Because they are situated closest to the nodal point of the eye. So this is also another MCQ. Which cataract is located closest to the nodal point of the eye? Again, the posterior subcapsular. Okay, very well. These are the three types of cataracts that we know, and let's look at the other MCQs which we can have. And hi, Dr. Khan, I've got your hi from here. Very much. Assalamu alaikum, Dr. Khan. Peace be unto you. And most common type of cataracts, remember, out of congenital cataracts, remember, congenital cataracts is zonular cataract. Please remember, zonular, because a specific zone of the lens is opaque, is not. Specific zone of the lens is opaque, that you see the entire lens is clear, but a specific zone of the lens becomes opaque. We call it a zonular cataract. Okay? This is the single most common type of cataract in children, and they cannot see very well. Then the next important, remember, in children, we need this critical period of fixation is 3 months. You can remember this. Actually, it is between 2 to 4 months of age, but so for easier memory, we write it as 3 months of age. And what is critical fixation? Remember, this is the time period at which the fovea becomes dominant. Okay. Remember, the fovea, which is the most important part of the retina, is not developed at birth. Okay. So it develops at birth. It takes between 2 to 4 months of age. So this is called the critical period, because if during this period the fovea is not receiving rays of light, it will not develop fixation. Okay? So a cataract, a vitreous hemorrhage, a retinal detachment, a corneal opacity, if it's blocking the rays of light, blocking the visual axis, not allowing the rays of light to focus on the fovea, it will block the fixation, it will delay the fixation. So that is why it is important for children to have a clear optical visual axis from birth onwards. So the fovea may develop between 2 to 4 months. So this is important to remember. 2 to 4 months or 3-4 months is the critical period of fixation. Rosette, look at the lovely rosette, the lovely flowers, okay, the petals of a rose, rosette cataract in trauma. This beautiful rose which is bloomed in his lens is unfortunately because of some trauma. Remember, a trauma can produce a rose also, is not. Then complicated cataracts, remember, cataracts which are due to disease of the eye. Any disease of the eye causing a cataract, be it uveitis, retinitis pigmentosa, myopia, glaucoma, any disease of the eye causes cataract, we call it complicated cataract. Okay? And there are 3 important things here to remember. They are usually posterior subcapsular, they are polychromatic, which means they are multiple colored, and they have a breadcrumb appearance. Remember, they look like crumbs of bread. Kleb, you know, kleb, to my friends in Kyrgyzstan, Russia, crumbs of bread. Okay? It's grayish white, it is granular, so the crumbs of bread. And most important question is polychromatic. Okay? Polychromatic means multiple colors. Okay? It shines like a rainbow. So sometimes we call it a rainbow cataract. Very well. So we're going to, I hope the speed is fine, ladies and gentlemen. If not, let me know, because we have to finish this. And we will have a short lunch break in about half an hour. I mean, lunch in India at least, this is the lunch break in half an hour. So hang on to it. You know? Hold on to it. Don't lose consciousness. Snowflake cataracts, very important, as in diabetics. Okay, snowflakes as in diabetics. Oil droplet cataracts in galactosemia. Remember, the question will be asked like this: a child presents to you, a newborn child presents to you with mental retardation and cataracts. Okay, what kind of cataract do you expect? You remember galactosemia. Remember, these are children. Galactosemia children are often mentally retarded. So combination of mental retardation and cataract, kindly remember galactosemia. Okay. What else we know about cataracts we should know is the sunflower cataract of Wilson's. Remember, Wilson's disease has these 2 important ophthalmic MCQs, the sunflower cataract and second, what was that? The Kaiser-Fleischer ring. Remember the KF ring because of Wilson's disease, is not? Very well. But the most famous question is Christmas tree cataracts. Of you have Christmas tree cataracts, and look at the famous Christmas tree shining like Christmas is far away right now, but in myotonic dystrophy you'll see a Christmas tree shining like a Christmas tree. Okay? All these are important for you. Glass blowers cataract. People who are making glass, working in glass factories, get exposed to tremendous amount of heat, which is a heat cataract, damage the lens capsule, we call it a heat cataract. This is the example is a glass blower's cataract. Okay? And some drug-induced cataracts, remember the ABCD drugs of cataract, certain drugs, amiodarone, which is antiarrhythmic, busulfan, anti-cancer, chlorpromazine is, antipsychotic. Chloroquine is antimalarial, but taken for long periods, like in rheumatoid arthritis. Dexamethasone, it's a steroid, systemic steroid. So A, B, C, D drugs cause cataract. But remember, it is the systemic steroids which cause the maximum cataract. Of all the drugs that may cause cataracts, can you watch out for systemic steroids? Okay? So this is a very important question often asked. So look at the MCQ. The question asked is, a chronic bronchial asthma patient complains to you with slow painless loss of vision. Chronic bronchial asthma patient comes to you with slow painless loss of vision. The answer is cataracts. Remember, the connection between bronchial asthma and loss of vision is a steroid-induced cataracts. Okay. What else? If sometimes you get a fluctuating vision in a particular cataract, it's a diabetic cataract. As we discussed today also, in diabetics we get fluctuating vision. So diabetic cataracts are well known for fluctuating vision. Okay. So diabetic cataracts can also have. So we have two MCQs in diabetic cataracts. One is a snowflake cataract. Second is a fluctuation of vision. Okay. Very well. So what next is, after types of cataract, let's look at the quick stages of cataract. Incipient, which means early, like all of you, my friends, are incipient doctors. Early, incipient means early. Immature, partially opaque. Mature, which is fully opaque, and hypermature is opaque and shrunken. Okay, so there are 4 stages of cataract: incipient, immature, mature, and hypermature. We need to know them because the symptoms vary, and you can be asked a question on the symptom. Okay, on the stage you will be able to identify the symptom according to stage, but the vision varies very much so. Okay, so let's talk about the symptoms. What would do that? First would be, of course, blurring of vision is usually a slow, painless blurring of vision, and so you have blurring of vision, and then you have diplopia, doubling of vision, or polyopia. You can have double vision or you have multiple vision, diplopolyopia. Could be colored halos, remember, rings of light around, rings of color around light, colored halos, glare, I showed you the glare, and loss of contrast sensitivity. Means that in a daylight which is snowy, which is cloudy, which is rainy, your vision drops. Okay, bright sunlight, like a bright sunny day in Hyderabad here, it's high contrast. But low contrast, we have, some of you may be facing this in Russia and Kyrgyzstan, which is snowy, foggy. These are low contrast. The loss of vision, but the classic three are loss of vision, diplopia, polyopia, and colored halos. Okay, so this is what we knew, symptoms. And when they come to us, the early cataracts like incipient and immature, we give them glasses. But if they're late, we have to do surgery, okay, because we have to remove the cataract. And so there's a question of surgeries, a lot of MCQs on surgery. So let's look at some of the surgeries of cataract. We have surgery of cataracts is intracapsular. Let's look at the earliest surgery. And my friend here, who's written unwanted, I wonder why you've written unwanted. Nobody's unwanted here. No. My friend, hi to you again. So intracapsular cataract extraction, remember, is removal of lens along with the capsule. Okay, so what we have the capsule here, okay, and the lens here. You take them out together, so capsule and cataract together, which is called intracapsular cataract extraction. So we create this condition called aphakia. Remember, phacos means lens, aphakia means no lens. We have to correct them with glasses. Now this causes a lot of problem because the glasses are very thick and they cause a lot of magnification. This is not a surgery which we do nowadays. Intracapsular is not done because it creates diplopia, doubling of vision because of magnification, is not. So these patients are suffering under big handicap because if they don't wear glasses, they can't see anything. And if they do wear glasses, then they have diplopia, double vision. We don't do that. Another important side effect of the intracapsular, you have to remember, is the famous jack in the box. Jack in the box, because things keep moving. So suppose I'm wearing a glass like this from the corner, somebody walks like this at a particular angle. As this patient walks in front, at a particular angle, which is usually around 50 degrees. So when he's at this particular angle, the rays of light, they get reflected, hits the edge of the lens and goes out, is it not? At this particular point, the aphakic patient is not able to see this. He disappears. So as he walks like this, at this particular area, he suddenly disappears and reappears as he walks out of this scotoma. This is called a jack in the box scotoma. Okay? Something like popping out of a jack in the box. So this is a very, very troubling symptom of intracapsular, which the patient really hates. Another important side to remember is the famous pin cushion distortion. which means that everything that you see in the world, buildings, cars, people, houses, everything becomes distorted like a pin cushion. Yeah, like a pin cushion you see here. So a building you would see not like this, but like a curved inwards like a pin cushion. This is called a pin cushion distortion, which occurs in every high-powered lenses of convex lens. So these three important side effects, remember, diplopia, jack in the box, and pin cushion. Okay? So we don't like intracapsular. The next surgery is extracapsular. And extracapsular, you have to remove the cataract, extracapsular surgery. Remember what we do, the difference now is we remove the cataract, but we leave the capsule. We leave the capsule intact, posterior capsule intact. So we place the intraocular lens, which looks like this. And this intraocular lens is called PCIL. So this works as a perfectly normal lens and focused rays of light, perfect in the retina. So this surgery is called as ECC with PCIL and is made up of a type of plastic called as PMMA, polymethyl methacrylate. Okay, patient is very happy with this and he has very good vision with this. So this is the surgery that we like to do, extracapsular. But there is surgery even better than extracapsular. And what is that surgery? That surgery is called as phacoemulsification. Okay, we are discussing various surgeries now. Remember the phacoemulsification? What is that? It's called stitchless surgery. Stitchless, sutureless. Why do we make the stitchless? Because then there are no stitches which can pull the cornea here and there and cause a loss of vision the first day. So how we do it? We make a very small incision around 2.8 millimeter. Okay, you can see how we enter through the sclera of the cornea, and it's called a tunnel because in three different planes, 1, 2, 3. Okay, remember this incision is in three different planes, 1, 2, and 3. So it has got like a tunnel, it's got walls, it's got a roof. It's called a multiplanar incision, which automatically seals the incision. We don't have to put a stitch. Okay, and this is less than 2.8, and then we emulsify. We have this titanium rod which goes and hits the lens at ultrasonic frequency, hits the lens at 40,000 times per second. It damages the lens, smashes the lens, and takes it out. So we do not have to enlarge the incision. We do not have to enlarge the incision. And then we put a foldable IOL. Okay, remember we have to, since it's a very small incision, so we cannot put a normal IOL. We have a special IOL called a foldable IOL, which you fold like this, and then we insert into the eye, fold IOL, insert into the eye like that, and it inserts beautifully inside like a flower. Called a foldable IOL. So these two innovations, making a small incision less than 2.8 and making a multiplanar incision, allows us to create a sutureless incision where it does not require a stitch. Does not require a stitch. It does not require a stitch. The next vision is extremely good. Okay, it's a very good vision. This is the phacoemulsification, which is a stitchless surgery. So remember the first two surgeries that we did, which was the intracapsular, extracapsular. Remember, both of them require stitches. Okay, because they are both big incisions, we have to go with stitches. But now the incision that I'm talking about, phaco being the first, it requires no stitches at all. Okay. Now the problem with phaco, remember, is the cost. And because you see, phaco machines are expensive machines. All this stuff, this crescent knife that you see here and the foldable IOLs are all expensive and they cost a lot of money. So the big cities like Mumbai, Delhi, Hyderabad, Chennai, Bangalore, Calcutta, they can do it. But the smaller cities with smaller budgets, they cannot afford it. It's not. So for them, in India at least, we have this very useful surgery, which we call as SICS, stands for Small Incision Cataract Surgery. Called the Small Incision Cataract Surgery. Look at that, what we do here. The incision here, we make a slightly bigger incision. It is 6 mm. You can see it here. It's a bigger incision here. It's not. It's a bigger incision here. It's not 3 mm. Okay. Why? Because we have to break it manually extra. Here, we don't have a machine to break it down because we want to avoid the cost of the machine. We break it out with our own hands. Okay. There are multiple techniques there. With the force of our own hands, you break it. And then, because we break it with our own hands, so the pieces are obviously bigger. So they cannot come out through 3 mm opening, but they can come out through 6 mm opening. Okay. So we take it out. And then, because it's bigger incision, so we can put a non-foldable IOL, okay, which is a PMM IOL, which is also less expensive. So we put a PMM IOL, and here also we have no stitches. Why no stitches? Because remember, the 6 mm incision does not require a stitch. Okay? Anything you make more than 6, 6.5, 6.7, 7, it will require incision. So here also in SICS, we make a multi-plane incision in 3 different planes like this. It goes 1, 2 and 3 and we make it 6 mm. So these two things, 6 mm, remember less than 6 mm will not require stitch because we make it multi-planar, is it not? So this no stitches, and again the vision is 6 by 6 but is economically viable. So remember both phaco and SICS we get a good vision 6 by 6 after surgery because there are no stitches involved. But phaco is expensive and this is very cheap because we do not require a machine, we do not require a foldable IOL. So these can be done all over our country. That is the MCQ, ladies and gentlemen. My friends, remember the most common surgery performed in South Asia or India, South Asia, all the countries that are not economically so well developed, like in South Asia. So remember if you get an MCQ like this, the commonest surgery performed in India or South Asia is SICS, small incision cataract surgery, okay? Because we get no incision, we get a small incision, but we do not require stitches again. One more surgery is called the FLACS, okay? Almost surgery is called the FLACS. It stands for femto laser assisted cataract surgery. Here we use a laser beam, okay? It's called the femto laser, okay? F stands for femto, called the femto laser assisted cataract surgery. So FLACS we have, and what we do here, we use a laser beam. Rather, it's a type of phaco only, except that we do not use a laser machine in phaco. Here we use a laser machine, which gives us a perfect capsular excess, okay? It gives a perfect circle and the tight incision. So FLACS is the latest where we use a laser beam to operate on the cataract surgery, okay? This is called FLACS. This is also stitchless. So these 3 surgeries that I mentioned, remember, these are stitchless. Okay? So remember 5 surgeries we mentioned again: intracapsular, extracapsular, both stitches. Then we have phaco, SICS and FLACS, okay? They are both types of cataract surgery which are all stitchless because we use the same technique, which means a small incision and multiplanar incisions, okay? So except that we use laser here, which is more expensive, but the least expensive is SICS. But the most commonly performed cataract surgery in India is SICS. Okay? So these are multiple cataract surgeries that we need to know. A quick word about the intraocular lens we sometimes ask you. Remember, calculate intraocular lens, has to be calculated individually for every patient. Okay? So there are so many of you sitting here watching me. So if you develop cataracts, remember, many of you wearing glasses. Somebody is wearing -1, somebody is wearing -1.5, somebody is wearing 2, 2.5. So since you all have different spectacle powers, so when you have cataract, your intraocular lens that we calculated will also be different because all of us have different eyes with different corneal curvatures, with different axial lengths, not. So for calculation, it's important to calculate biometry. Remember, the word biometry is an instrument to calculate the IOL power. This IOL power has to be calculated individually for every cataract patient. Okay? And this biometry depends upon 2 important variables, which are extremely important: the axial length and the keratometry. Okay? Since axial length for everybody is different, the IOL power will also be different. And keratometry is the corneal curvature. It's an instrument which measures the corneal curvature because some people have flat corneas, some people have steep corneas, some people have very steep corneas, So it depends on patient to patient. So what we do in a biometer, we calculate the axial length, which is about 24 for most of us. Keratometry, feed in these 2 into the biometer and we get an IOL power. So remember, MCQ asked, what are the variables on which the IOL power depends upon? These 2. And of these 2, remember, the most important is the axial length. Axial length is the most important. So if you make a mistake calculating the axial length, then the IOL power calculated will be wrong. Very careful. Remember, these are all MCQs that we can ask you. Very well. What next? Then we have the fold. Remember, the PMMA IOLs are non-foldable. They are made up of polymethyl methacrylate, but these are foldables are made of silicone and acrylic. You can see how the IOLs can be folded. You can fold like this. We can use either silicone or acrylic, okay? Any of these 2. Okay? And of these 2 IOLs, remember, one IOL we would like to ask you, of these 2 IOLs, which one of the IOLs has MCQ because it causes the least amount of secondary cataracts. Okay? Secondary cataracts, and that we'll have to ask you. That is, we talked about non-foldables made of PMMA, and look at this, the lowest incidence of secondary cataract, also called a PCO, posterior capsular opacity, is not. The lowest incidence of secondary cataracts is a hydrophobic acrylic. Remember, we have these acrylic IOLs. We have 2 different types of IOLs: hydrophobic and hydrophilic. Okay, phobic and philic means, phobic means it hates water, phobia is hate, and philic means love, it loves water. So hydrophilic and hydrophobic, remember, two different types of acrylic, but it is the hydrophobic acrylics which has the least amount of secondary cataracts. An important INET question and many times asked in NEET PG also. Okay, so this is the IOLs with the least amount of secondary cataracts. What else? And what happens? Remember, after cataracts operated, you have cataract IOL for distance vision, but for near vision there is no accommodation. There is no accommodation, so they cannot see near. So these people have to wear glasses, not for near. Now this is very frustrating for people who don't want to wear glasses. So the patient often come to doctor, you have given me good distance vision, but why can't I see near? Because the IOL is plastic and it cannot change its shape for accommodation. So for all patients, we have to give reading glasses, but people who do not want to wear reading glasses, we have a special IOL called a multifocal IOL. Okay? How do you recognize multifocal IOL? You recognize this by the grooves on the surface. Okay, remember that. You see the grooves on the surface. So this, when you will see these grooves on the surface of the IOL, it means that the patient has got a multifocal IOL. Okay? So kindly remember, the multifocal IOLs will be given to all patients who do not want to wear reading glasses after cataract surgeries. They are expensive and they have other problems, but you have to remember that we can give them. We have an alternative. So the next kind of after this is, what about the complications of cataract? We've done the cataract. Complications, three important complications. The first is the single most common complication of cataract surgery, which is the secondary cataract, also called as after cataract, also called as posterior capsular opacification, not PCO. This is the single most complication. Almost 50% of all patients land up with secondary cataract. There are two different types you can see here. The most common is called Elschnick's pearls, because you can see the pearls here. Well, not really pearls. You can see better pearls in Panjagutta, but they are called pearls because they look like pearls apparently. Elschnick's pearls and Sommering's rings. Remember, these are more common, these are less common, but you remember both names. Okay? And they cause a loss of vision. So what we have to do, we have to cut this capsule. We have to remove this capsule here, and we call it laser capsulotomy. So you remove this. So here you use the second laser, Nd:YAG laser. Remember, we have the second laser coming up of ophthalmology, Nd:YAG laser, neodymium, yttrium, aluminum, and garnet. Full form: neodymium, yttrium, aluminum, and garnet laser. And with that, we cut a hole in the capsule, something like this. Make a small hole in the capsule like this, capsulotomy. You blast a hole in it, and you have to remember the wavelength 1064 nanometer. We often like to ask that. Okay? This is a very simple surgery for a very complicated problem, which is secondary cataracts. Remember, these are late complications. Secondary cataracts are late complications. They usually come after 6 to 8 months. Okay? Usually, not before that. The second complication is cystoid macular edema, CME, and when it occurs after cataract surgery, we call it as Irwin gas syndrome. Okay, so we call this as Irwin gas. Remember IGS, important name, IGS, Irwin gas syndrome. What is that? It's defined as cystoid macular edema occurring after cataract surgery is called. Now, another very common problem for us, which will also cause blurring of vision. And the third complication is endophthalmitis. Remember, the word endophthal means vitreous. So there is infection of the vitreous cavity. It can be early onset, it can be late onset. Okay, this is the most serious complication. And remember, the most common early onset endophthalmitis, the most common organism is Staph epidermidis. Kindly remember, always ask, the commonest organism causing early onset endophthalmitis is Staph epidermidis. Also remember, why? Because it happens to be the commonest ocular commensal in the eye. Very important MCQ. What is the most common organism in the normal eye? Is Staph epidermidis. You all know that, isn't it? So that's why it caused that. But however, you may have a late endophthalmitis, which is defined as occurring after 6 weeks of cataract surgery. If it occurs before 6 weeks of cataract surgery, we call it early onset. If it occurs after 6 weeks, we call it late onset. And here, this is called as caused by P. acnes, Propionibacterium acnes. So can you remember, P. acnes or Propionibacterium acnes is the most common organism causing late onset endophthalmitis. Okay? So you got infection here in the eye, and you have to treat it with intravitreal antibiotics. So this is the main complicated cataracts. One last thing about cataracts is about the fearsome amblyopia, okay, which occurs in children when they can't see, is it not? So amblyopia, also called as lazy eye syndrome, is it not? Lazy eye syndrome, which is seen in children. Remember, it's one of the most common cause of loss of vision in children. And remember, an important MCQ to be noted here. If they ask you the commonest cause of blindness in children, you will say vitamin A deficiency. If they ask you most common cause of loss of vision in children, it is lazy eye syndrome or ambliopia. Okay? So what is it? It's defined as loss of vision. How much? At least less than 2 lines. Okay, less than 2 lines. So if you are reading say 6:12, then there's amblyopia, or less than that, 6:18, at least 6/12. So if you're reading 6:9, this is not amblyopia. 6:12 is amblyopia. Less than 6/12 is amblyopia. Okay, 2 lines or more in children, not attributable to any structural defect. Okay, so that means a child who's reading say 6/18 but has no problem, no structural defect, which means no cataract, no glaucoma, no squint, no refractive, nothing, and yet he is reading 6/12, okay, or 6/18. This is amblyopia. And the most common causes are squint. This is the number 1 cause of uncorrected squint as a child. Second is refractive error, not wearing glasses as children, and cataracts and uncorrected cataracts and ptosis. These are the most common causes of amblyopia. MCQ, the commonest cause of amblyopia is uncorrected squint. Okay, this is very, very important. The next thing is critical period. Remember, amblyopia cannot occur after 8 years of age. So those who, suppose any of you are amblyopic here, it means that you have an amblyopic before you were 8 years of age, okay, not after that. And unfortunately, treatment is also has to be done before 8 years of age. It cannot be done after 8. Okay, so that's why it's the dangerous thing. And remember, amblyopia is well known for its no improvement of visual acuity after correcting disorder. So that is the clue. Remember, if you have a patient who's 6/18 and you think it's amblyopia, so what will you do? You'll give him glasses, but it will not improve. Why is not improving? Despite the fact there is refractive error, is that he has amblyopia. If he improves with correction, he has refractive error. Okay, I'll discuss it a little bit more. And one important phenomenon is crowding phenomena. Crowding phenomena means that a child or the amblyopic patient can only read the target in a single, if presented single, you know, like suppose we have this POTH, okay, suppose we have this chart here. If I present the chart to him, he will not be able to read it. But suppose I erase the others and just make him read H, I erase the other 3, or make him read T and erase the other 3, then he will be able to read this chart. So this ability to read the chart as a single letter but not crowded letters is called as crowding phenomena. This is a very important characteristic of amblyopia. Okay, this is important. And the treatment of amblyopia is to close one eye, the good eye. Remember, so you can see it here. The eye has been closed. The good eye has been closed for at least 6 to 8 hours a day. Okay, so what you do? Suppose the right eye is amblyopia, left is good. Close the good eye for 6 to 8 hours a day. Every day could be 6 months, could be 1 year, for 6 to 8 hours, and this forces the bad eye to develop fixation. Okay, it works very well. It works very well. But remember, it has to be done by 8 years of age. Otherwise, it doesn't work. It doesn't work after 8 years of age so well. And suppose the child is resistant to wearing this patch, you know, because they don't like wearing patches. Remember, you've closed the good eye, and the bad eye, he has only finger counting, hand movement, or vision like that. So he can't function. So he'll tear off the patch. Not. In that case, we can do another treatment which is called penalization, which means to punish. We put a drug, atropine, in the weekend. Weekend means only 2 days out of 7. We put atropine in the good eye again. Again, it will cause blurring of vision. You'll have to force the bad eyes to see. Okay, so remember, penalization means to punish the good eye. Remember, we punish the good eye by making it blur and allowing the bad eye to see. Okay, so remember, moral of the story: don't be too good. Okay, if we are too good, we punish you. Okay, so remember, this they can ask as a question: what is the drug of choice in penalization? The atropine. Or they might ask, what is the drug of choice in amblyopia? Is again atropine. Again, so remember, so typically, see how we diagnose amblyopia. Let me give you case history. Any of you sitting here nearby, okay, suppose any of you, suppose sitting here, and you have a vision of, let's say, 6/60. Okay? Now, so obviously it's abnormal. No? First definition met is less than visual acuity is 2 lines or more, 6/60. Now, the second is that there is no attribute to any structural defect. That means when I see you, okay, so like anybody, like I've got here Harshita here, Harshita, let me take an example, don't mind. Okay, so Harshita's vision is 6/60, and when I take a look at her and I see that there is no problem, the vision, she does not have cataracts, she does not have refractive error, she does not have glaucoma, she does not have anything. Eye is perfect and the vision is not improved. It's 6 weeks. Now this is amblyopia. Okay, so this is what it is. So not attributable to any structure. This is amblyopia. Okay, this is amblyopia. But then what is the cause? Now for the cause, squint, refractive error, okay, we have to delve into Harshita's childhood. Okay, so what happened? Did she have a squint in the childhood? Did she have cataracts? She had refractive error. Then we delve into that. Okay. So this, and remember, she had amblyopia. If she had amblyopia, it has before it. After that, you cannot have amblyopia. And remember, so when we give her anything, glasses, squint correction, glaucoma correction, cataract, nothing happens. So amblyopia cannot be worked out after 8 years of age. So this is what is. So remember, it is actually very commonly seen. And in my classroom, usually when we have classes of around 250 and beyond, usually one of the students is usually amblyopic. It's so common. Okay, so this is amblyopia. Treatment would be, remember, occlusion, as I showed you, closing the good eye, preferable, or if not, the patient resistant to it, then we give them the penalizations. We blur the vision of the good eye, forcing the bad eye to see. This is called. This is what we've done, and we will now a quick revision of uveitis, and then we'll have the lunch break because many of the I can feel the tension we're about to collapse now. So a quick revision of uveitis, and then we'll take a short break. Okay. Uveitis. Let's talk about that. And what is that? Inflammation of the uvea. You know the inflammation of the uvea is iris, ciliary body, or choroid. Okay. So you have the second layer of the eye, the iris, ciliary body, or choroid. Any of them get inflamed, so it's called iritis or cyclitis or choroiditis, and it can be everything. So we'll do panuveitis. We divide into 3 parts: anterior, intermediate, posterior, and pan. So anteuveitis means iritis or iridocyclitis. Intermediate means pars planatis with vitritis, and posterior is choroiditis. And if the entire uvea gets inflamed, we call it panuveitis. Very serious. Of this, the most common is anterior uveitis, remember, with 70%. So that's why we focus mostly on anterior uveitis. Second commonest is posterior uveitis. Luckily, pan and intermediate uveitis are not very common. So as I mentioned, most common uveitis is 70% idiopathic. Remember, the most common cause is idiopathic, which means you do not know the cause. Okay? But however, the MCQs are placed on the second commonest cause, which is what? These are certain systemic disorders related to the spine and the joints. Okay, so these are disorders linked to the spinal disorders of spine and joints. We call them as HLA-B27 spondyloarthropathies. Okay, of which there are 4 of them. So of which the most common is ankylosing spondylitis, which are seen in tall, thin, young males. So typically, some of you may have tall, thin young males who have low backaches. You may be suffering from ankylosing spondylitis. This is a very common disorder. This is the second commonest cause of anteuveitis after idiopathy. Okay? So the MCQ asked is typically like this: a young male with low backaches and red painful eyes is a diagnosis of what? You will say ankylosing spondylitis. Young male with low backaches and red painful eyes is uveitis. So this is, they are linked to the HLA-B27 spondyloarthropathies. The second is inflammatory bowel disorders, IBD, which there are 2 varieties, Crohn's and ulcerative colitis. Any of them can cause uveitis. So typically you get the question, a patient presents to us with red painful eyes and bloody stools. The diagnosis, ulcerative colitis. This combination of red painful eyes, which is anteuveitis, and bloody stools is ulcerative colitis. This causes uveitis. Okay. Psoriatic arthritis. So we have psoriasis, some skin disorder along with arthritis, and again red painful eyes. And reactive arthritis is a disorder of the joints, where you all remember the famous CUR, is not the famous CUR, CUR. Remember, conjunctivitis, urethritis, arthritis. Classic triad of conjunctivitis, urethritis, and arthritis. Remember the famous mnemonic: can't see, conjunctivitis; can't pee, urethritis; and can't climb a tree, arthritis. So can't see, can't pee, can't climb a tree. Okay, so CUR. So this is, they may also lead to uveitis. So these 4 are particularly seen. Typically, these are young males who develop urethritis, which is not very common. Remember, they usually do not cause, young males do not have urethritis. Females have them, but of the short length of urethra. But males do not usually have urethritis. But if they do, then they may develop conjunctivitis, and along with arthritis leading to conjunctivitis. So this is linked to uveitis, I beg your pardon. So these are the four things. So the next thing is the JRA, also called as JIA, juvenile rheumatoid arthritis. Nowadays, latest name change being juvenile idiopathic arthritis. Okay? So this is JRA or JIA. And typically what we have here, remember there are two important MCQs. They are children with young girls who often have joint pains and they develop uveitis. So this is the two MCQs. First, it is the most common cause of anti-uveitis in children, can you remember. Adults is idiopathy, followed by ankylosing spondylitis. In children, it is JRA or JIA. And second, in JRA, you cannot put an intraocular lens, IOL. Okay, why is that? Because remember, why would we like to put an IOL? Because JRA causes uveitis. Uveitis causes a cataract, which is a complicated cataract, is it not? Which is a complicated cataract. So they would require intraocular lens, but in intraocular lens, we cannot place an IOL because it's an inflamed eye. It's an inflamed eye, and intraocular lens is a plastic foreign body. You would not like to place a plastic foreign body in an already inflamed eye. So that is why intraocular lens is contraindicated in JRA causing cataracts. Okay, so it's a rare contraindication of a IOL, which IOLs we require normally, but in this case, we don't have to put it. Two important MCQs here, JRA. Let's look at the important findings of anti-uveitis. Look at the famous circumciliary congestion, the reddish pinkish. You can see the circumciliary, which is around the ciliary body, also called circumcorneal congestion, which is the telltale sign. Second, marker of activity, cells. Remember, cells, the neutrophils floating up and down, they are the marker of activity, which means we have to start treatments with steroids, and when we see no cells, we stop treatment with steroids. Okay, so that is a marker of activity. That is, the cells is a very important sign. But flare is the earliest sign of anti-uveitis. Remember MCQ, flare is the earliest sign of anti-uveitis, which is a beam of light which is visible to us on passing through the aqueous humor because there is too much protein in the aqueous and splits the light visible to us as a flare of light or a beam of light. Most early sign. Then we have keratic precipitates, which are neutrophils attaching to the cornea. When they're moving up and down, remember the same neutrophils, when they're moving up and down, we call them cells. When they get stuck to the cornea, we call them KPs, keratic precipitates. And typically they attach onto a triangle, which is a inferior triangle on the cornea. This is called the Arles triangle, which is a triangular area in the inferior half of the cornea. Inferior, why? Because of gravitational currents, they will stick to the inferior triangle. This is the Arles triangle, where the site of the sticking of the KPs. Of the KPs, we have a specialized type of a KP called as a mutton fat KP, remember, which are large and oily and greasy. They look like mutton fat, and they are a sign of granulomatous uveitis, which means the uveitis is caused by tuberculosis or leprosy or syphilis or sarcoidosis or Lyme disease. Now it becomes serious. Also, there are two other indications of granulomatous uveitis, which are Koppe's nodules and Busacker's nodules. And remember, Koppe's are, remember the P is on the pupillary margin. These are nodules on the pupillary margin like this. Okay, this is the pupil, suppose. And Busacker's, S for Busacker, is on the surface of the eye. Busacker's on the surface of the eye. P for, so Koppe's for pupillary margin, Busacker's on the surface of the iris. They are again signs of granulomatous. All these three can be seen in granulomatous uveitis. All these three in granulomatous uveitis, but the most common are Koppe's nodules. The most common are Koppe's nodules. Then we go to the very famous, the festooned pupil, irregular pupil, which is a sign of posterior. You can all see the lovely festoon here, no? The festooned pupil, you can see sign of posterior synechia, which we can see here. So this is a sign of posterior synechia, which is seen in anti-uveitis. Whenever you see posterior synechia like this, it means that the patient has had anti-uveitis. It may be past or present, and this is because of posterior synechia. So this is very important, irregular pupil. And then we have intermediate uveitis. We run anti-uveitis. Intermediate uveitis is inflammation of the pars plana along with the vitreous, and the most common cause idiopathic. Again, we do not know the cause. When it is caused idiopathic, remember we call it pars planitis, inflammation of the pars plana. So when it's idiopathic, when a cause cannot be found, we call it pars planitis. Okay. But the second commonest cause would be sarcoidosis. Remember sarcoidosis, I told you, if you haven't listened to my notes or to my class, kindly remember sarcoidosis can cause all types of uveitis: anterior, intermediate, posterior, and pan. It's a granulomatous type of uveitis. It can cause all anterior, intermediate, posterior, and pan, but the most common type is anteuveitis. So sarcoidosis is a very popular question which often will come to you. They will cause anterior as well as intermediate, posterior, and pan. Then you have, and so there is a problem of the, I guess, this sound not clear. I'm getting a, please look at it, my friends. We'll just handle it. No, we'll just getting this clear. Maybe the mic has shifted off or something. Right. So in uveitis, remember, astigmatic uveitis presentation is floaters. They have these floaters, black spots floating in front of the eye, which many of us have also, normally also. That is the most common presentation of intermediate uveitis. But if you have loss of vision, remember, normally intermediate does not have loss of vision. But if you have loss of vision, the most common cause is cystoid macular edema, swelling of the macula. Okay, remember, CME when it occurs after cataract surgery, called Irwin-Gass syndrome, but it may occur in any other condition. When it occurs in uveitis, this causes loss of vision. Okay? So, very good, Harshita. CME is quite correct. The answer is absolutely right. And the only finding sometimes you find in uveitis is snowballs and snowbanks. Now, this is a very important MCQ, which I expect anytime. Remember, snowballs and snowbanks are seen in cystoid macular, I beg pardon, in intermediate uveitis. I'm so sorry, not cystoid macular, no? Intermediate uveitis. So, this is intermediate uveitis. And thank you. We've got the clear sound now. Thank you very much. And what about posterior uveitis? Remember, posterior uveitis you have is choroiditis. And choroiditis, the most common cause are toxoplasmos. Please remember, the most common is cats. So those of you who have cats in the house, please watch out. You get toxoplasm from cats. Second common cause is tuberculosis. Remember, tuberculosis has this important MCQ. Remember, tuberculosis can attack the eye in multiple ways. I can think of at least 10 disorders which tuberculosis causes, okay, in the eye, ocular disorders. It can be posterior uveitis, it can be Ehlers disease, it can be telloconjunctivitis. There are so many others. But MCQ, remember, the commonest ocular manifestation of tuberculosis is posterior uveitis. Very important MCQ for NEET PG as well as INSET. And how do you diagnose it? By the famous headlight in fog appearance, is it not? This is the headlight in fog appearance which we see. Okay, so where the headlight is the appearance, which headlight gives you the chororetinitis, and the fog is the vitritis because you can't see it clearly. So it's called headlight in fog, as you see here. Look at that. This is the fog, which is very, very hazy. This is the, so clear we getting, but volume is okay. Now it's they have fixed it hopefully. So please give me a thumbs up. You have fixed it. So fog appearance, okay, fog is the vitritis, but the headlight, the chororetinitis. Okay, so this is the headlight and fog appearance, posterior uveitis. This is what we're getting. And so what about the treatment? The treatment, remember, of anti-uveitis. Let's talk about quickly about the treatment also. The treatment of uveitis, of all kinds of uveitis, is because they are inflammation, so we have to give steroids, is it not? So we give steroids, but in anterior uveitis, you have to give topical steroids, okay? Topical steroids, remember, will cause glaucoma. And remember, the most common side effect of topical steroids is glaucoma. Of systemic steroids is cataract, and topical steroids is glaucoma. So you give topical steroids, drug of choice is topical steroids. But the second, this we talk about anterior uveitis, but the second drug, remember, are the famous cycloplegics, not with the cycloplegics, which are atropine, homatropine, cyclopentyl, topicamide. Okay, so kind of remember, if they ask drug of choice of anti-uveitis, you will say topical steroids. But if they ask you drug of choice of acute anterior uveitis, acute is sudden and painful, then the drug becomes cycloplegic, which could be atropine, homatropine, topicamide, and cyclopentyl. So whenever we use acute, we get a cycloplegic. When we give drug of choice, we get steroids. Okay, so this is about anti-uveitis. What about intermediate uveitis? Is again steroid, but injectable, because topical steroids will not penetrate down into the ciliary body. And if it's posterior uveitis, then you will get systemic steroids, because only systemic steroids can penetrate to the choroid. Yeah, no cycloplegic is required in intermediate uveitis and posterior uveitis. So steroids in all forms for uveitis. Yes, so we've got uveitis. Then what about the next thing, which is going to be with treatment of steroids? This is what I mentioned. Remember, antivirals, topical steroids, most commonly glaucoma. So this is what I was mentioning. Cycloplegics, atropine, homotropine to reduce the pain, break the synechiae, intermediate uveitis, injectable steroids, triamcinolone. Yes, I've got the answer. Intravitreal also. Yes, we've got, that's right. That's correct. We're going to intravitreal, but intravitreal has more chance of infection. So we do not prefer so much for intermediate uveitis. We prefer subconjunctival or subcutaneous. If it doesn't, then of course we can do intravitreal also. And posterior uveitis, as I said, systemic steroids for posterior uvea and antimicrobials, because it's toxoplasmosis, tuberculosis, toxocarisis, etc. So whatever the injection, whatever the microbial organism that is causing the infection, we have to give the antibiotic, an antimicrobial. What about panuveitis? Panuveitis, the most famous, is sympathetic ophthalmitis, okay, where it is uveitis following trauma to one eye, is not? So very famous. Remember the definition: bilateral granulomatous uveitis following trauma to one eye. Okay, and remember, both you have trauma to one eye. This is the exciting eye, but the other eye gets also inflamed. So both eyes gets inflamed. They are granulomatous uveitis. So you will see mutton fat KPs following trauma to one eye. Okay, the injured eye is called the exciting eye. The other is called the sympathizing eye. And most commonly, the organ affected is the ciliary body, is not the ciliary body. Can you remember, ciliary body MCQ has the highest chance of developing sympathetic ophthalmitis after injury. The injury can be penetrating, where there is entry but no exit, or perforating, which is through and through, is it not? So in injury which does not exit but enters is penetrating, which enters as well as exits is perforating. Okay, both of them can cause sympathetic ophthalmitis, and usually they're seen within 14 days, okay, to 3 months. Remember, once the injury occurs, within 3 months is the highest incidence. Any time between 14 days, 2 weeks to 3 months is the highest incidence of the second eye developing sympathetic ophthalmitis. So we have to be particularly careful in the first 3 months. It may occur after that also, but the incidence is highest in the first 3 months of injury. And here what we do, the diagnostic famous findings are Dillon-Fuchs nodules. Okay? So remember, these are nodules on the choroid. You will see nodules in the choroid called DFN, Dillon-Fuchs. Remember, I have sometimes mentioned that sometimes it's easier to memorize with just the initials. Okay, so Sashwat Ray may not be easy to memorize, but SR is easy. Similarly, Dillon-Fuchs nodules may not be so easy, but DFN is easy to memorize. Okay, and granulomatous uveitis, so you'll have mutton fat KPs again. Remember, retinal flare is the MCQ. It is the earliest sign of sympathetic ophthalmitis. Very famous question. Retrolentil flare, it is flare behind the lens. It's the vitreous flare. It's not an aqueous flare, it's a vitreous flare. And can you remember, it is the earliest sign of sympathetic ophthalmitis and will occur in the other eye, not the injured eye, but the sympathizing eye. Okay, so these are the questions, and the best treatment is if the eye is lost, then you take out the rock. Injured eye, it was PL negative, you take out the injured, it's called enucleation, which has to be performed within 14 days. But you see, the logic being that if you take out the injured eye, which has no vision, so you take out the antigens, so they cannot form the antibodies which can damage the other eye. This is a very good treatment, but can you remember this MCQ? We like to ask you 14 days of injury. This is the most dangerous. Remember, sympathetic ophthalmitis is the most dangerous condition in entire ophthalmology. Why? Because you can damage both eyes, you can lose both eyes. There are other dangerous conditions also where you can lose one eye, panophthalmitis, endophthalmitis. You can have a siderosis bulbi, you can have one damage, one eye gone. But this is the one condition where you lose both eyes. It's the single most dangerous condition in ophthalmology. And then the next topic is HIV, the ocular manifestation. Quickly, ocular manifestation of HIV. So let's look at the first MCQ, which you have to remember, these beautiful white spots. The most common ocular finding of HIV are soft exudates, also called as cotton wool spot. Okay? We call them soft exudates also, though that is not a very good term. They're not really soft or exudates, but we call it so. Also called as microangiopathy, which means damage. Microangiopathy is small blood vessels. Not. So what happens in HIV is the small blood vessels of the retina get damaged. Microangiopathies. And as they get damaged, so they produce the soft exudates or the cotton wool spots. This is the most common ocular manifestation. But remember, the vice versa is not true. That means the commonest presentation of HIV is soft exudates. But the commonest cause of soft exudates is not HIV. It is diabetic retinopathy or hypertension. So remember, when you have a condition like this, where you see the cotton spots, your first differential is diabetic retinopathy and hypertensive retinopathy, any of these two. And once you've ruled the diabetic and the hypertensive retinopathy, then you think of HIV. Okay, very well. And the next thing is, what is the most common ocular infection? Is CMV retina. Look at this reddish white thing, the very famous. Yes, somebody already answered this. Pratyusha has already answered this. Is pizza pie appearance. Look at that. Called the pizza pie appearance. It looks like pizza. Well, it doesn't really look like pizza, which I'm planning to have tonight. But because of the red and the white color, it's called the pizza pie appearance. Also called the scrambled eggs and ketchup appearance. It looks nothing like that. Let me tell you. So CMV, remember, is the most common ocular infection. Okay, and it causes also, remember, MCQ number 2. It is the commonest cause of blindness in HIV. Number 2, and number 3, drug of choice is valganciclovir. You have to give oral valganciclovir. Not ganciclovir. Ganciclovir is no longer the drug of choice. It's IV. It's oral valganciclovir. So 3 MCQs of CMV called as valganciclovir, which you may have done in pharmacology. Then the most common systemic infection in HIV to attack is tuberculosis. Okay, remember, if you ask ocular infection, you say CMV retina. If it's systemic infection, tuberculosis. Also, the commonest cause of death in HIV is tuberculosis. You know that, isn't it? Most common ocular malignancy is Kaposi's sarcoma, a very rare infection. So whenever you see Kaposi's sarcoma, you have to remember the underlying HIV. Okay, and remember, this is the most common in our tumor, the most common infection, and the most common finding is cortical spots. And most common ocular side effect of heart therapy is immune recovery. Can you remember, in HIV, we use the drug of choice of HIV is heart therapy. It's not highly active antiretroviral therapy. And when you have severe retinitis, we give them valganciclovir. So both the drugs run concurrently. CMV is valganciclovir and HIV is heart. But when you give heart, you have this inflammation of the eye, which causes immune recovery uveitis, IRU. Again, a NEET PG question. Immune recovery uveitis is the most common ocular side effect of heart therapy, MCQ. Can you remember? Okay, so what happens is, as you give heart therapy, the HIV starts dying out and the immune system recovers. As the system recovers, so it mounts an attack on the eye, so it may cause uveitis. So paradoxically, you will see, as the patient starts improving, his eye appears to seem inflamed. It appears to get worse. It gets worse because it's getting inflamed. You get anti-uveitis, you get intermediate uveitis, you get CME, you get vitritis. You feel that is actually worsening. It is not. It is because the HIV status is improving. It's mounting an attack on the eye. It's called immune recovery uveitis. This is the most common side effect of heart therapy. Again, very popular and set question. Okay, so these are multiple questions of HIV. Ocular HIV, and with that, ladies and gentlemen, I think we should really have a lunch break before all of us collapse. So right now, by my watch, it is about 3:20. So we'll have half an hour. That should be enough. I should be back here in 3:50. So get fresh, have a cup of coffee or tea or cigarette or cocaine, whatever it is. Get some food into you and back to the YouTube with the hair in a braid. Thank you very much. We meet in half an hour. All right, gentlemen, back to work again. I hope I'm loud and clear, audible. Those of you who are still there, tell me if I'm visible to you and I'm audible to you. So we now go to next topic, glaucoma. Okay? Big one. Glaucoma has a lot of MCQs possible. You need to understand that, because unless you understand, we just try to memorize it, it's not going to work. It's not. So let's start with glaucoma. First of all, what is glaucoma? It has three things. Raised intraocular pressure. How much? It has to be more than 21 millimeters of mercury. No? Remember, normal pressure we just talked about when we did the numbers is 10 to 21. Average is 15 to 16. But anybody more than 21 millimeters of mercury is supposed to have raised intraocular pressure, which would damage the optic nerve. The pressure rises and causes the optic disc damage, which is the optic nerve, and the visual field collapses like that. So these are the three things of glaucoma. But remember, we need only two. We don't have to have all three. We don't have all three. Any two. For instance, look at this. Suppose you have a condition where the pressure is 60 millimeters, very high. Okay, but the visual field is normal and the disc is normal. Now this is not glaucoma. Why? Because 2 out of 3 are normal. We want 2 out of 3 to be abnormal. The only thing abnormal is 60. There is only 1. So this is not glaucoma. The pressure is very high, but other two are normal. So this is called as ocular hypertension. Okay, this is not glaucoma. It may or may convert to glaucoma later on. May or may not. But right now it is not glaucoma. It's not. It will only become glaucoma when the second one becomes positive. Okay. Similarly, you have pressure, say normal 15. Okay, very normal pressure. But there are visual field damage and the disc damage. Now this is glaucoma. Why? Because 2 out of 3 are damaged. What is that? The disc and the field. So any 2 out of 3. So this is glaucoma. We call this as normal tension glaucoma, NTG, normal tension glaucoma, because the pressure is normal. This is a very dangerous condition for us, particularly India, where we have a lot of normal tension glaucoma, and Japan. Okay, can you remember 2 out of 3 NE2 is glaucoma. And what is the damage? The damage that happens in glaucoma is the one, this particular cell. You remember the ganglion cells. Remember the third order neuron? First order photoreceptors, second order bipolar, third order is the ganglion cells. Retinal ganglion cells, RGC, you call them the RGCs, and that is the damage. The location of damage is to destroy the ganglion cells. Okay, that is an important MCQ. Then we divide them into children and adults. So in childhood glaucoma, we have something called as PCG, primary congenital glaucoma. Primary congenital glaucoma, also called as ophthalmos. The word ophthalmos is like a bullseye. Okay, it means bullseye because of the raised intraocular pressure. The eyeball is so large, it looks like a bullseye or a cow's eye. So it's a very large. You cannot make a mistake with this. Okay. So here, remember the classic triad is of these three things. What are these things? You have photophobia, cannot tolerate light, blepharospasm, lens tightly shut, and lacrimation. Okay, remember we talked about photophobia, blepharospasm being a differentiating point when we're talking about congenital NLDO, no, nasal lacrimal duct obstruction. So this is important. So please remember, this is a very small child. The age group is from 0 to 3 years of age. Ophthalmos is within 3 years of age. Okay, who's 3 years of age, and after that, why only 3 years old? Because up till that, the eyeball is elastic and can stretch in response to raised intraocular pressure. So only up till 3. After 3, the eyeball cannot stretch. So ophthalmos can be only called up till 3 years of age. Okay. So this is how we diagnose that. And what are the other symptoms? The cause is Barker's membrane. There is a membrane which blocks the angle. Okay. So if this is the angle, okay, so there is a membrane which blocks the angle like this. Okay, and blocks the angle, so the aqueous humor cannot get out. Aqueous humor cannot get out, raise the intraocular pressure, damages the optic nerve, causes glaucoma, enlarges the eyeball. So this is how they present to us. And this enlarged eyeball is very easily diagnosed. And because of the enlargement, it causes myopia. Remember, all of you, those who remember refractive, this thing that we're going to discuss anyway, that as the eyeball enlarges, the rays come in front of the retina, they become myopic. So all of you who have large eyes have myopia. So this child develops myopia simply because the eyeball is large, and this colloidema because they cannot pump out the aqueous humor. Okay, because of raised intraocular pressure, the aqueous humor rushes into the cornea, and the endothelial pump cannot pump it out because the pressure is too high. That is why they have colloidema, which causes the haziness of the eyes and cause the blepharospasm and the photophobia. And because the stretching of the eyes, so there is this tearing of the descemet's membrane of the cornea, the descemet's membrane of the cornea, and there are famous railway tracks. Look at that, the parallel railway tracks here, the famous HAB striae. I told you, remember, ophthalmology has two striae. Striae means folds. One is HAB striae, which you see in congenital glaucoma. Second is Vogue striae, which you see in keratoconus when we come to that. So this is how the presenting finding are. This is how we diagnose it, and the treatment is by doing goniotomy or trabeculotomy. To make a hole in the angle, which is called goniotomy, making a hole, or trabeculotomy. Okay, any of these two. Goniotomy is done when the cornea is clear, which rarely is. Most of the time we do trabeculotomy because we don't have a clear cornea, making a hole in the trabecular meshwork. So this is how congenital glaucoma works. What about the next type of glaucoma, which is open angle glaucoma? Now remember, so this is adult glaucoma. By definition, anybody above 40 years of age would develop raised intraocular glaucoma would cause adult glaucoma. This is definition. Anybody above 40, 45. No fixed age like that. So this is an angle glaucoma where the angle is open, so the pressure rises. Why would we do that? Because the trabecular meshwork gets blocked. In the angle, there lies the trabecular meshwork, and they get closed, as we'll talk about. Who are the risk factors? Remember, families is important. People whose parents, grandparents have glaucoma can have open angle. Thin central cornea, people with thin corneas. Okay, remember, anybody, I told you standard is 540. So people with thinner corneas, which is less than 500 microns, then their risk of developing open angle glaucoma. I myself have thin cornea. Okay, so I am at danger of developing open angle glaucoma, which I hope I'm spared. Thin central corneal thickness, CCT, central corneal thickness. Remember, we talked about the central thing. We are not interested in the peripheral corneal thickness. Colored race means these are the black people populations, the blacks, the Africans, so Afro-Americans, the Caribbeans, the African population. These are the people who have the highest amount of open angle glaucoma. Okay? Glaucoma is very ethnic and depends on race to race. And myopia. People who are myopic have more open angle glaucoma. So risk factors, certain risk factors. Okay? And then, so I have this question from Pratyusha, who says, goniotomy, orthogonal, yes, goniotomy done when the cornea is clear, that's correct. And trabeculotomy is done because the cornea is not clear, so we cannot see the angle, we cannot do goniotomy, we have to do trabeculotomy. So then I just mentioned why the glaucoma occurs if the angle is open, because in the angle, this is trabecular meshwork, which are full of holes like this, and they get blocked, and as they get blocked, so this is called as raised intraocular pressure. So that's why the pressure rises. And rises slowly, it damages the optic nerve and the visual field collapses slowly. Okay. Remember, there are no symptoms of open angle glaucoma because a very slow rise in pressure takes about 20 to 30 years before the optic nerve damage is detected. And the patient does not know because central vision remains clear, his peripheral vision collapses, visual field, but we have no way of finding out our peripheral field because we are only yet to know about our central vision. Very well. What about the optic signs? What is the signs that tell glaucoma? There are multiple optics. You have to know at least 3 or 4. Remember, increased cup disc ratio. You can see the picture here. The normal cup disc ratio, you all know, is from 0.3 to 0.6. Okay. This it varies. It varies from person to person. So if you look at your own discs, like where Pratyusha here may have a 0.3 cup disc ratio, and before that we have Akanksha, we have around may have a 0.4, and before that we again before that was somebody else whose name is not coming up here, Redwood maybe, yeah, and we have a 0.5. Okay, but as soon as you reach 0.6, this is normal, and beyond that is glaucoma. So 0.3, 0.4, 0.5, 0.6 is considered normal range of normality. But look at this, the picture here, 0.7, and this is definitely not glaucoma, because the raised intraocular pressure, what is done, it destroyed the NRR and the cup size is enlarged to fill up that area. One of the most important size, increased cup disc ratio, 0.7 or more. 0.7 is touching glaucoma, suspicious for glaucoma. Disc pallor, the optic disc becomes pale. If you remember, the normal color of the optic disc is a reddish orange, reddish pinkish. It becomes pale, sign of glaucoma. Splinter hemorrhages, you have hemorrhages on the rim, something like this. You will be able to see hemorrhages on the rim like this, called splinter hemorrhages, and if you see them, this is a very powerful sign of glaucoma. All these are multiple signs of glaucoma. You can have any one of them, all of them, and there are many other signs which you don't have to go right now into. In the visual field, remember, some visual field are very typical. Paracentral scotoma means a scotoma. Scotoma is defined as a localized loss of vision surrounded by normal vision, like a blind spot. So if I look straight at you, I have somewhere area is a small area at which spot I can't see anything. That's called blind spot. you can't see the blind spot. You cannot see the scotomas because they are negative scotomas. But when very small, something very small is placed over the blind spot, you will find you're not able to see it. Okay, but you per se cannot see the blind spot. It's only visible to us indirectly when something very small, smaller than the size of the blind spot, is invisible when it rests on the blind spot. Okay, so paracentral scotoma is a scotoma close to the center. Can you remember MCQ? This is the earliest field defect of glaucoma. MCQ, earliest field of glaucoma is paracentral. You have Bayram scotoma, which is an extension of the blind spot in the shape of an arc. That's called a Bayer. You can see that here. Look at the Bayram scotoma. An extension of the blind spot in the shape of an arc in the center 30 degrees is the definition of Bayram's area. So any area of that is scotomatous here, Bayram's scotoma, very specific for glaucoma. Okay, and remember, Bayram's is very specific for glaucoma. A nasal step, a stepwise field defect, step-like field on the nasal side, again very specific. And remember, if any of these two are very specific for glaucoma. Okay, arcuate scotoma, which is shaped like an arc like this, in the field could be a sign of glaucoma. See the difference between Bayram's and arcuate. They are both arc-shaped, but the Bayram's is connected to the blind spot. Arcuate can be anywhere. Okay, so multiple field defect. And remember, paracentral is the earliest. Bayram's and nasal steps are very typical of glaucoma. So these are some questions that are possible of glaucoma. You can have any one of them, you can have all of them. But you will find them only on perimetry visual field testing. You cannot find them in real day-to-day life. Okay? And the only very famous MCQ is the frequent range of presbyopic glass. So remember that only thing that they'll complain of that is that their presbyopia seems to race. You know the older people, 45, 50, so they wear reading glasses. So normally reading glasses change every 3 to 4 years. This will change every 6 months or 1 year. So frequent change of presbyopic glasses is the only symptom of open angle glaucoma. Please do not forget this. This is open angle. What about, remember, open angle characteristic is that it takes years to develop, 3, 4 years, not like that, 20, 30 years it will take. Then angle closure glaucoma. What about angle? Now here the angle is closed, okay? There angle was open, trabecular mesh was closed, here angle is closed. And it's closed, why is it closed? Because of the one mechanism called as pupillary block. That is the most common. Let's look at angle closure glaucoma risk factors. Let's look at that. And the middle-aged female, that means 40, 45-year-old lady. Middle age actually starts at 50. So anybody, why females? Because they already have a small eye, so shallow races, so it closes easier, isn't it? So females have more angle closure. In open angle, there is no genetic predisposition like that. In angle closure, the female sex has more glaucoma angle closure because of the small size of the eyeball. Okay, you know or should know that females have an eyeball which is approximately 10% smaller than the male eyeball. Okay, and always remember that the female eyeball is smaller than the male. Okay, and that's why they have more angle closure glaucoma. Hypermetropes, why hypermetropes? Because again the eyeball is smaller. That is why the rays are focusing behind the retina, which is definition of hypermetropia. Remember what is hypermetropia? Definition of hypermetropia is a condition when the rays of light are focusing behind the retina. By what? Why would they focus behind the retina? Well, they would if the eyeball is smaller, if the retina comes closer. So they have a small eye, so again the pressure rises. And Asians, why Asians? Because as Asians, all of us, Indians, Pakis, Bangladeshis, Nepalese, Filipinos, Chinese, Mongols, Japs, all of us have a slightly smaller eye. So we have more angle closure glaucoma. So now, compared to Western eyes, which are bigger, we have smaller eyes. Asians have more glaucoma, particularly East Asians like China, Singapore, Korea, they have very small eyes. Very well. Then mentions pupillary block. The pupil gets blocked when the pupil dilates. Why would the pupil get blocked? Because the pupil gets half dilated. Remember, the most important risk factor for the pupillary block is when the pupil dilates halfway. Mid dilatation we call it, not full dilatation, mid dilatation. It gets blocked. So anytime the pupil dilates, as in darkness, as if drug induced, as any other emotion induced, it dilates halfway, it leads to pupillary block, and this leads to angle closure glaucoma. This may lead to angle closure glaucoma. So there are 4 stages of angle closure glaucoma. Remember, latent, subacute, acute, chronic, and absolute, of which we discuss only the acute mostly because it's the most dramatic and the most emergency. Okay, latent is subacute. These are subclinical, so patients don't come to us often because they have sometimes headaches and eye aches. They get tired, they get some colored halos, but they're self-resolving. They automatically resolve. So they don't come to us. When they come to us means acute stage, when it's too late and they don't resolve self. They do not get corrected automatically, so they have to come. the acute angle closure and chronic and absolute glaucoma. Absolute is when the patient becomes blind. So 5 stages of angle closure, of which we mostly discuss acute and acute angle closure, beg your pardon, sorry, comes to us with the sudden severe pain, redness, blurring, colored halos, severe symptoms, severe symptoms, very painful. These patients suffer terribly. A sudden pain attack, the head in this area, radiating down to the head, and the eyes red, and the vomiting away with the pain, and the vision is blurred, and again they see the telltale colored halos, which they saw in cataracts also. But remember, this is differentiating the cataract colored halos, the symptom, the mechanism is different, and angle closure glaucoma, the mechanism is different. That's why they have to be differentiated. And the classic diagnostic sign is a vertically oval pupil, something like this. The pupil will not be circular like this. Be vertically oval, mid-dilate, not reacting light. It's dilated and fixed. Flash light, not constricting. Take it away. It's not dilating. Not reacting to light is the sign of acute angle closure glaucoma, which gives the giveaway. And the main problem is to differentiate from open angle glaucoma. Remember, chronic angle closure glaucoma is difficult because chronic angle closure glaucoma, the 4th stage, which comes after acute. Okay, this one. This is not painful. Okay, so this is also painless, and it looks very similar to open angle. The only differentiating point, kindly remember, MCQ, is to do gonioscopy. Gonioscopy will tell you that the angle is closed in chronic angle closure, but open angle it will be open. So this is the gonioscopy which will tell us, differentiate between chronic open angle. Acute, there is no problem because it's sudden painful redness, watering, loss of vision. It's not. And this is the colored halo which we were talking about. This is the colored halo which you see in both cataract glaucoma, and we differentiate with the Fincham's test because the mechanism of acute angle closure glaucoma, colored halos, is corneal edema, and cataracts is different refractive index of different lens parts. And so we use a stenopic slit, which is a plastic disc with a slit on the, we have a stenopic slit here, something like this, which I think the picture is not there. The stenopic slit is a plastic slit, and you place it on the eye in front of the patient. Ask patient to look at the colored halo while move the slit in front. If the colored halo breaks up, it splits up into various parts like this, is due to cataract. If it doesn't break up, it's due to glaucoma. Okay? So this is a Fincham's test, very important in MCQ. We don't use this practically because we don't need to, but very important MCQ. The angle closure glaucoma, can you remember, very painful attack, sudden attack, and we need to resolve it as fast as possible. Okay? And so what do we do in this case? We have to immediately lower the intraocular pressure first of all with the fastest anti-glaucoma drug. What is that? Mannitol, is it not? It's given IV. So give injectable mannitol, it lowers the pressure, and then we make a hole in it. You make a hole in it, which is called as LI, laser iridotomy, so that we create a small hole in the angle, and so therefore the aqueous can get out. So LI, laser iridotomy. Remember, LI is done by our old friend, the laser Nd:YAG laser, okay, which was done for capsulotomy. We also use it for laser iridotomy. So if remember the MCQ, if there's immediate management of acute angle closure glaucoma, you have to say mannitol because it lowers the pressure. That's the first thing. But if there's the definitive management or the final management of angle closure glaucoma, the answer becomes laser iridotomy, LI, which is done with Nd:YAG laser. Remember, in this case, you need to treat both eyes because yes, it is true that it has one eye has attack, but it is a question of time. The second eye will also attack because they are the same eyes of the same patient, is not. They're two different eyes of the same patient, so they have the same depth, they have the same configuration. So if one eye is attacked, it is a question of time. It will attack within 6 months, 8 months, 1 year. The second eye will also attack, but it will come. When they come to us with one eye, we treat both eyes. Okay? So this is because we know that the second eye is only coming in a matter of time. That was angle closure glaucoma. The next thing is treatment of glaucoma, some anti-glaucoma drugs. Angle closure glaucoma, I just told you that you do mannitol and followed by LI. But open angle glaucoma is basically drugs. We use mostly drugs to do it because drugs are very effective and safe. We also have surgeries like trabeculectomy, and argon laser trabeculoplasty. But those are not so asked. We need to know the focus of the drugs which lower the pressure. So what is treatment glaucoma? Basically, the only treatment is to lower the pressure. You cannot get the optic disc changes back. The optic disc cannot be got back, and you cannot get the visual field back again. They're irreversible. So what you can only do is lower the intraocular pressure so that there is no further damage. Whatever the damage is done, we cannot get it back. We can only stop further damage. So how do you lower intraocular pressure? There are two ways. Either increase the outflow or decrease the production. Is it not? Either decrease production of aqueous will come down or increase the outflow. And so we have these 7 different classes of drugs which you must learn in pharmacology, which I'm not going to go into, but tell you the most salient questions. So there are only 2 drugs. It's easy to memorize that way. 2 groups of drugs which increase the outflow. What are these? These are 2 drugs. The rest of them all decrease the aqueous production of this 5 other classes. These 2 classes of drugs will increase outflow. One are called the pilocarpine, or which belongs to the agonist, which is the cholinergic agonist. Okay? So there are 2 drugs here, pilocarpine and carbachol. They increase the outflow through the trabecular meshwork. These are the pilocarpine. This is one of the class of drugs. We increase the outflow, which I mentioned 2 classes. The second, these are the prostaglandin analogs, like latanoprost, bimatoprost. But they increase outflow, remember, through a different pathway. It is the uveoscleral pathway. Can you remember? The 2 groups of drugs act differently. The prostaglandins act through the uveoscleral pathway, and the cholinergic agonists act through the trabecular meshwork pathway, right? So they are both effective. This is particularly effective, the prostaglandins. They're very effective. So that is why they are nowadays the drugs of choice of open angle glaucoma. Kindly remember, the prostaglandin analogs are the drugs of choice of open angle glaucoma because they're very safe. They do not have systemic side effects. Okay, so they are drugs of choice. They're also the drugs of choice of normal tension glaucoma. Remember, they are so powerful. Remember, the prostaglandin analogs are the most powerful anti-glaucoma drugs. They lower the pressure by almost 35%. And because they can lower the pressure by 35%, which is 1/3, so these are also the drugs of choice of normal tension glaucoma. And remember, open angle glaucoma is easy to manage. Normal tension glaucoma pressure is already normal. It's difficult to lower already normal pressure, okay? Because normal pressure is normal according to the eye. So how would you lower it? Okay? So latanoprost, bimatoprost, which are prostaglandin analogs, kindly remember, is drugs of choice. They are the drugs of choice of open angle. I've got a question here from Dr. Garima. Acute congestive versus angle closure. See, Dr. Garima and rest of you, they are the same. Angle closure glaucoma is also called as acute congestive glaucoma. Okay, I mean the acute stage. The acute. Remember, angle closure we talked about 5 stages. So this is latent, subacute, acute, chronic, absolute, isn't it? So the acute angle closure glaucoma is also called as acute congestive glaucoma because the eye gets congested. Similarly, open angle glaucoma, the older term was chronic simple glaucoma. So they used to call it, nowadays we call it open angle glaucoma, but the older textbooks used to call it CSG, which stands for chronic simple glaucoma. There's nothing simple about it, let me tell you. We used to call it. So acute congestive glaucoma for all of you is the same as the acute phase of acute angle closure glaucoma. Okay. So this is the drugs. So let's look at some of the important drug questions that we like to ask. Drug of choice I just mentioned. Prostaglandin analogs are the drug of choice of open angle glaucoma, also the drug of choice of normal tension glaucoma, as I mentioned that, because they are very powerful, they can lower the drug's pressure. What else? Out of all the groups of drugs, remember, the most powerful drug I just mentioned is the prostaglandin analogs, lowering the pressure by almost 35%. Of this particular drug, if they ask, again, an INESET question, one particular drug, if they ask, which is the lowers the pressure the best, the most, it is the bimatoprost. Okay? Bimatoprost is the most powerful IOP lowering drug so far that we have, okay? Which is of course a part of the prostaglandin analogs. What else in anti-glaucoma? Remember, we have a lot of anti-glaucoma drug MCQs because of drug interactions, which you really must study in pharma. Remember, children, the drug of choice, the topical CIs, carbonic anhydrase inhibitors, which are dorzolamide and brinzolamide. Okay? So why is that? Because they are the safest anti-glaucoma drugs. Okay? Remember, the safest anti-glaucoma drugs, these are dorzolamide and benzolamide. So these are the drugs of choice in children that we use. Children normally do not cause glaucoma, but sometimes they do. Then we use this. What else? Remember, any important MCQ in glaucoma will always ask this: which particular anti-glaucoma drug is the drug of choice in which particular anti-glaucoma drug is contraindicated in children? Okay, please remember, it's brimonidine. It causes respiratory apnea, so it may cause death sometimes. Okay, so please remember, brimonidine is contraindicated in children. Never use that. Then also remember, prostaglandin analogs are, as you can understand, would be contraindicated in pregnancy, is it not? Because what do the prostaglandin analogs do? They would increase the cervical incompetence. So the child may have premature delivery or they may abort. So can you remember which drugs, anti-glaucoma drugs, are contraindicated in pregnancy? are absolutely the prostanoid analogs because they might cause the cervical os to widen and cause a premature delivery. Okay, so therefore, if it's contraindicated, which drug would be indicated in pregnancy? And remember, there's not too much, but there's only one that is indicated. Drug of choice indicated is brimonidine. Remember, so kindly remember this: in pregnancy, brimonidine is indicated, and that too only the first trimester. Second, third trimester, nothing is prescribed. Brimonidine is a drug of choice in pregnancy, and brimonidine is also contraindicated in children. So one indication, one contraindication. Brimonidine seems to hog all the headlines, does it not? It does actually, as we will come across. In bronchial asthma, remember, beta blockers are contraindicated, particularly timolol and levobunolol, because they will cause bronchoconstriction. Very powerful question all the time asked: which a patient presents in acute bronchial asthma to the medicine emergency? He says he's been using some anti-glaucoma drug. Which drug? It is timolol, which is a beta blocker. What else? Remember, in diabetics, we have these two drugs are used. They are not contraindicated, but used with caution. The glycerol is definitely contraindicated because it raises intraocular pressure. Raise the blood sugar. I'm not so sorry. Raise the blood sugar. Glycerol is very, very sweet. Raise the blood sugar, so it's contraindicated in diabetics. And acetazolamide causes metabolic acidosis, which is dangerous in diabetics who already have metabolic acidosis. So therefore, acetazolamide should be used with great caution in diabetics because they may worsen the acidosis. So these are certain interactions which you have to be careful about. But it's not over yet, because what are anti-glaucoma drugs? You have to watch out in depression. And many of you seem to be depressed here, watching me here, and wondering what is the harvest be and when will this class get over. I'll try to get on with it. Depression is, remember, two glaucoma drugs are famous for depression, particularly brimonidine. Again, I told you brimonidine seems to hog all the answers. Brimonidine is absolutely contraindicated in depression, which is nowadays the most common disorder in the world. According to WHO, depression is the most common disorder, having overtaken cardiovascular disease. And timolol. Timolol to a lesser extent causes depression, not so much. Much more is brimonidine. Okay? So multiple questions, drugs, and we still have. Remember, out of all the anti-glaucoma drugs, apraclonidine is the highest allergic, followed by brimonidine. So apraclonidine and brimonidine are both alpha-2 agonists. So apraclonidine we don't use so much nowadays. Luckily for us, is highly allergic. So the six, again you see brimonidine. Every question, brimonidine hogging all the answers. And again, brimonidine pilocarpine causes follicles. So it is, for me, ladies and gentlemen, if you get a question on anti-glaucoma where you're not sure of the answer, a good way is to write brimonidine. You don't know anything. Okay? It seems to hog everything. Okay? And these are the two antibiotics which cause follicles on the conjunctiva, okay, because of the highly allergic thing. So these are anti-glaucoma drug interactions we need to know. And the first anti-glaucoma drug, which remember we talked about, is IV mannitol, which is intravenous. And if it's not given as IV mannitol, then you answer acetazolamide. But acetazolamide is also available intravenously, but not in our country, outside. But it can be given as IV. So in the absence of mannitol, you can write acetazolamide. Okay? But the first should be mannitol. Okay? So these are certain anti-glaucoma drug questions, and we have a lot of MCQ. We have a lot of MCQs here. So this is lens-induced glaucoma. Okay? Let's look at some secondary glaucomas now. What is secondary glaucoma? Secondary glaucoma means glaucoma where the cause is known to us. Okay. Remember, angle closure, open angle glaucoma we call as POAG for open angle, primary open angle glaucoma, and PACG for primary angle closure glaucoma. The word primary is often added because we don't know the cause of them. Okay. We don't know why the pressure rises. Okay. Here we know the cause. So lens, when it induces glaucoma, it can induce in two different ways. One is called phacomorphic, and one is phacolytic. Look at that. Phaco, the word phaco means lens. Look at the word morphic. Morphic means morphology. So what happens when you have a mature cataract? What it does, it swells up and pushes the iris forward, closing the angle. It's a bit like this. If you see this is the iris, okay, and this is the lens. So when a cataract becomes mature, you can see the mature cataract white in color, okay, because it absorbs a lot of water from the aqueous, okay, and it swells up. The word intumescence means swelling. So look at the lens swelling up. It swells up like this. As it swells up like this, see, it pushes the iris forward. Iris pushes forward and the angle closes. The angle closes and the aqueous pressurizes. So this is the way a mature cataract can cause glaucoma, which is a secondary angle closure glaucoma. We call it phacomorphic, and it's again presents as an acute angle closure glaucoma. You can see the redness, you can see the vertically oval pupil, the pressure is high. Remember, acute angle closure glaucoma and phacomorphic glaucoma present similarly. Pain, redness, colored halos, loss of vision, etc., etc. Same thing. The only difference is, and with the same pupil, vertically oval pupil, only difference is you will know it's phacomorphic when you see the cataract. Because in phacomorphic, the angle closure glaucoma is caused by the cataract. You will see the cataract. In acute angle closure glaucoma, the glaucoma is caused by the blockage, the pupil blockage. It is not caused by cataract. So that is the only difference. Treatment, first to lower the intraocular pressure, and more important, definitely is to do cataract surgery, or phacomorphic, okay? And then we do phacolytic glaucoma. Phacolytic glaucoma is, remember phaco, anytime you get the word phaco, it means lens, okay? So phacolytic glaucoma is caused by a hypermature cataract. Remember, that was a mature cataract. This is a hypermature cataract, and because hypermature cataract is a very, very old lens, so it starts leaking protein. Look at this. The HMW means high molecular weight. It means high molecular weight lens proteins. They start leaking out. Okay, so it works a bit like this. So suppose you have the phacomorphic. Remember, it's very small, no? So it's a very small hypermature cataract with an old capsule. And this old, wrinkled and fragile capsule allows the high molecular weight proteins to leak out. Okay, so look at that. So they leak out through this and they go and block the trabecular meshwork. So they block the holes of the trabecular meshwork. Again, the pressure rises and causes glaucoma. But this is an open angle glaucoma, and this is trabecular meshwork blockage leads to annualized pressure. This is called phacolytic glaucoma. The difference between phacomorphic and phacolytic: phacomorphic is angle closure, phacolytic is open angle. Phacomorphic is mature cataract, phacolytic is hypermature cataract. Okay, but the treatment of the both are the same. We have to get rid of the cataract. So this is the cataract which causes the glaucoma. We treat the cataract surgery. So phacomorphic and phacolytic, can remember, are two different ways in which the lens can cause glaucoma. And then the last of the glaucomas, the most fearsome of all, which is I am always scared of, the neovascular, new blood vessels. So new blood vessels appear on the eye, and how? Because of any condition which causes hypoxia. It's not. Remember this very famous circuit where the retina, anytime the retina becomes hypoxic, hypoxic, it may cause retina. What a condition causes hypoxia? It will produce VEGF, vascular endothelial growth factor, and this will produce new vascularization. So new blood vessels occur on the iris, and as they occur on the iris, look at that, these new blood vessels will come like this, and because they are fibrotic tissue, there is fibrovascular tissue in the blood vessels, so it can contract. So as it contracts, what happens? It pulls as close to the cornea like this, and the angle closes. The angle closes, the intraocular pressure rises again. So neovascular glaucoma, kindly remember, is a type of angle closure glaucoma caused due to retinal hypoxia. So number one cause of neovascular, always memorize this, is diabetes followed by CRVO. Okay? When we have CRVO causing neovascular glaucoma, typically we call it a 90-day glaucoma, which we'll discuss again. Remember, whenever central retinal venous occlusion causes the same thing, it's the same thing happening. Occlusion will lead to hypoxia, hypoxia will lead to VEGF, VEGF will lead to neovascularization. So they close the angle and you develop a neovascular. So number one cause diabetes, number two is CRVO. So this is the way glaucoma, it closes the angle, zips the angle shut, and the pressure rises, and you can see the new vessel. Look at the new blood vessels. See the new vessels here? It is absolutely abnormal to have vessels like this, and they are contracting the iris and closing the angle. Okay? So you have a red painful eye, pressure is very high, raised intraocular pressure, which causes corneal edema, and rubeosus iridis, which is the name given to the blood vessels on the iris, rubeosus iridis. Okay? So this is how you get the diagnosis of glaucoma. And what is the treatment? Remember, early we divide into two types, early and late glaucoma. Early glaucoma is we can still treat because we have to give anti-VEGF drugs. First, remember, it's because of VEGF, no? So first you treat the VEGF with anti-VEGF, which is bevacizumab or ranibizumab or aflibercept. Okay, any of these three are fine. You can use any of them. Bevacizumab, ranibizumab, aflibercept. If you remember the first two, I'd be happy. Any of these two drugs we give intravitreally, we have to inject through the pars plana. It reaches the retina, and anti-VEGF. The second is to treat the hypoxia. Treat the hypoxia by doing pan-retinal photocoagulation. You take a laser beam which focuses on the retina. Pan means the entire retina except the macula. So you spare the macula and you do a panel photocoagulation. This is the best treatment of retinal hypoxia. So there's no hypoxia, there's no VEGF, and neovascularization will stop. So that is the way to stop neovascularization. First, we stop this one. Second, we lower intraocular pressure with drugs, and drugs, anti-glaucoma drugs, and remember, except these two, okay? Except prostaglandin analogs and colony agonists, MCQ. Remember the MCQ, which anti-glaucoma drugs are contraindicated in neovascular glaucoma? Prostaglandin analogs and colony agonists like pilocarpine and carbachol. Why these two? Because they both cause uveitis. They both cause uveitis, and neovascular glaucoma is already inflamed eye. We don't want any further inflammation. Thank you very much. Okay. Remember, these two are contraindicated. But as a matter of fact, anti-glaucoma drugs do not. We got this question from Raja Charan. No, Raja. Krukenberg spindles are not seen in neovascular glaucoma. Krukenberg spindles are seen in pigmentary glaucoma. Kindly remember, that is the pigmentary glaucoma, where on the cornea you get a spindle shaped figure like that. Spindle, where spindle means where you have tapering ends, top and bottom, and the middle is equivalent. Like I am rapidly developing to spindle myself, with a thin at the top, a thin at the bottom, and expanding like a spider hair, an octopus hair. This is a Krukenberg spindle, which is in pigmentary glaucoma, not in neovascular glaucoma, to answer your question. Okay. So, and then kindly these two are contraindicated. And then, but as a matter of fact, remember, anti-glaucoma drugs are not really very useful in neovascular glaucoma because the pressure is so high that the drugs rarely can lower it down. So we have to basically fall back into surgery, which is the trabeculectomy. Okay. So usually we do trabeculectomy or aqueous drainage implants. Remember, don't confuse trabeculectomy. Okay. This is for adult glaucoma, with trabeculotomy with juvenile, with congenital glaucoma. Okay. Remember, otomy and ectomy difference. Otomy means making a hole, ectomy means making removal. So in trabeculectomy, we remove a piece of the trabecular meshwork. This is done in adult glaucoma. Okay. In children, we do trabeculotomy, which is making a hole in it. Remember how to memorize O. Otomy, O, your lips become rounded like that of babies, O like that. So this would be in children, trabeculotomy. The ectomy is in adults. These are the most important surgeries. So we lower the pressure somehow. It's not easy, but we can do it. This is early neovascular. When it's late, this was the management of early neovascular glaucoma. Late neovascular glaucoma, remember, is not much. Not much can be done here. Late neovascular glaucoma is too late. The pressure is so high that we have to destroy the ciliary body. We can do cyclodestruction. The patient is already blinded most of the time. The raised intraocular pressure destroy the optic nerve. Okay. So there's nothing, we cannot give him vision back, but it will make him more comfortable to lower the pressure. How? By destroying the ciliary body. This is called cyclodestruction. We can do it with two things. One is to diode laser cyclophotocoagulation. We call this DLCP. There's another laser. We take a diode laser, focus on the ciliary body, destroy the ciliary body, the pressure comes down. After it takes about 20-30 days, the pressure comes down. But because it's a little expensive, so it is not done so much. So we prefer to do another way to lower the intraocular pressure, which is cyclocryopexy. Okay, cyclocryopexy. We have Dr. Vikram Chaudhary here. Namaskaram, Dr. Vikram. Welcome. Cyclocryopexy. Remember the word cyclo means ciliary body. Cryo means cold. Pexy means destruction. And you can see it here. See how cold that probe is. And you have to remember this cryo means cold. So it's a very cold probe. You can see it. And you remember the temperature of this cold probe. It is a mind-boggling minus 80 degrees centigrade. Look at that. And remember this temperature, minus 80. Easy to memorize because it is the coldest in the universe. It's colder than Antarctica, colder than Siberia, colder than your ex-girlfriend's heart also. You know, all of you guys know that the coldest in the universe is an ex-girlfriend's heart. There's nothing colder than that. Okay. This is colder than that, and this is minus 80 degrees centigrade. Okay. So please remember, we take this, touch the ciliary body, and destroy the ciliary body, pressure comes down, but the patient doesn't recover vision. Okay, because vision is gone. So this is a sad story of neovascular glaucoma, one of the most dangerous of all glaucomas that we have. Okay, so that's enough of glaucoma. We go back to something very important, which is not liked by many of you, but it is a very important topic. Usually 4 to 5 MCQs come off this. Okay, what is that topic? It is refraction and optics. Okay, refraction and optics, and we have got Samir Khan here. Khan bhai, adab, salam alaikum. Refraction and optics. Okay, so I know that you guys don't like it, but what to do? I mean, this is ophthalmology. We have to do some physics and maths, but we will try to rush through it with the minimum of mathematics. What is that? The first of all, the definition, emetropia, a condition where the rays focus on the retina. Okay, so you see this condition, and the rays focus right on the retina like this. Okay, so this is emetropia. Emetropes, remember, we do not have to wear glasses. So people who don't wear glasses, like me, like many of you don't wear glasses, the rays of light focus right on the retina. We don't have to wear that. But alas, everybody is not so lucky. What about people where the rays do not focus in the retina? We call that condition as ametropia. Ametropia, E and A, like key and car. Ametropia, rays do not focus. If they do not focus on the retina, where would they focus? Well, there are three possibilities. Okay, the three possibilities are they can focus in front of the retina, we call them myopia, or they focus behind the retina, we call them hypermetropia, or they can have two different foci, one in front of the retina, one behind the retina, and this could be astigmatism. Okay? So two foci. Anyway, it doesn't matter where it focuses. One could be in front, one could be behind. They could be both in front, they could be both behind. Doesn't matter. If you have two foci, it's called astigmatism. So we have these three different types of conditions: myopia, hypermetropia, astigmatism, which are all types of ametropia. Okay. So, but who decides that? With that, I will be emetropic and you will be myopic or hyperastigmatic. God decides. Of course, He does. He decides everything. But we need some better choices to take. What are the answers? The answer, remember, it depends upon corneal curvature. No, more corneal curvature. Some of have flat corneas, some of have steep corneas. No, axial length. That is the length of the eyeball. Anterior chamber depth. Okay, and lens thickness. Remember these four things. Together, these are four variables which decide the final refractive status. That is axial length, anterior chamber depth, corneal curvature, and lens thickness. Remember, MCQ of this, the by far the most important is corneal curvature. MCQ always asked, the single most important factor that decides whether rays will focus on the retina or not is the corneal curvature. Okay. Then, as I said, most important factor contributing for this corneal curvature. So that's important for the three kinds of we just mentioned: myopia, hypermetropia, astigmatism. We have this. So let's talk about the first one, which is myopia. Remember the word myopia, as you can see, this little lady here is a condition where it keeps her eyes half shut. You know? Look at her squeezing her legs like this. This is a myopic patient. The word myopin, the myopia comes from the word myopin, which means a patient who keeps the eyes half closed. Okay? This is MCQ, typically asked, very famous. The parents of a child complain that the child watches TV with the eyes half closed. Not because of any objectionable content on the TV, I hurry to add, but because they can't see. So those of you who are myopic and not wearing glasses, you often keep the eyes half closed like this. Half closing the eyes like this lady is showing keeps the rays focus on the retina because of an effect called the pinhole effect, which makes these patients see clearly. So uncorrected myopes. And remember, those of you who are wearing glasses, there is no such problem. It is the problem with patients who do not like to wear glasses. Okay? Typically, we say that myopes are people who keep their eyes half closed when they don't wear glasses because they can't see clearly. And remember, the most common cause is axial myopia, where the eyeball is longer than normal. So, and each 1 minute extra cause 3 are very important. You can remember. So, what I'm telling you is, look, see, suppose you have a 24 millimeter eyeball, is not? The rays would focus here, correct? But these are large eyeballs. So, the axial myopia means a large eyeball, okay, like this. If you have an eyeball like this, which is 25 millimeters, let's say, so what will happen? The rays will still focus, is not? Because the cornea would still be the same power, 43, and the length still 19. The rays would focus here, but the eyeball is longer, the retina is backward. It's gone back because the eyeball is longer. So retina is not there to collect the rays. So this, by definition, rays are focusing in front of the retina and they are myopic. So kindly remember, this is the most common cause of myopia called axial myopia, where the eyeball is longer than normal, and every 1 millimeter extra causes 3 diopters of myopia. Very important to remember equation. So that means that those of you who have a 25 millimeter axial length will have to wear 3 diopters. Every 1 millimeter extra, is it not? 26 millimeter is 6 diopters. 27 millimeters would be 9 diopters. You see this? So how every 1 millimeter extra length is jumping your power by 3 diopters. Look at that, the power of the axial length. This is the most common. However, it is not the only cause of myopia. Another cause is called curvature myopia. The example was keratoconus. In this case, remember, again the rays have focused in front of retina, but not because of the axial length, but simply because the cornea is too curved, and a steep corneal curvature bends more rays. You know that, no? More the curvature, more the bending. So more the bending, so it will focus in front of retina, so you become a curvature myopia again. Example being keratoconus, and this is very high myopia because every 1 mm extra curvature does not cause 3 diopters, but causes 6 diopters of myopia. Remember, that's important. So axial myopia is more common, but is not as dangerous because only 1 mm extra causes 3 diopters. But curvature myopia, as in keratoconus, is rarer, but is more dangerous because every 1 mm extra curvature causes 6 diopters of myopia. So keratoconus patients are very high people. They are very high myopic people. -6, -10, -20, -30, things like that. So these are because every 1 mm extra causes jump in power by 6 diopters. Okay? Now, we've got a question here from after session will be PDF prepared. Yes, Mohammed Sharab, the PDF will be provided to you after the session, but that does not mean, as the next friend comments, that you should miss the class. Okay, yeah. So power of lens calculation is important for NEET PG. Yes, power of lens calculation is definitely important for NEET PG, which is retinoscopy. We'll discuss that. No? And so myopics, remember, because the rays focus in front of retina, have distance visions blurred, but a near vision they can manage, they can see. You know why? So a myopic typically can read nearby objects. He may have to get it a book closer like this, but he can't read the distant ones. Why? Because by definition, distant rays are parallel like this. You can see that, and the rays focus in front of retina. So why will you be able to see near ones? Because you see the near ones you can see because these rays are divergent, is not? There's a divergent. The near rays are divergent, so they focus later, and because they focus later, so they become parallel. Because they become parallel later, so they focus later. So they focus later, right on the retina. So near rays, they can focus on the retina. Okay, so they can still see near objects, but they can't see distant objects. So this is the main problem myopia. The bane of their lives is they cannot see distant objects clearly. They can see just near objects, okay, but they can't see distant objects. So what we have to do is to give concave lens prescribed to focus. Why concave lens? Because you see, look at the condition. It's easily understood. This is a condition where rays are focused in front. Now I want the rays to focus on the retina. So I can't give any lens which converges. Not convergence will cause the rays to come even more forward, isn't it? So I need something to diverge the lens. So I need a concave lens like this. Look at this. I diverge concave lens like this, and what will do? It will focus the rays. It will diverge like this. So it diverges. So it becomes parallel later. It becomes focused later. So concave lenses, they are prescribed to the people who are myopic. So all of you guys who are myopics are wearing concave lenses. We call them divergent lenses. How would you know? Because we call them minus powers. Remember, anything that's divergent in ophthalmology, we say they're minus. Those who are wearing -1, -2, -3, -1, you're all myopes. Okay? Minus means concave lens, and concave lens is only worn by myopics. Okay? The only problem of concave lens is the minification. It makes the image sizes smaller. With every 1 diopter, you have image size of 2%. Okay, if you have 2% image. So supposing that any of you, suppose my friend Mohammed Shadab, who's taking a break, I think, is wearing a -2 diopter spherical lens, then into 1 diopter is 2%, into 2 into 4%. Okay, so you have this 4% minification image size. The image size becomes smaller. Okay? So that is the only problem with concave lenses. Every 1 diopter causes reduction of the size of the image, minification by 2%. If you're wearing -5, it becomes 10%. If you're -4, it becomes 8%, things like that. That may cause problems to people who are high-powered glasses, like -10, will reduce the size of the image to 20%. That was myopia. And also remember, myopes are preferentially undercorrected. Undercorrected means less power. So suppose that you are wearing -3, then we can give you -3. But a better idea is to give you -2.5 or even -2.75, to give them less correction than the normal. This is called undercorrection. The vision remains as clear, but they're more comfortable. So they're more comfortable. So it is a better idea to undercorrect, give less correction to myopics for reasons which you do not have to go into right now. Because remember, it's a revision course. And how we do that? We do this by the famous duochrome test. Remember, we identified this duochrome because there are two colors, red and green, and on letters will be written on red, some letters will be written on green. You ask them, once you have finally given him the correction, okay, final glass you prescribed, let's say, you ask him, he read the letters, whether the red ones or the green ones, which is clearer, okay, and that will help you guard against overcorrection. Overcorrection means that you must not give extra power. So -3 can be given 2.5, 2.75. You cannot give -4 or -3.5. This is called overcorrection. This is absolutely unacceptable. Okay. So what we do is ask them to read the two letters and ask them to compare. If the red letters are clearer, that means he is undercorrected. That is what we are aiming for. Most of the time, we aim for the red to be clearer than green. This is undercorrection. If the green is better than red, it is overcorrection and not to be prescribed. If they are both equally clear, then it is fully corrected. You can still give them. So -3, you give -3, red will equal to green. That's not a problem. But better it is for the comfort of the patient is to make the red clearer. Please remember, we aim for red better than green. Okay. How to memorize this? We memorize this by remembering that it is exactly opposite to that of a traffic light. Remember, in a traffic light signal, we only progress when the green is done. Here, if the green is better, then we go back and we change the power. Here, we only progress when the red is better. So remember, often is opposite to traffic lights. This is overcorrection. And for myopes, then we go to the next case. So remember, myopes are basically very simple people. You know, myopes are very simple. All they want to see is see clearly. Okay? They are very simple people. They just want to see clearly. You know, like girls just want to have fun. Similarly, myopes just want to see clearly, and all they want is, doctor, we should be able to see clearly. They are very simple people. Give them contact lenses, and they're the happiest people on earth. What about the next condition is hyperopia, also called as hypermetropia. Okay, what is that? The definition, remember, here the rays of light focus behind the retina. They focus behind the retina. But why would they focus behind the retina? Well, simply because the eyeball is smaller. Does that make sense? Because the eyeball is smaller, so the rays would focus behind, because they are programmed for a cornea and lens of 43 and 19. The rays would focus there only, but the eyeball is smaller, so the retina has come forward and they have become hypermetropia. Okay, so eyeball is smaller, and remember, in this also, every 1 millimeter of shortening causes 3 diopters of hypermetropia. Okay, so please remember, this is called axial hypermetropia. The most common cause is called axial hypermetropia, just like myopia was called axial myopia. And the reason is a smaller eyeball, a shorter eyeball. That is why, remember, myopes are people with large eyeballs, hypermetropes are people with small eyeballs, and people with normal eyeballs are emetropes like me. Okay? So that is why hypermetropes also have raised intraocular pressure, remember, because the size of the eyeball is smaller, so there is less space and the pressure rises more. Okay, so that's why hypermetropes we remember as one of the causes of angle closure glaucoma, isn't it? Very well. And because, so what we do, these guys, they require a plus part, is it not? So you can see that clearly that these are people, because the rays are focusing behind the retina, so they will require a convex lens, no? When you have a convex lens, then lay the focus on the retina. So this is what they require. But remember, they all wear convex lenses, and the convex lenses have magnification. Remember, 1 diopter, 2%. You're wearing a plus 10, you magnify into 20%. So remember, all convex lenses magnify, all concave lenses minify. Now, the problem with hypermetropes is they don't use this convex lens. You know why not? Because they already have a convex lens in their own eyes. Remember, the crystalline lens is already convex. So they just increase or decrease that power. They just change the power of this own convex lens, which is a condition called as accommodation. Is not? Remember, accommodation is a device which lets you increase the power of the lens by making the lens more convex. So that is what they do. Instead of wearing a convex lens, they accommodate subconsciously and get this power of convex lens which they need from their own crystalline lens. And that is why they keep accommodating all the time. Remember, it's completely subconscious. They don't do deliberately. It's done automatically. So hypermetropes are always accommodating for near and distance. Remember, that is not a good idea, because accommodation is meant only for near. So these guys, the hypermetropes, they're not using accommodation. They're abusing accommodation. Why? Because using for a purpose which is not meant. Accommodation is only meant for near. But hypermetropes cannot see near, they cannot see distance, they cannot see intimate because they can't see anything. So always accommodate, and because they accommodate all the time, so they have problems of eye strain, which is called asthenopia, and excessive accommodation. So they are indulging in excessive accommodation because otherwise they can't see clearly. And that is why they have the asthenopia or eye strain. So kindly remember, hypermetropes always comes with headaches and eye aches. They never complain of visual problems because they can see clearly. By accommodating, they can see clearly. They get the rays on the retina, no? They can see clearly, but they have problems of headaches and eyes because they're always accommodating. The ciliary muscles are always contracting, and so we develop a lot of headaches and eyes. They have asthenopia. This is eye strain. Very well. So because they accommodate so much, they lead to convergence. You know why? Because look at that. This lady has the convergence has gone so much like this. Because they accommodate so much. Remember, every time they accommodate, there's two things: convergence and meiosis. Also, the three things together: accommodation, convergence, and meiosis. So because they're always accommodating, so they're always converging. So after 5 years of constant accommodation and convergence, all uncorrected hypermetropes can land up with a convergence squint, as you can see here. Okay, so this is a very dangerous thing to have, and so we have to correct them in convex lenses. And remember, I said each one diopter causes 2% magnification, and uncorrected hypermetropia therefore leads to convergence. So please remember. So, but the good news is, remember that it is not small amounts of hypermetropia. At least it has to be around 4 diopters. If you have only say 1 diopter, 2 diopters, you don't have squint, you have 4 or more, then you're not wearing glasses, you're accommodating, you're converging, you may develop convergence squint. We need a minimum of around 4 diopters of uncorrected hypermetropia to cause convergence squint. Okay, this is why when patients come to us with squint, we have to check the refractive status. Are they hypermetropes or not? This is what we have. And then remember how to diagnose hypermetropia by doing cycloplegic refraction. Okay, so remember, because hypermetropes can accommodate, so the vision is clear, 6, 6 and 6. So we have difficulty distinguishing them from an emetrope who also has 6, 6 and 6, is not. The myopics can't see. So they, when you ask them read the chart, you will find they have poor vision, and that tells you that you're myopic. But hypermetropes are accommodating, so they are getting both 6, 6 and 6, just like an emetrope who's also getting 6 and 6. Then how to differentiate between the two? By doing cycloplegic refraction, which means to put a drop of cycloplegic, which is atropine or homatropine or cyclopentolate or tropicamide, in these patients on which you're suspecting hypermetropia. What will that do? They will paralyze the accommodation and the vision will drop. In emetropic, the distance vision will not suffer because emetropes don't use accommodation for distance, only for near. But for hypermetropia, this will immediately suffer because it paralyzes accommodation. Okay, so this is called cycloplegic refraction and is done for people with high ciliary muscle action, like high accommodation, like hypermetropics, and children. Which drug will you use? Why children? Because they have very high ciliary power. The drug you use on these depends on the age. Atropine for very small children less than 5 years because they're very powerful accommodation. Homatropine for 5 to 10 years, and above 10, 15, you have to use cyclopentolate. And for you guys, if you come to me, then I'll use tropicamide because you're older, your ciliary muscle is much less. The drug depends upon the child. If it's a child, very small children have atropine, remember up to 5 years, 5 to 10, homatropine, 15 onwards, 10 to 15 onwards, 10 to 15 onwards is cyclopentolate, 15 onwards would be tropicamide. This is called cycloplegic refraction. Okay? And this one thing that hypermetropes have to do, you remember, they wear the glasses on the tip of the nose. This is the principal lens effectivity. Myopics wear the glasses close to the eyes because they wear concave lenses. Hypermetropes wear the glasses close to the tip of the nose because they are wearing convex lenses. Okay, so remember, they wear the glasses low down on the nose. Like low-waisted jeans, the hypermetropes prefer to wear the glasses low down on the nose. Okay, these are multiple questions of hypermetropia. I hope you're all getting this. I know it's a little tough, and post-lunch session is a little more difficult for us to handle, but we will again have a short break, another few minutes. So hang on to your consciousness, don't collapse. Okay? We have the next condition, astigmatism, one of the most difficult things, also the most unhappy patient in the ophthalmic OPD. This is a condition where you have 2 different foci. First of all, it's the most common refractive error, and you have 2 different foci where the image found by 2 different foci like this. Okay, so you have the condition where 50% of the rays focus here and 50% of the rays focus there. Okay, you see, not one, that's why it's called astigma. Stigma means point, A means no single point. So here the image is not formed in a single point. Okay, so you have two intervals like this, one focus here, one focus there, and in this interval the image falls. This is called as astigmatism. Why do you do that? Because of the curvature of the cornea. You see, the human cornea is not a perfectly uniform sphere, is it not? The center is usually more curved and the periphery is flatter. So if you have a center which is more curved like this, then the rays would focus earlier, because more the curvature, more the bending, rays would focus in front. Okay, and if the rays are coming from the periphery, which is the flatter, then the rays would focus behind, because the flatter surface does not bend the light well. Okay, so that is why we have astigmatism, because of the non-uniform or the imperfect curvature of the cornea, and that is why this is the most common refractive error. It is all of us have astigmatism. Some have less, some have more. Some have significant, some non-significant. Some require correction, some don't require correction. But all of us have astigmatism. That is why it's the most common refractive error. Please remember, that's MCQ. And we have different foci like this. And because two different foci, the image is not formed in one single point. Instead, see what it forms. The image forms anywhere between these two focal lines. And if you see this interval, this is called a cone. Can you see this is the cone? And this cone is an important name. We call it conoid of Sturm. I've got a request here. Is yes, provide the PDF after the class. That's correct. I've got somebody called Cord here. Yes, Ms. Cord, the PDF will be provided. It will be provided after the class, but only after you tolerate me for these 6-7 hours as compensation for this mental and physical torture. You will get the PDF, but you have to tolerate me for that time being. Okay. So look at this space. What is this space? This space is like a cone, like an ice cream cone. And this space is called the conoid of Sturm. Conoid, like a cone. Okay. So remember, these are very important MCQs. NEET PG also, FMG nowadays. So conoid of Sturm will be a MCQ. They'll ask you in which condition will you have conoid of Sturm. And in this cone, remember, the sharpest image will be formed in exactly the center of this cone, which is called the circle of least confusion. Okay, look at that. Called the circle of least confusion. You can see that here. Okay, so we have, when you focus here, this is the one cone, and this is the one of the rays focus here. Focal line, this is the one focal line, this is the other focal line. Okay, you see here. So this area, the cone is the conoid of Sturm. You can see here, written here, and the center of this conoid of Sturm is the place where you have the best possible vision, because the points are forming, the image is forming not in a point which should be ideal, but in a circle of least confusion. See, it's not a point, astigma. So there's no single point, but there's the circle of least confusion. The circle of least confusion is the center. This is the one. You can see the circle. The rest of, look at this circle, it's huge. This is elliptical here. This ellipse is huge. The circle with the smallest diameter is this one. The smallest blur circle, we call it. Circle of least confusion is the place where the image forms. So the MCQ will be asked like this: where should the retina be placed in astigmatism? Remember, we should do retinoscopy such that the power is prescribed, so the retina is located on the circle of least confusion, which is where the most clear images will be formed. So kindly remember, these are two new terms which you should know, because they are asked in all kinds of exams nowadays, and FMG exam is now being pushed up to the level of NEET PG also, is not. These are conoid of Sturm, leaves confusion. And then what's the next thing? The next thing what we have here is of astigmatism. We have to do astigmatism, and also remember, next is the maximum asthenopia. Please remember, it causes the highest amount of asthenopia. Even remember, hypermetropia is also asthenopia, but astigmats have much more so. So they have the most common refractive error, they have the highest asthenopia, and corrected by the cylindrical autolus. Remember, we have to correct them by cylindrical lens. Okay, so not spherical lenses. That is why when we write my big prescription, we write -2 diopter S, is it not? S for sphere. When we write hypermetropic prescription, we write +2 diopter S, plus for sphere. Why? Because convex concave lenses are made of a glass sphere. You see, this is a sphere, and when we cut this sphere, we get these three kinds of lenses. They are both constructed, the convex and concave lens constructed from sphere, it's called spherical lenses. But cylindrical lenses, they are cylinders like this. So astigmates are corrected by cylindrical lenses. One has a major axis, one is a minor axis. So astigmates are corrected by cylindrical lenses. And how will we know that? It will be written in the prescription. So in the prescription, you will see a minus 2 diopter C. You know, the word C will be mentioned there. A minus or a plus 2 diopter C will be mentioned there. And PPT is behaving a little weirdly now. So give me a second to adjust this. So it's called as minus 2 diopter C, C for cylinder, and you have to write an axis. This axis will be anything from 1 to 180 degree, 90. See, look at the cylinder. You have the cylinder, glass in front of me. This is cylinder. So if then astigmatism, we make a lens out of this cylinder. We cut the cylinder like this. You have one major axis, one minor axis, and see there is an angle between them, is not? Because the angle between them, so similarly you have to write the angle in astigmatic prescriptions. So you have to, when you write the prescription in astigmatism, you will often see there are 3 different numbers like this. Minus 3 diopter sphere with a minus 2 cylinder at 90. You will have 1 for sphere, 1 for cylinder, and 1 is the axis. You have to always mention the axis. Astigmatism, the power depends on the axis. In sphere, the power is the same in all the spherical meridians, so it does not matter. Astigmatism, it's cylinder, so you have to write the axis, otherwise it doesn't make sense. Okay. And yes, I am getting a request for a tea break. Bhai, give me a couple of minutes, because I want to finish this topic and then we'll go for have a tea break. You're absolutely right. We do need a tea break, but in a few minutes. And next question. So let's do astigmatism. Just finish astigmatism. So we'll finish one topic. And this is so we have these 5 different types of astigmatism. 5, okay. One is called simple myopic astigmatism. Okay. Simple myopic astigmatism. So you see what is like this. The description like this. So this is one rays on the retina like this, and one in front of retina. Now this is called simple myopic. Okay. So we write an example: minus 2 diopter C at 90. See why minus? Because one is myopic. Why cylinder? Because astigmatism. Why 90? I have picked up any axis. So this is an example of a simple myopic astigmatism. Okay. Similarly, the second type of astigmatism is called simple hypermetropic astigmatism. You know how? In this condition, the rays would be like this. One would be on the retina, the other would be behind the retina, is it not? So this is called simple hypermetropic. Why? Because one is hypermetropic, the other is on the retina. This is called simple hypermetropic astigmatism. And example would be plus 3 diopter. Why plus? Because one is hypermetropic. Why C? Because cylinder, astigmatism. So any axis we can give. I have just written anything that occurs to my mind. Okay. And then the next thing would be more complex. It's called compound myopic. What is that? In this condition, look at this. There are 2 rays, but they are in front of it. Both are in front of it. Remember, in simple myopia, simple hypermetropy, one is on the retina. Now these are both in front, so this is not simple. Okay, this is compound. So they're both in front of retina. So we write compound as minus 2 with a minus 3 with 25. You see, we need 2 minus. So why? Because both of them are myopic. So one is myopia for this, the other minus is for this. But we have to combine a sphere and a cylinder, because 2 spheres cannot be combined together like this. 2 cylinders cannot be combined together, but a sphere and a cylinder can be combined together. So by sign convention, we'll write the sphere always first, cylinder later, but you'll have 2 minus signs that tell us compound. See, that is the way to differentiate. In simple myopic, you'll only have 1 minus sign. In compound myopic, you'll have 2 minus signs. Similarly, compound hypermetropic will have a condition where both the rays are focusing behind the retina. One here and one there. You understand? This is not simple hypermetropic, because simple one will be on the retina. The compound hypermetropic would be both behind the retina. Both behind the retina. The compound hypermetropic astigmatism is both behind the retina, and this will have 2 plus signs. Plus 3, plus 2, and again sphere written first, cylinder written later at any axis which I choose. At any axis which I choose. So look at the difference. In simple hypermetropic, we have 1 plus sign. Compound hypermetropic will have 1 plus sign. No? Big part. Compound we have 2 plus signs at any axis. And finally is the mixed astigmatism, where you can have a condition where one of the rays are focusing in front of retina, the other behind the retina. One is myopic, other is hypermetropic. We call this as mixed astigmatism. Okay, and we write this similarly with 1 plus and 1 minus sign. So adding. So you see, this is how we distinguish between the 5 different types of astigmatism. Kindly remember, we'll give you prescriptions like this in the exam. You have to tell us a diagnosis. 1 minus sign, simple myopic. 2 minus signs, compound myopic. 1 plus sign, simple hypermetropic. 2 plus signs, compound hypermetropic. 1 plus, 1 minus, mixed astigmatism. I'm sure you'll be able to do this fine. Okay? A little complicated, but ophthalmology is complicated. And then we have to go to another type of astigmatism. Look at that. These 5 types, they're all regular types. These are all regular astigmatisms. The 5: simple, myopic, hypermetropic, compound, mixed. There is one which you can see here. Suppose the surface is irregular. Can you see this corneal scar? Or on the surface of the cornea, this is corneal scar, corneal opacity. No, this is a corneal scar or opacity like this. And because of this scar opacity, the rays of light will be scattering here and there. They'll go here and there because the surface is not smooth. So whenever the surface is not smooth of the cornea, you land up with astigmatism which is called as irregular astigmatism, because the rays of light are focused irregularly. So they could be keratoconus, pterygiums, Salzmann nodal degeneration, or any post-traumatic scar, post-refractive surgery scar, and the MCQ is they can only be corrected by contact lenses. So remember, because the surface of the cornea is not smooth, suppose there is a corneal scar here like this, okay? So rays of light are jumping here and there without any rules. So how do I make them focus? Not by glasses, not by spectacles, but by placing a contact lens on the surface of the cornea, which will make it smooth. When they make it smooth, so then these people will only correct with contact lenses. So remember, MCQ asked, patient is 6/18, not improving with any kind of glasses, but only improves with contact lenses. What is the diagnosis? You will say irregular astigmatism. Okay, so this will be the question based on. So we have regular, 85%, irregular about 15%. Regular has 5 different types we just did. Okay. The next thing about astigmatism, over with astigmatism. So to summarize astigmatism, we have, remember, the 3 types of myopic astigmatism. So remember, of all the 3, astigmatism is the most common. Okay, they have the maximum asthenopia. They are the only ones to have cylindrical lenses or toric lenses. Myopes have problems of vision. Hypermetropes have headaches and eye aches. Astigmats have the highest amount of headaches and eye aches. Okay, and now we come to presbyopia, and after this we'll take a break as I have been requested. So presbyopia, remember, loss of accommodation is with age. So look at this lady, looks very attractive, but she is not exactly your age, my friends. Okay, she's not 25. Okay, you can look, if you look carefully at her. No, so what is she happening? She's holding her mobile a little far away from that. Okay, a little far away from that. This is not reading, this is not. Why is she doing that? Because she can't read. Because why can't she read? Because she's slightly older. She's about 45, according to my eyes. And this is what you see, loss of accommodation with age. Remember, accommodation, you lose accommodation with age, okay? And so as you do the accommodation, remember, accommodation is meant for near activities. So all the near activities, reading, writing, stitching, sewing, knitting, cooking becomes difficult. You have to hold objects like this. Presbyopia is called loss of accommodation. It hits at age of 40, around 40. So remember, Shah Rukh Khan says that life begins at 40. But I say that presbyopia also begins at 40. Okay, so where the amplitude of accommodation becomes 4 diopters. Remember, normal accommodation when we are born is somewhere close to 15 diopters, or almost close to 15 diopters. Slowly, we lose 15, becomes slow. And at your age, my friends, most of you around 25, you would have around 10 diopters of accommodation. At your age, which is so tender, which is hardly an age at all, you would have 10 diopters. You've already lost around 5 diopters. And slowly as you reach 40, it comes from 10, it comes down to 4 diopters, at which everything near activity becomes impossible. You'll have to hold everything like reading, writing, stitching, and everything. Now that is no way to live. So you have to give convex lenses again to make the rays focus on the retina. It's not. See, presbyopia is like this. The distant rays are fine. The distant rays are focused right on the retina. It's the near rays which are divergent, which I told you. So they become parallel later and focus later. It's not. Initially, you had accommodation, you could increase the power of the lens, but now you are presbyopic, you have no longer accommodation. So how do I get the rays on the retina? Only by giving you kind of lens, which is convex lenses, will focus them on the retina. Converging. Remember, presbyopes also wear convex lenses. But then how to differentiate between presbyopia and hypermetropia? Remember, hypermetropia also wear convex lenses, so do presbyopics. Remember, age makes a difference. Presbyopia is only after 40 and beyond, okay? So none of you can be presbyopic. But hypermetropia has no age. Children are hypermetropic, you could be hypermetropic, I could be hypermetropic. Hypermetropia has no age. Presbyopia is people older than 40. So loss of consciousness with age. So that is the first thing. The age will distinguish between hypermetropia and presbyopia. So the problem is blurring of vision at normal reading distance like this. All these patients will have to read all the newspaper, books, and mobiles as she's doing it at this level, which is of course makes life very difficult. Okay, blurring of vision, and it is kind of convex. As I said, I have this question which I'll discuss when we come back. Convex lenses, and then so this is a slight idea to give you about the approximate idea how we give you addition at age. So it begins at 40 with plus 1, at 45 becomes 1.5. Remember convex lens, so they're 1 plus. At 50 it becomes plus 2. At 55 it becomes 1.2.5, beg your pardon. 60 it becomes 3. Okay, so you don't have to memorize this table, you have to remember this. Just remember this particular figure which has been asked sometimes. What is the approximate correction of presbyopia at 50 years of age? This has been asked sometimes because 50, remember, is a landmark age, half a century. So remember, all our parents, all your parents are presbyopic. They are 50 plus, they all read reading glass. Okay, but you guys don't read reading glass. You are only either myopic or hypermetropic or astigmatic. This presbyopia, and they're corrected by glasses. So if you are emmetropic, then that's fine. You give them convex lenses. But if what happens if you are a myopic or a hypermetropic or astigmatic, then you already have glass for distance, and you now have near at 40. So you have to wear a bifocal. These bifocals. Okay, so we have two different lenses. The top segment is for distance. It could be myopia, it could be minus. Hypermetropic will be plus. Astigmatic will be cylindrical. But the near is always plus, because near is at the bottom lens. We hold our eyes like this and read like this. So the reading glasses are fixed at the bottom. So these are bifocals. It's a combination of two different lenses, one for distance, one for near. Okay? But bifocals are for refractive error, but this is not a very good idea because it's a very old technology. So nowadays we have these lenses called progressive lenses, where you have three zones: one at the top, one in the middle, and one in the bottom. The top zone is for distance, for driving. Look at that. You can see the top zone is for the sky. The middle zone is for intermediate, laptops. Look at the middle zone. You can see here the boats here, and the bottom zone is for reading, like this, for reading newspaper. So you have three zones, but they blend in each other seamlessly, progressively. There's no cut here, is not. So these are the progressive lenses, the most recent advances in presbyopia. Bifocals used to be very old technology. Still many people wear it, but they have been replaced by progressive. And by the time you guys become presbyopia, of course, there will be some new other technology. So this is what it is, and dark room. But we'll take a tea break, and after tea break, I've got a question here: differentiate between the rule, without rule, astigmatism. So we'll take this question as soon as we come back after a 15 to 20 minutes maximum. We'll take a quick tea break because I know that you guys are getting tired. I think it's better to take shorter intervals with smaller. 15 minutes is fine with us. Thank you very much. All ladies and gentlemen, let's start again. All of you ready? Ready, Akila? To my Tamil friends, Tayaru. To my Telugu friends. And we're back again to bore the hell out of you. So I have this question here, Raja Charan Chani, who says how different between with the rule and without and against the rule estimate. Okay, so we have this, remember, called with the rule estimate, WTR, and against the rule astigmatism. Okay, with the rule, against rule. And this is kind of astigmatism. This is sometimes asked. It depends on the, see, we have two kinds of curvatures, you know, in a real life. If you see, if this is a kind of a surface where with the rule is defined as a surface where the vertical curvature, remember, vertical is more curved than the horizontal. Okay, like a rugby football, like this. If you say American rugby football, it's like this. If you see, the vertical curvature is this one and the horizontal curvature is like this. If you see this, the vertical curvature is slightly more curved and the horizontal is slightly flatter. This is a surface which has with the rule astigmatism. But we also have, we call it with the rule, with the rule. Why? Because this kind of astigmatism is more common in the real world. In the real world, these are curved surfaces which are more common, where the vertical curvature is more than the horizontal curvature. So like American football, rugby football. That's why it's called with the rule. This is the kind of astigmatism seen in younger people up to 50 years of age. Okay? After 50, the cornea flattens, and we develop this called against the rule. Against the rule. We call it against the rule because it is less common. Okay, and it's in older people above 50 years of age. Okay, what's the definition of against the rule? Definition of against the rule is exactly the opposite. With the rule, the vertical was more than horizontal. Against the rule is horizontal is more than the vertical. Here, the horizontal curvature, if you see, is more curved and the vertical is flatter. This is the typical shape of an egg. You know, if an egg, if you balance it like this, you see this surface. Now look at this. Here it is obvious that the horizontal surface is more curved and the vertical surface is flatter. Okay, so this is the basic definition. With the rule means vertical more than horizontal. Against means horizontal more than vertical. Okay. Now, so we now know why it's called with against, because simply it's commoner in younger people with the rule, against the rule, and is older thing. Now, how to recognize the astigmatism is, remember, in with the rule, when you want to see, you have to check whether, and I need with the rule, remember, you will have a plus cylinder at 90 or a minus cylinder at 180 degree. This is WTR with the rule. Okay, you have to memorize this with the rule, because to neutralize this kind of an astigmatism, we need this kind of a plus cylinder placed at 90 degree or a minus cylinder at 180 degree is with the rule. Okay, so that means what? Suppose I have an example of a plus 1 diopter cylinder at 90 degree. Now, if you look at this astigmatism, plus 1 at 90, so this is a example of a simple hypermetropic astigmatism, because plus and it's at 90, so plus 90, this is an example of with the rule. Okay, or it could be minus cylinder at 180. It's the same thing. Okay, it's minus at 180 is the same as plus 180. Like what? Suppose we have a minus 2 diopter cylinder at 180 degree. Now you see, it's a minus 2 diopter cylinder. If you look at this, this is a simple myopic astigmatism because one single minus, and because minus sign at 180, so this is also WTR. Okay, so remember, this is how we memorize this. With the rule is plus at 90 or minus at 180, and against the rule is exactly the opposite. Against the rule would be opposite. You have to give it, and against the rule you will have minus at 90 or plus at 180. Okay, this thing you have to memorize. You should not forget this, because otherwise it will, if you want to know this is what it is. So against the rule, let me go back and find place. So ATR is minus at 90 or plus at 180, and WTR is plus at 90 or minus 180. Okay, so any of this will fulfill criteria. Now you take any simple, suppose I give you a compound minus 2 diopters fair with a minus 3 cylinder at 90. Now so look at this. There are two minus signs. So this is a compound myopic astigmatism, but also you see this is a minus cylinder at 90, is not? So minus at 90 is an example of against the rule. That is the way it is. Okay, so can you remember plus at 90 or minus 180 with the rule, and just reverse it. Plus becomes minus at 90 and minus becomes plus at 180. That's all. If you can manage to memorize WTR, just convert this. Plus at 90 minus 180. exactly opposite is ATR, minus 90 plus 180. Okay, this is astigmatism, and these are different types of astigmatism which exist in younger people and older people. Less than 50 is usually with the rule, and above 50 is usually against it. Okay, so this is what it is. That can be asked another, but remember these are again mostly questions of NEET PG and NEET. Okay, so I hope that makes this, you may understand that, Rajuchan. And so next we go to, once we have done that, DRP, dark room procedures. So dark room procedures are a set of 4 procedures which you do in dark rooms. Okay, what are the? Retinoscopy, distant direct ophthalmoscopy, direct ophthalmoscopy, and indirect ophthalmoscopy. These are the 4 ones. So in a dark room we do. Ophthalmologists, we love dark rooms. Okay, not because of any other reason which you might think of, the juvenile minds might think of, but because in a dark room, because the pupil dilates more, so we get more details of the retina, and because there are less reflections from the cornea. So you will find that most of the good ophthalmologists, whenever we examine you, we switch off the lights. Okay, because in the darkness, pupil dilates more, we can see more details of the retina and less reflections from the cornea. There are 4 of them here: retinoscopy, distant direct, indirect, of which the most important is retinoscopy. Retinoscopy, remember, is a misnomer. It's got nothing to do with the retina. Okay, what is it? It calculates the power. Somebody is asking me, do we get how to calculate the power? Remember, we've done myopia, hypermetropic astigmatism. But how do we calculate that? How much you are myopic? How much are you astigmatic? How much are you, hypermetropic? So this is with retinoscopy. And retinoscopy, therefore, let's look at that, also called as skiascopy. This is for technique for objective measurement of the refractive error of the eye. Okay, objective measurement. Like we don't have any machines for that. We have to do it ourselves. And this is the objective refractive error, who is myopic, hypermetropic. Remember, not presbyopia, because presbyopia is not a refractive error, it's a quality of aging. Okay, how do you do that? We take a retinoscope and perform at 1 meter distance. That is your MCQ. Perform at 1 meter distance, and then because you perform at 1 meter distance, so you have to subtract the power that you introduce, which is 1 diopter, from the final retinoscopic power. Okay, because you were done at 1 meter, and because you stand at 1 meter, so introduce some extra power into the eye. So we have to subtract that power from the eye, which is usually 1 diopter from retinoscopic reading. And also, if you use cycloplegic drugs, I will mention this, you subtract for cycloplegia also. Okay, so we'll do that. So what for that? We need retinoscope, and retinoscope, you streak, you move it from side to side. So you have a retinoscope, something like this, an instrument like this. It has a light. The light comes out of this. I put an eye, and you will be able to see a reflection from the eye like this. Okay, and we move the retinoscope from left to right like this. The light comes out. It falls on the eye, patient's eye, who's standing at 1 meter away, reflects from her pupil, and I can see this retinoscope reflects like this. And what you do, you move the retinoscope from left to right, as I mentioned, and up and down like this. Okay. Here you need to know 2 things. First of all, you draw a power cross like this. Okay? This is called a power cross, okay? Because you calculate the power from this cross, and you have to remember the mnemonic SPAM, spam, not that terrible spam which clogs your inbox every day. This stands for same plus against minus. Same plus against minus. So what you do, you stand 1 meter, take a retinoscope and move the retinoscope like this, and you will find that in the patient's eye, there's a reflection of this light, coming from the pupil. So supposing I do like this, and I find the reflection is going opposite. See, it's moving like this. Now you see this is moving opposite, so it's opposite also called against. So against movement, look at this. Against means minus. SPA. It stands for same plus against minus. So this is going against, so it means minus. So from my box of lenses, I pick up the lenses, the least power of -1 is -1. Place it in the eye, retinoscopy, and again I keep on doing it till it neutralizes. Supposing neutralize at -5 here, and similarly I do the same thing in a vertical retinoscope. I do like this, and again it's opposite movement like this. So -1, -2, -3, -4 till I neutralize it. Neutralization means how? The reflection disappears. You can see it here. This is the spam against minus. Watch the pupil, light reflects in the pupil of the patient, whether it's with or against the movement of retinoscope, which I am moving like this. And same plus against minus. And so you would see it here in this picture. Look at that. The first is against movement, this one, which I mentioned, that when I am moving my retinoscope here, the reflection in the patient's eye is going there. It's not. This is against minus. So this is what I was telling you. I keep doing this, I get a -1. So -5, suppose both of them I get it. If I get -5 in both, So that means it's sphere, is it not? Because it's a sphere. Remember, sphere has the same power in all the meridians. This minus 5 translates to a power of around minus 5 diopter sphere. But remember, this is not the correct, this is not the final power. This is not the final power. Why? Because you have stood at 1 meter and reduced 1 diopter extra power. How do I know 1 diopter? Because by formula, the class 12 formula, which you all remember, power is 1 by focal. Because I have stood at a focal length of 1 meter, so 1 by 1 is 1. So this is the 1 diopter extra power reduced in the eye by standing close to the patient. So this subtract power 1 has to be subtracted, the extra subtracted. So minus 5 minus 1 is minus 6 is the final power. Okay, this is how retinoscope is calculated. Similarly, let's take another example. Again, I stand 1 meter away from the patient, start doing retinoscopy. I move it first side to side and move it top to bottom. Okay, and this time, suppose I watch as a light reflects in the pupil. I see, supposing as I move it like this, it moves like this. It moves like this. So they're moving in the same direction. Not this is called same movement. Remember, same means plus, same plus, and it would look like this. Look at picture B, where it's called with movement or same-sided movement. Where here I'm moving the retinoscope here, and the reflex is also moving there. Okay, so and neutralize means that the entire eye, the reflex fills up with light. So that is how when I know the power has been neutralized. So suppose I keep doing this in the, now I get a with movement, no? So I get a plus power, SPAM. So I draw the power cross, and same means plus, so I pick up the lowest possible plus power, plus 1. Keep on doing it, still moving same, plus 2, plus 3, plus 5, plus 6, plus 7. It's still moving. At plus 7, it stops moving, and the entire pupil fills up with light, neutralized. I plus 7 here, plus 7 there, let's say, also by vertical elastic. Again, because they are same power in different meridians, it means it is plus 7 diopter sphere. It's a sphere having the same power in all meridians. But again, you have to subtract from 1 diopter because you have stood at 1 meter away. Power by 1 by focal length, 1 by 1 diopter subtracted from this. So plus 7 minus 1 plus 6. And this is the final power. Okay. Astigmatism, in astigmatism, you will have 2 different powers. So you will have minus 3 here and minus 5 there. So they have different powers in different meridians. This tells you astigmatism. So this is retinoscopy, and this is how we will do it. So kindly remember the important things here. With against movement, remember same plus against minus, keep on doing it till you subtract 1 diopter, whatever. Remember, suppose the distance is different, Suppose sometimes they give you a 50 centimeters distance. Suppose your power is minus 5, but you've done it 50. Sometimes to make it more difficult for you, they don't give you 1 meter, they give you 50 centimeters. Doesn't matter, it's the same thing. So this is minus 5 is a retinoscopy at 50 centimeters. So we have to subtract the power according to standing at 50 centimeters. Power is 1 by focal length. Remember, 50 centimeters first convert into meters, like simple basic physics and maths, SI units. 50 centimeters, half a meter. So 1 by half a meter. 1 by half means 2 by 1, is it not? So 2 by 1 means 2. So this is the power to be subtracted. So minus 5 minus 2 is minus 7. You understand? So if you stand closer to the patient, you subtract more, because by standing closer, you reduce more power simply by standing closer and making him accommodate. So you see, at 1 meter we subtracted 1, at 50 centimeters subtracted 2. So it's basically the same formula, power is 1 by focal length, and that's how subtracted. This is called retinoscopy. This is enough for you guys. You should be able to answer this. Sometimes we use, look at this, for cyclopedia, I mentioned this. Sometimes use atropine, homotropine. Then you have to subtract another figure, because that is the sum for the cyclopedia. For atropine, because the strongest drug, we subtract 1 diopter. For homotropine and cyclopentolate, we subtract around 0.5. This is not so important for you, but I'm telling you just to complete the slide. So this you will only subtract if it is mentioned. If it's not mentioned, you won't subtract. Okay. So supposing that in this case you get retinoscopy finding, as I was mentioning this one, let's look at this. Suppose you get retinoscopy say of minus 3 and minus 3, and the question is at 1 meter with atropine. So minus 3 minus 1 meter with atropine, another one is minus 5 again. Okay, so it depends. If you mention atropine, subtract 1. If they have not mentioned, don't subtract. Similarly, if they mention the distance, subtract. They don't mention, don't subtract. And it depends on the distance. 50 centimeters would be 2 subtraction, 1 meter would be 1 subtraction. Just make 1 by half. Okay? That's retinoscopy done, and that's enough for you. I know there's too much maths here, and many of you are already keeling over, expiring of boredom. So we will skip this and go to the next topic, which is the distant direct ophthalmoscopy, DDO. Okay, so here you use a different instrument called a direct ophthalmoscope. Remember, but it's at a certain distance. Okay? It's not 1 meter. What is the distance? This is about, and try a direct ophthalmoscope. First, the instrument changes. It's not a retinoscope. With a direct ophthalmoscope, you use two investigations, DDO and DO. Okay, so we'll talk about DO later, direct ophthalmoscope, and the distance is approximately about 25 centimeters. So you see, this is the direct ophthalmoscope, and the patient is about 25 centimeters away from the patient. Okay, not 1 meter. And she looks through this, the light falls into the eye, reflection, and you get a bright red glow. So from the pupil, the patient with the DDO, you'll be able to see a real inverted and the same size image. This is not so important for you. The image will be same size, real and inverted. Physics questions. So what you will see in a normal eye will be a bright red glow. In a red glow, in a normal healthy eye. All of you should have a red glow when I see it. But if it's not red, there's a problem here. Like what? If you have a retinal detachment, you get a grayish glow. Look at that. Can you see the gray glow in this eye compared to reddish glow in this eye? In the right eye, it's red glow. This is normal eye. But in the other eye, it's grayish glow. This is retinal detachment. Okay. If you have a vitreous hemorrhage, bleeding in the vitreous cavity, then you have a no glow. Then there's no glow. Okay. And remember 3 different MCQs. Just by standing into 25 centimeters, looking at the retina, and you see the reddish glow coming out, as you saw. In a normal eye, a red glow, in a detached eye, grayish glow, and no glow. In a vitreous hemorrhage, nothing glow. It's completely dark. This is one of the important inferences, conclusions of distant direct. What else does it help in distant direct? In picking up a dislocated nucleus or a lens. A cataract which has got dislocated can be seen. Once, suppose you get a trauma and the lens dislocates into the eye, it's very difficult to diagnose it, because slit lamps cannot see it, torches cannot see it. The best way is to look through a DDO, distant direct ophthalmoscopy, which will pick up the edge of the lens like a dark crescent. Okay, so this is a question can be asked: what is the best technique to detect a dislocated lens or a subluxed lens? Would be a DDO, distant direct ophthalmoscopy. What else can we use? We can use in the Charlot's oil droplet sign to detect keratoconus. Please remember, so this is the oil droplet. You stand at 25 centimeters, look into the eye, and in the healthy reddish glow, you will see this glowish hair, the oil droplet sign of keratoconus. Kindly remember, don't confuse this with the oil droplet cataract of galactosemia. It's not. So these are the multiple use of distant direct ophthalmoscopy, where you take a direct ophthalmoscope, stand at 25 centimeters away from the patient like this. That's DDO done. Now the next is DO, where we take the same instrument, but we come closer to the patient. That's why it's called direct ophthalmoscope. It's not distant anymore. In direct ophthalmoscope, you come very close to the patient, almost noses are touching, and you see that. The same instrument, very close to the patient, almost touching the eyes and the nose. And what you're seeing here are you're seeing the 3 structures in the center of the retina, which is the disc, the fovea, and the macula. This is not the disc, the fovea, and the macula. This is what you're seeing. The center, 3 structures of the central retina. Okay, that's what you're seeing by coming so close. And you get an image called virtual erect image, VEM. Sometimes they like to ask you, particularly for NEET PG and for NEET, virtual erect magnified image. Okay, and because magnified, so how much magnification? 15 times. Can you remember? This is important MCQ always ask, how much does the direct ophthalmoscope magnify? Almost 15 times it magnifies the image. So these 3 questions are important. Direct ophthalmoscope takes the instrument closer to the patient, very close, sees the disc fovea macula, sees the image, a virtual erect and magnified, and it sees a magnification of 15 times. Okay, that's direct ophthalmoscope. And then the last invention is the indirect ophthalmoscope, where you make the patient lie down. Okay? The field of view sometimes is asked in NSET is very small, only 5 to 10 degrees. Only about 5 to 10 degrees. You cannot see too much of it, only see 5 to 10 degrees, but you get a magnified image of 15 times. So that it's a trade-off. Always you will, whenever you see a hugely magnified image, you will see a small size. Then we come to indirect ophthalmoscopy, which is an instrument which you wear on a head. It's a binocular head-mounted thing. You put it in both eyes. Patient is lying down. Remember, indirect ophthalmoscopy is done with the patient lying down. Okay, it's done with the patient lying down here, which can see here, and like this, indirect ophthalmoscopy, right? And you can see what is this indirect ophthalmoscopy, and with head mounted binocular lens matters. We can see here, gentlemen, and again it looks a little familiar to me. I wonder why. It looks familiar. So wearing a head mounted direct ophthalmoscopy, patient lying down, the lens light falls from here into the lens and through the condensing lens into the retina. The patient has been dilated already. It gives you RIM, that was VEM. This is memorized as RIM, real inverted magnification. So again you get an image, but it's inverted. So you have to calculate what appears superior is actually inferior, what appears inferior is actually superior. Okay? Inverted magnified, but magnification is only 5 times. Please remember, unlike the 15 times of magnification in direct ophthalmoscopy, indirect is only 3 to 5 times. Just remember 5. Why? Because you're standing far away, so it gives you a very wide range. Okay, what you can see structures right up to the ora serrata. Right from the disc to the ora serrata, you can see gives a very huge range of image, but the magnification is less. You cannot have everything. You cannot have the range as well as magnification. Is not. You can remember when you want to see the central retina in great detail, as in glaucoma, where you want to see the disc, optic disc, so you use direct ophthalmoscope. When you want to see the periphery of the retina, as in retinal conditions, you do indirect ophthalmoscopy, okay, because up to ora serrata. So you have to know when to use it, what is the image quality, what is the magnification. With ora serrata up to the peripheral retina, you'll be able to see indirect, but not with the direct. Okay. So these are the questions that we have, the DRP, and with that we move to the next topic. I'm going to slightly faster up, ladies and gentlemen, as the afternoon falls into evening. I find that more of you are collapsing and leaving this. We don't want to tax you out. We want you to finish, as I said, short and sharp. Okay. So we want to be here as much as possible. The retina vitreous is the next thing that we have here. Let's do retina vitreous. So retina, first of all, a quick, remember retina has 10 layers. First 9 layers are neurosensory and the 10th layer is RP, is not neurosensory. So if you look at the topography, you will remember that this is the lens. This is the first 9 layers. You don't have to memorize all 10 layers. Life is too short for that. By that time you memorize all 10 layers, life would be over. Okay, so the 10th layer is called the retinal pigment epithelium, and the first 9 layers are called neurosensory layer. This is the vitreous cavity here. Okay, and then after the RP you have the choroid, and then you have the sclera at the back, right? So this is the topography. This is how retina looks like. 10 layers, first 9 neurosensory. And then the blood supply, you need to know the blood supply. The retina has dual blood supply, and the inner 2/3 are the central retinal artery, supplied outer 1/3 by the posterior ciliary artery, which is also supplies the choroid. The inner 2/3 means from the vitreous side onwards. So from here till here would be inner 2/3 supplied by the central retinal artery. Please remember, outer 1/3 by the posterior ciliary artery, which also supplies the choroid. Yes, because, and the watershed layer is the boundary layer. You know, watershed is a term which you may have heard in medicine and surgery. Is the boundary at which the boundary of this here where the two circulations separate. Okay, so inner to this watershed layer is supplied by the central retinal artery, outer to this layer by central posterior ciliary artery, and this layer is called a name called the OPL, outer, not the IPL, but the OPL, the outer plexiform layer. You have to remember the OPL is the layer which is watershed, divides the circulation into two. The inner 2/3 from the OPL inwards is the central retinal artery, outer 1/3 is the posterior ciliary artery. Okay, very well. The next thing about is the retinal detachment. The first condition about retina is retinal detachment, which means separation of the neurosensory layers from the RP. Okay, remember the distinction, the definition is very simple. All 9 layers have to separate from the 10th layer. Right? Remember, you cannot have separation from the first from the second from the third. That is not detachment. If separation within the neurosensory layer, then we call it retinoschisis. First layer from the second from the third from the fourth. But all 9 layers separate from the 10th layer is retinal detachment. Okay, and the symptoms: floaters. You get the black spots floating in front. You have flashing of light. Okay, and a final is curtain-like sensation descending in front of the eye. It's not floaters, flashes, and curtains, descending in front of the eye, completely blotting out all vision. It's a sudden, painless loss of vision. And diagnosed by the, remember what I said, the normal level have a red glow. In this case, you will have a grayish glow. You will have a grayish glow. Okay, this gray glow. You can see the grayish glow here. Remember. So this grayish glow is a sign of a retinal detachment. Very simple to diagnose if it's not very shallow. You diagnose detachments and then we classify it into three types of detachments: regmatogenous, which is the most common; fractional, less common; exudative, least common. We focus mostly on the regmatogenous. Regma. The word regma means a break. There's a break in the smooth surface of the retina called regmatogenous. This is the most common type of detachments. Second is fractional. Third. We'll focus on regmatogenous first. Regmatogenous detachments may, let's talk about, there's a break in the retina. Okay, regma. Why? Caused by the most common cause of myopia. Second is cataract surgery. Third is trauma. Remember why myopics, many of your myopics, why should we have a detachment? Because you see, as eyeball is larger in a myop, remember 1 millimeter extra, 3 diopters. As the eyeball gets larger and larger in a myopic, what happens? What happens is the retina becomes thinner and thinner and thinner as it stretches to cover up the expanding eyeball. So you see, the retina is like a thin tissue paper at the back of the eye, is it not? What will happen as the eyeball expands? There's pressure on the retina, so it thins, and as it becomes thinner and thinner, and one day it will crack like that. This is a retinal detachment. So remember, those of your myopic have thin retinas, and the higher the myopia, the thinner the retina. And high myopia, remember I told you, is more than -6. So anybody who's wearing -6, the retina is thinned out, and those who have higher than that, 8, 9, 10, 12, the danger is even more. Okay, so higher the myopia, thinner the retina, and the chance of detachment is higher. And typically, what are the typical regmas or a break in the retina? It could be holes, which are small holes in the, you cannot make out that your holes. Lattices, which you see here, these fine lines in the retina, they're called lattices, which again cause a break, allows the vitreous to go over. Tears, particularly a horseshoe tear, a tear shaped like a horseshoe, which is the most dreadful of all. The most dangerous is a horseshoe tear. Multiple lesions occur in myopics. Okay, they occur because of the pulling of the eyeball, and it becomes thinner and thinner, and suddenly one day the retina detaches. So sudden pain is loss of vision, which can be preceded by floaters and flashes, but sometimes just loss. So remember, a very important question. Remember, myopia, the most common side effect of ocular or ophthalmic complication of myopia is retinal detachment. And remember that myopes can have other problems also, like open angle glaucoma also. But the single most common complication of myopia is retinal detachment. The MCQ will ask like this: a young myopic presents you with sudden floaters and loss of vision. That is enough for you to diagnose retinal detachment. Myopic patient presents you with sudden floaters and loss of vision to diagnose retinal detachment. Okay? Loss of vision, and the most common site is the supratemporal quadrant. Can you remember? Superior and outer. Superior and temporal quadrant is the most common site of the retinal detachment. And the famous Schaeffer's sign, as you can see, Schaeffer's sign is tobacco dusting of vitreous. You can see there against the vitreous, you can see these black dots floating around. You can see them in the vitreous. They look like tobacco dust floating in the vitreous. This is called as tobacco dusting vitreous, and this is the Schaeffer's sign. And remember, in retinal detachment. Okay? So this is retinal detachment, and then we go to the next kind of exudative detachment, where exudation means there is exudation of fluid. Okay, so any condition of the eye which produces a lot of fluid, okay, leads the two layers to separate. It's called exudative detachment. Examples: there's no breaks in there, there'll be a fluid there, which you can see the fluid, like malignant melanoma of the choroid, okay, which is one of the most common causes. Remember, malignant melanoma is also the commonest tumor of the eye in adults, is it not? It's the commonest tumor of the eye in adults. Commonest tumor of the eye in children is retinoblastoma. Or PIH, pregnancy-induced hypertension. PIH stands for pregnancy-induced hypertension, which you know, blood pressure rising by more than 140/90 after 20 weeks of pregnancy, and choroiditis inflammation. These are three most common causes where there's a sudden exudation of fluid, separates the two layers, causes detachment. Most common question asked: a lady in her third trimester complains of sudden painless loss of vision. I said trimester, not semester. Many of you are getting worried, you're in the third semester also. No, I said trimester. Sudden, a young lady in her third trimester comes to sudden painless loss of vision is most likely due to exudative retinal detachments. Pregnancy, you may become blind because of exudative retinal detachment. It's not very common, but it's again the subtle painless loss of vision. Typical characteristic of exudative lens is shifting fluid. Remember, because there's a lot of fluid there, it shifts according to position. So when you sit up like this, so the fluid will go by gravity, go down inferiorly and keep separating layers of retina. So inferior detachment is the most commonly seen when the patient is sitting up. When it's lying down, the fluid will shift back and the retinal detachment will go in the posterior half of the retina because the fluid gravitates down and separates the layers there. So you will see shifting fluid causing shifting areas of detachment. This is the well-known characteristic of exudative retinal detachment. Okay? Sudden pain loss of vision, but not very common. The third one is tractional element, which means something is pulling the retina off the neurosensory layer, like particularly some membranes or some fibrotic stuff, or some membrane pulling the life like this, pulling it off the neurosensory layer. The most common cause is diabetes. Kind of remember, number one cause of exudative lens is diabetes, but you can have sickle cell anemia and retinopathy of prematurity also. Okay? Sickle cell anemia, ROP. So the commonest cause of traction is diabetes, please remember. But commonest cause of rheumatic is myopia. And retinopathy of prematurity is a condition where children are premature and they have these membranes which pull the retina off and they may become blind. This can be asked as an MCQ. What is the most common cause of loss of vision in a premature baby? Retinopathy usually occurs if the child is premature, is less than 32 weeks. 37 is maturity. So 5 weeks earlier and less than that also, 31, 30, 29. So more the prematurity, more the chance of ROP. Remember, the most common cause of loss of vision in retinopathy of prematurity is going to be tractional retinal detachment. But you have sickle cell anemia and diabetes, and it is, remember, it's a slow pain loss, unlike the other two detachments which were exudative and rheumatic, which is sudden loss of vision. This is slow pain. So finally, remember, this is the only detachment with slow loss of vision. Okay? They're all painless, but this is slow, the other two are sudden. We've done the 3 detachments. What is the point? We have to reattach them again. The whole thing is to reattach them back again. The aim of detachment is to attach them. Why is that? Because you see, if we do not attach them back again, the retinal pigment epithelium is responsible for a lot of supplying a lot of nutrition, oxygen and glucose to the neurosensory layers. So if they do not attach them together, within 48 to 72 hours, the rods and cones start dying out. That is why it's essential to get the 2 biretinas into position ASAP, as fast as possible, as soon as possible. In rheumatogenius, we do this surgery called buckling, where we place a silicon buckle on the sclera. It forces the 2 retinas together. Or we can do laser photocoagulation, take laser beam, close the holes, which is leading to the detachments, the holes, the lattices, and the load and the horseshoe. Okay, so this is laser in exudative detachments. Remember, there is no particular medicine or surgery as such. Treat the underlying cause, which is causing the producing the fluids, is it not? Which is producing the fluids. Yeah. So what is that? Like, so you treat the underlying cause. So if it is choroiditis, treat the choroiditis with systemic steroids. The fluid will absorb, and the retina and the detachment will combine back into position. Or if you have melanoma of the choroid, treat the melanoma. The fluid will absorb, and the retina will fall into position. If it's pregnancy or hypertension, treat the hypertension. For God's sake, don't treat the pregnancy. Treat the hypertension. The fluid will absorb, and the retina will come back together. Okay, so we treat the underlying condition. It is the tractional which causes the maximum problems. Okay, because of the traction, those membranes are there. So we have to cut all the membranes. So we go inside the vitreous, called vitrectomy, and remove all those. We shave these membranes. We tease these membranes off, so that we call it, it's vitrectomy, so that after later on they can't contract again and pull the retina off again. So vitrectomy is required for tractional detachment. Basically, the aim is to do it as fast as possible. Remember, the more you delay the attachment, the poorer is the prognosis. So the faster you do it, much better chance. So retinal detachment surgeries can be sometimes a bit of an emergency where you want to do it as fast as possible. That was an emergency, semi-emergency of retinal detachment. You can remember, all of you high myopes, those of you here, my friends, more than -6, -8, -12, -15. Be careful of retinas. It's too thin, so take care of retina. Have a checkup once every year. Retinal checkup, dilated retinal checkup once every year. Next is diabetic damage to the retina due to diabetes, the single most common vascular disorder of the retina. The single most common vascular disorder of the retina is, remember, diabetic patients flood our OPDs. You see 100 cases of retina in one day. you will see 75 or 70 cases will be of diabetics. The world's diabetic capital. Remember, we are the world's diabetic capital. At last count was almost 77 million diabetics. Okay? So this retinopathy, that is happens to retina, depends not only on the diabetes, so on what factors of diabetes, and the glycemic control. That means how good is your control, isn't it? If you have poor control, retinopathy will occur in 5 to 7 years. Good control will come in 10 to 15 years. Duration of diabetes. One of the most important things is duration. How long is diabetes? The longer the duration, more the chance of developing retinopathy. So for a patient who's had 15 years or more, chance of retinopathy become much higher. Less than 15 years, it is less. Associated hypertension. There are some other factors along with diabetes which cause damage to retina. This is with hypertension and hyperlipidemia. Remember the big three: diabetes, hypertension, hypercholesterolemia. If you have all three, then you're in big trouble. Okay? They all damage the retina. On top of that, if you're pregnant, then you've had it. Okay? So everything is over. Okay? So people remember, women who are diabetic, we always tell them to postpone their pregnancy if possible until they control the diabetes. If you have uncontrolled diabetes and you become pregnant, then you might lose vision, okay, because the hypertension, the diabetic retinopathy worsens like fire during pregnancy. So during pregnancy, we have to keep checking the retina. Okay? All these associated will damage the retina, and the typical sign is, of course, blurring of vision, but the most important symptom of retinopathy of diabetes specific is the fluctuation of vision. Remember, it fluctuates. In the morning, it's something else, maybe 6:6. In the evening, it'll be 6:12. In the night, it'll be 6:9. Okay, so it fluctuates, and it's so specific diabetes that many times we have diagnosed diabetes by taking history of fluctuation of vision. This is very specific for diabetes, and of course, you have blurring of vision, which is a non-specific finding. When do we screen such diabetic? On WHO, in a type 1 diabetic, WHO says that you screen it on the 5th year of it. So when you've detected on the 5th year onwards, you start checking the retina, and then once every year. Okay? It's no point doing it before that. Why? Because usually before 5 years, there's no retinopathy. These are insulin dependent, IDDM, and they have to be on insulin, otherwise they won't survive. And because they're always insulin, the sugar is under good control, so retinopathy does not occur before 5 years. That is the funda. But if you are a type 2 retinopathy, you have to check the retina on the day of diagnosis of diabetes, because type 2s are difficult to diagnose. You may have detected today, but the patient may have retinopathy since the last 10 years, is not? So you would already have retinopathy. So at the time of diagnosis, we must check the type 2 diabetic. Type 1, 5 years onwards. And then both of them has to be checked once every year. This is important to remember. Earliest ocular manifestation of diabetes is microaneurysms. New term for you, MA. We call it MA. This is the earliest sign of diabetopathy. The next thing is a quick word on the two stages of diabetopathy. You have two stages. In the first few years, usually about 10 to 15 years, we have this condition called as NPDR, which stands for non-proliferative diabetic retinopathy. Remember, the word proliferative means multiplying. So it is not multiplying, non-proliferative. What is not multiplying? There is no new blood vessels. You see, there are no new blood vessels in the retina here. Okay? That means no microaneurysms, no new blood vessels, new vascularization is not there. But you can have microaneurysms, you can have cotton wool spots, you can have hard exudates, you have IRMA. This is NPDR. This usually lasts for 10 to 15 years, and then it goes into PDR. Okay? And NPDR has three stages: mild, moderate, and severe, of which sometimes the severe NPDR definition has been asked. Sometimes we have to remember the 4-2-1 rule for diagnosing severe NPDR, where you can have microaneurysms in all four quadrants. Okay? And you have beading. This beading, we call it venous beading, where the blood vessels appear to be like beads like this. Okay, venous beading in two quadrants or more, and one quadrant of IRMAs, intraretinal microvascular abnormality. So if you have more than one quadrant of IRMA with more than two quadrants of beading and all four microaneurysms, then you fulfill the kind of severe NPDR. Remember the 4-2-1 rule. And then it goes into, after 15-20 years, the NPDR goes into PDR, proliferative diabetopathy. Why do you want to know whether the stage is NPDR or PDR? Because the loss of vision depends on what stage it is. In NPDR, remember, the most common cause of loss of vision is macular edema. That is what we have to treat. In PDR, it's called proliferative diabetopathy, which means new blood vessels appear in the retina. You can have two different stages, either on the disc, the new blood vessels appear on the disc, you got NVD, or it can occur anywhere else on the retina, you got NVE, neovascular elsewhere. Okay, so remember, as soon as you see the first new blood vessel, in the retina, it becomes PDR. It could be NVD if it's in the disc, or NVE anywhere on the retina. Okay, but in NPDR, remember, there are no new blood vessels. This is the stages of retinopathy. We need to know the stages because the loss of vision depends on retinopathy. Okay, the loss of vision depends. Like what? Therefore, in NPDR, remember, the most common cause of loss of vision is macular edema, but in PDR, then I have multiple causes of loss of vision, like vitreous hemorrhage, neovascular glaucoma, and fractional retinal detachment. Remember, all these big ones, these are seen in the complication of the PDR, is not complication on in PDR. So you can have vitreous hemorrhage or neovascular, which we talked about a short while back. Fractional retinal detachment, we just mentioned, the most common in diabetes, right? So this is loss of vision. So we have to find out what stage it is. And for the treatment of diabetes, first, of course, you have to control the underlying conditions. So treat the diabetes, the blood pressure, the cholesterol, get out of the pregnancy or whatever it is, and control the systemic conditions. Okay. Then for macular edema, remember, that's the most common cause of loss of vision overall in diabetic retinopathy, macular edema. Treatment of macular edema, there will be anti-VEGF drugs. Because again, VEGF is employed here. Anti-VEGF drugs like bevacizumab or ranibizumab or aflibercept is the drug of choice here in treating macular edema, the treatment of choice. But if it is PDR, remember this is NPDR, if it's PDR, then PDR means the new blood vessels already occurred, and then this is not going to help so much. So we have to do a pan-retinal photocoagulation. It means you take the laser and focus on the entire retina except for the center, which is called as pan-retinal photocoagulation. That's the best treatment for PDR. Okay? And remember, in NPDR, you will give anti-VEGF drugs. In PDR, you will do pan-retinal photocoagulation. The treatment, diabetes. Now we go to the next topic of the vitreous hemorrhage. And good evening, Dr. Vasant. I hope you're back to, some of you are back to the class. And remember, I'm going to try to make it as short and sweet as possible so they can retain the maximum. Vitreous hemorrhage, which is sudden bleeding inside the vitreous cavity. So it's a sudden painless loss of vision, the reddish tint to the eyes. Okay, you can see the blood clot here. Sudden pain loss of vision with sudden floaters, reddish tint to vision. It's very, a horror-struck patient who cannot imagine what happened to him suddenly. The most common cause is proliferative retinopathy. So again, diabetes is the most common cause of vitreous hemorrhage, but in young patients is most likely to be trauma followed by Eales disease. Okay, so overall, most common hemorrhage is PDR, which is proliferative retinopathy, but it could, in younger patients, could be trauma as well as Eales disease. You have this sudden pain loss of vision, and when we diagnose it, so how do you treat vitreous hemorrhage? Remember, first depends on the cause of cause. So if it's trauma, the treatment is different, Eales is different, PDR is different. But first, regardless of the cause, we treat the vitreous hemorrhage by giving the patient bed rest. So 3 months of relentless bed rest with the head end elevated like this, couple of pillows supporting the neck, the feet like this, so the blood trickles down to the inferior half of the retina, clearing the vision. Bed rest for 3 months, and during these 3 months, you treat the underlying cause, whatever is the cause. If it's PDR, fine, treat the cause. If it's trauma, treat the trauma. Eales disease, treat the patient in Eales disease with ATT. Okay, so treat the underlying cause and wait and watch for 3 months. Wait and watch for 3 months. Sometimes hemorrhage absorbs. It absorbs completely. There's nothing to be done. But sometimes when the vitreous hemorrhage is extensive, it does not absorb. Even after 3 months stays there, we can't do anything. We have to do vitrectomy. So 3-step treatment. Okay, first, bed rest for the patient. Second, treat the underlying cause. Wait and watch for 3 months. If it doesn't absorb, vitrectomy. Remove the blood and the vitreous together, which I showed you. This is the 3 principles of vitreous hemorrhage management. So remember, CRVO is the central retinal venous occlusion. Okay, very important condition. CRVO is central retinal venous occlusion. So here the vein occludes, the most important vein of the eye, which collects the blood from most of the structures, suddenly occludes like that, and which causing a sudden painless loss of vision, which the patient sometimes misinterprets as a voltage drop in the room. So typically they often complain, doctor, I feel the voltage has dropped in the eye. Dimming off room lights, as we say. So the site of occlusion is the most common site of occlusion is the one that is the usually where it enters the lamina cribrosa of the optic nerve. Okay. Suppose this is the optic nerve and this is the eyeball as it enters. This is the optic disc. In the optic disc, there is a particular structure called the LC, lamina cribrosa, because full of holes, cribrosa. And just behind this cribrosa is the central vein, which is coming out from the eye and leaving the optic nerve like that. So central vein just behind the lamina cribrosa optic nerve is the most common site of CRVO. What are the risk factors? These are often possibly not to be helped because they're old age. Most people they are above 60-65 years of age, and they have diabetes, hypercholesterolemia, hypercholesterolemia, blood pressure, and glaucoma. Okay, so the same risk factors, which most of them have. The uncontrolled diabetes and blood pressure. You can have hyperlipidemia, glaucoma, risk factors. Everybody has them. Okay. Without warning, the central vein suddenly blocks. Okay, it suddenly blocks like this. There are two different types of vein. One is called ischemic CRVO, which is luckily less common, and non-ischemic CRVO, which is more common. Ischemic and non-ischemic, remember. It is the ischemic that we like to ask questions from because this is the most dangerous one. The non-ischemic one is more common though. Remember, almost 75% of the CRVOs are non-ischemic. Here, there's moderate loss of vision, not too much, and blood vessels are dilated as expected. Retinal hemorrhages, all four quadrants, and the mild ischemic. This is for CRVO non-ischemic. 75%, but the benign form. It's the ischemic form which is the dangerous form, which we were so scared of. And the most common complicated non-ischemic CRVO is macular edema. Okay, non-ischemic macular edema, that's not much of a complication. What about the ischemic one that we're really scared of? Ischemic ones contributes only 25%. So out of 4 cases of CRVO, only 1 case will you see in ischemic CRVO. But we define it as more than 10 disc diameters of capillary non-perfusions. Remember, ischemia is lack of blood flow. So we find out a retina where more than 10 disc diameters. Remember, one disc diameter is 1.5, 10 to 1.5, 15 millimeters of the retina is present, where more than 10 is present of capillary dropout, where the capillaries are not nourishing the retina. So almost 10, if you would 10 diameter to 1.5 is 15 disc diameters, 15 millimeters, of retina does not have any capillary supply. This is called non-ischemic. And it's dreadful because all the questions, all the terrible findings of ischemic CRV are the ones we ask you. Remember, sudden painless loss of vision, we call it TVO, transient visual obscuration, sudden and painless sudden loss of vision, very similar to a dropping of the room lights. So they often said, doctor, the voltage drop has occurred. There's a drop in voltage. This is what happens. And this is ischemic CRV. Remember, and typically dilated tortural veins, your veins are dilated. The retina is full of hemorrhages, you can see here. Full of hemorrhages here, okay, all kinds of hemorrhages. You can see soft exudates, you can see flame shade hemorrhages, hard exudates, everything kind of hemorrhage you can see there. Dilated tortural veins, widespread cottonwool spots as we expect, RAPD, that is the relative ampule defect in the pupil, severe disc edema, you can see the disc edema, extensive hemorrhages called blood and thunder fundus, very Shakespearean, blood and thunder, also called as tomato splash fundus. Remember, it looks like you splashed tomato into the retina. So splash tomato fundus, disc edema, this is the most horrible retina you'll ever see. It's the most bloody. You cannot see blood like that. It scares the doctor also, let alone the patient. Okay, so this is all the tomato ketchup fundus. And in ischemic CRVO, you have this because remember it's an occlusion. The occlusion would lead to hypoxia. Hypoxia will produce VEGF. VEGF will cause neovascularization. Neovascular will cause neovascular glaucoma. So this neovascular glaucoma, which occurs after CRVO, usually takes about 3 months. And that is why it's called 90-day glaucoma. Okay? It's called 90-day glaucoma because it takes about 3 months to manifest. It can sometimes be called 100-day glaucoma also because it takes time to manifest. So remember, 90-day glaucoma is specifically neovascular glaucoma after CRVO. Okay? The ischemic CRVO, the severe loss of vision, a lot of capillary non-perfusion, at least 10 disc diameters. So all these are the problems of ischemic CRV, all of them ischemic. And so you have macular edema also as the most common cause of loss of vision. So remember, in ischemic CRV also, you can have macular edema, you can have neovascular glaucoma, and you can have, of course, transient visual loss. Multiple symptoms. And in CRVO, the treatment has to depend on the macular. Remember, the most common cause of loss of vision in macular edema in CRVO is the macular edema. It's not the hemorrhage, okay? It's the macular edema. So we need to treat the macular edema with anti-VEGF drugs, because remember, it's a CRVO. There's a lot of, the VEGF. So again, you have anti-VEGF drugs, which means that you have ranibizumab, bizumab, bevacizumab, or aflibercept. So you have to inject them into the cavity. This is the treatment of CRVO. And of course, you have to treat the underlying conditions like the diabetes, the blood pressure, and the cholesterol. You have to treat them. The specific ocular treatment is to get rid of the macular edema, which you give anti-VEGF drugs like ranibizumab or bevacizumab or aflibercept. Okay? This is the sad story of CRVO, where the vein occludes suddenly because of age, uncontrolled diabetes, blood pressure, cholesterol. So this is CRVO. Treatment is difficult. You have to control it. Next condition is CRAO, which stands for central retinal arterial occlusion, CRAO. And this is even more dangerous. The risk factors are the same: old age, glaucoma, then you have uncontrolled blood pressure, diabetes, cholesterol are the same, but the condition is totally different. The major ocular emergency with irreversible loss of vision, where you need treatment in seconds and minutes. And the main cause is uncontrolled diabetes, blood pressure, hyperlipidemia, and cancel arteries. Again, the same culprits as you see, the big three: the diabetes, the blood pressure, and the hypercholesterol. And one rare cause, giant cell arteritis, which may cause CRA also. We have to keep that in mind also, because it's not always at the back of our minds. And here is arterial occlusion. So the most common is a traveling embolus. Okay? An embolus, which is a clot broken off from the main clot. This embolus that travels through and blocks the CRAO is mostly called Hollenhorst plaque, okay? Because it's cholesterol, it's crystalline in color. In 30% of cases, you'll be able to see this also. And you see enters the dural sheath of the optic nerve. This is the most common site where is the narrowest part of this. If you see, this is the optic disc, and this is the eyeball like this. This is the optic disc here. So the narrowest part of the central artery enters the optic nerve here, and then it becomes thinner. Okay, so this is the part where you have the maximum chance of developing central arterial occlusion. You have the maximum chance of developing it here. Okay, this is one. And remember, it's most common is a cholesterol plaque. You can have other clots also, like fibrin, like calcium, but the most common is cholesterol, which is why it's called Hollenhorst plaque, specifically referring to a cholesterol clot, which is one of the most common clots causing CRA. Okay, and the narrow spine just behind the optic nerve and entering the optic disc, you find the central retinal artery, which is the narrowest part. And the most famous finding of ophthalmology is the famous cherry red spot around this macula. You see this whitish area where there's, because of lack of perfusion, so it's whitish, but surrounding the center of this whitish area is a bright red glow, which you see, and this is called as the cherry red spot. This is the diagnostic of CRA. The most famous finding of ophthalmology, possibly the cherry red spot, also accompanied by a cataract appearance or a boxcar appearance. What is that? This cataract or boxcar may appear either in the artery or in the vein. Okay, you see, if you've seen the blood in a vein, the blood in the vein moves sluggishly, and it moves smoothly. What happens? This is a normal blood, is not. But what happens in box scarring is that this blood column, it breaks into small segments. It breaks into small segments, and they move in jerks like this, like this, like this, like this. This jerky movement of blood column, which are not connected to each other, is called the cattle trucking or the box scarring appearance. This is a Western terminology, looking like cattle trucks, a wagon which used to carry cattle. So this is a very famous finding. We call it a finding which we call as the boxcar appearance. But the next question is the most important: how much time is there? And that is what many of you are wondering, how much time till the class gets over. But that is not what I'm asking. How much is the time left for the retina to die? Remember, the retina can only withstand hypoxia for 90 minutes. That's all. Called retinal ischemic time. After that, it cannot wait and it will die. So within 90 minutes, if you can return the ischemia, if you can restore the circulation, it will be fine. But after 90 minutes, it's reversible even after 4 hours. Okay, remember, we can do it even within 4 hours. If you can get the circulation back, we can save the retina. But there will be some damage. But after 4 hours, nothing can be done. It's irreversible damage. All these are experimental timings. Remember, within 90 minutes, no change. Within 4 hours, partial recovery. After 4 hours, no recovery. This is the importance of CRA. We need to know the time. And treatment is all based on emergency also. First thing is to ocular. Remember, the first thing always is to do 10 minutes of ocular massage. You push and release like that. Very safe. And sometimes you're lucky, it may dislodge the clot and the patient has this miraculous return of vision. Sometimes, but very rarely, you're lucky also. Ocular massage doesn't work. Lower the pressure with the fastest anti-glaucoma drug, IV mannitol or acetazolamide. How does that help? By lowering the pressure, it may start the blood flowing and it may wash the clot away. But the best treatment is reserved for the third step, which is called paracentesis, which is the highest success rates, where you take out the aqueous. You go through the limbus into the anterior chamber and take out the aqueous like that. Immediately the pressure plunges down and sudden loss of intraocular pressure, the same principle as mannitol, it may remove the blood clot. So paracentesis is at the limbus of the anterior chamber with a knife or a blade, and is extremely dangerous to the patient. Doesn't work, go to carbogen inhalation, a mixture of two gases. Carbon dioxide is 5% and 95% is oxygen. This is a mixture of two gases which the patient is inhaled. As it inhales, it allows the blood to dilate and give you some more time. Okay? This is called carbogen inhalation. Be careful of the percentage, 5% will be carbon dioxide. And after that, it doesn't work. Hyperbaric oxygen under great atmospheric pressure, aspirate to inhale. This will also work. And finally, if it doesn't work, you have to protect the other eye. Remember, one rare cause of Janssen arthritis is Janssen arthritis. One rare cause of CRA was also Janssen arthritis. If it is that, then you have to protect the other eye by giving systemic steroids, because Janssen arthritis can flatten both the eyes. Okay, can flatten both the eyes because of CRA. You have to give systemic steroids if the answer is Janssen arthritis. So these are the multiple ways to treat CRA, but most of the time they are often asleep. And by the time they come to us 4 hours over, there's nothing we can do. So it's rare and deadly. Okay? Rare and deadly. So this is CRA. Luckily for us, it is not very common. And the next thing is cystoid macular edema, CME. Remember, cystoid macular edema, CME. Do we have any questions? Okay, so we have this question. Good evening, Kanika. Good evening to you and to all of the rest of you who are still holding on to consciousness. Okay, so the question is here, Dr. Syed has asked this question. So how can we differentiate between CRA and CRVO? It has been, well, CRVO is very different. They are same people, of course, because the older people and all. But the findings are, remember, CRAO, first of all, is total loss of vision. It's hand movement. Okay, it's sudden dimming of, it's total dimming of room lights, total switching of room lights. Okay, CRVO is dimming of room lights. So they will have some vision, 6 by 60, 6 by 18. So first is the amount of loss of vision. CRVO is much more. CRVO is much less. Second is the finding that you find. Okay, in CRVO, the findings are, if it is ischemic CRVO, then you'll have a lot of problems. Like the tomato ketchup fundus. Okay, like neovascular or 90-day glaucoma. Okay, you'll have. If it's non-ischemic, then the findings are not so much. Okay, but in CRVO, you'll get a chair red spot. You will get a cattle tracking or a box cutting appearance, and the 90 minutes is there. Okay? So, and also remember that basically it is the degree. CRAO is far more dangerous this one. So, in the anterior segment, you will get a RAPD. You will get relative afferent pupil defect or a Marcus gun pupil because there is no blood at all. CRVO in the non-ischemic variety, there will be no RAPD. Okay? There are multiple ways of distinguishing. Please remember the findings: cattle track appearance, chair red spot, and box scarring is CRAO. CRVO is tomato ketchup fundus, or tomato ketchup fundus, also called the splash tomato fundus or blood and thunder fundus. They are different. Okay. Then, so I hope that makes it clear, my friend. And then again, so there is some problem of the voice. It seems any problem with the voice? Please check this. I'll just ask these guys to check it. And there is some, excuse me, there's some voice problems. And Satish, there's some, check the voice please. There is some problem with the voice here. Just check this please. Thank you very much. So next we go to CME, cystoid macular edema. Remember, edema is swelling over the macula. So, and it forms small cyst which you cannot see. So, there is swelling over the macula. So, immediately there will be a loss of vision, cystoid macular edema. And where is the macular edema? So, remember we have to first MCQ, it is exactly in the layer which called the outer plexiform. Remember that was the watershed layer, also called the Henle's layer, isn't it? It's also Henle's layer. So, it is in the outer plexiform layer, also called the watershed. That is where the fluid is. You have to know the level of the fluid in the 10 layers. Then it causes, what are the causes? Why should you have macular edema anyway? Well, there are multiple causes. The two most common causes is diabetes and post-cataract, which is the famous IGS. Remember Irwin gas syndrome? So diabetes and Irwin gas syndrome, diabetes we just talked about, where you have macular edema when we give anti-VEGF drugs. Okay. The second is Irwin gas syndrome, which is also very common. And so there will be loss of vision. Remember again, so this is macular edema, so loss of vision with a very important character of macular edema, which is called the metamorphopsia. Remember, metamorphopsia is distortion of shape. Look at that. So total loss of vision, and look at the distortion. All the straight lines appear distorted and irregular like this. This is how you will have macular edema as benefit. Can you remember, metamorphopsia means distortion of shape and is typically a sign of any macular disease, CME, CSR, ARMD, and you will have loss of contrast also sometimes. But these are the two most important: loss of vision, metamorphopsia. And then how do you examine it? On examination, you will find a yellowish spot in the macula. So the fovea number is actually a pit. Fovea is a depression like this. So you will not be able to see that, and there's a yellowish spot around that. That will tell you of macular edema, and you can see that here. Okay, this is we've outlined this here. This is the yellow spot around this, and it is you will see the contour is lost here. This is the yellow spot here. Yeah? So this is how we do a CME. This is how it's. The next thing after this, you diagnose CME. Then what about the treatment? Remember, CME treatment depends upon the cause of CME. Right? So remember, first of all, we need to do a fluorescein angiography (FA), and where we find the specific treatment. Remember the petaloid epithelial fibrosis. Remember CME, what is that? You have to do fluorescein angiography where you take the dye, the name of the dye, fluorescein angiography, the name of the dye is sodium fluorescein. Okay, that's the first question. Sodium fluorescein. You inject it in the antecubital vein. Second question. You inject in the antecubital vein here, and the dye goes from the vein in the cubit here into the retinal circulation. This takes about 8 to 12 seconds. This is called the arm retina circulation time, and it goes to retina. And if it leaks out like a flower petal or a petaloid appearance, then this is okay. So this confirms cystoid macular edema. And the treatment for Irwin gas, remember Irwin gas, I'm talking about Irwin gas, post-cataract CME, is topical steroids followed by topical NSAIDs and injection triamcinolone subcutaneous. First, try with steroids. This usually absorbs the edema, but watch out for glaucoma. Doesn't work, go to topical NSAIDs, non-steroidal anti-inflammatory drugs. Like you can have topical diclofenac, you can have flurbiprofen, you can have something else. And finally, if it doesn't work, it goes to injection triamcinolone. Injection triamcinolone means that you have to inject the steroid, the last stage, in the Tenon's capsule. So this is for CME for the Irwin gas. In diabetes mellitus CME, remember, we'll have to give anti-VEGF drugs. Okay, as I mentioned, anti-VEGF drugs in diabetes, like bevacizumab, it's something else. If there are any other cause, like retinitis pigmentosa, sometimes called CME also, then we give acetazolamide. Okay, so these are the multiple things, and hi Ajay, and we are heading towards another. Many of you, I can feel the boredom coming into creeping. We'll take a break, short break, another 15 minutes later. So hang on to your trial. Okay, it's just an exam, and everything passes by. You just have to hang on. Difficult times. I also tell myself, you people are having difficult time, but we also have difficult times, and we just hang on tight. They don't last. The difficult times never last. The tough times never last. We last. Okay. So the next thing, so we've done this. Acetazolamide is drug of choice if you have CME, retinitis pigmentosa. And the next thing after CME is a condition called CSR, central serous retinopathy. Look at that. So you have fluid. Serous means serous fluid again over the central, which is the macula. Okay. So remember, so both CME and CSR are fluid over the macula. The difference is in the level. Okay, in the level of the retina where the fluid is. See what happens. See, remember, this is the neurosensory layer, and this is the RP, is not. So this is the macula, let's say. So in CME, remember, the fluid is between neurosensory RP somewhere here. This I told you. This is cystoid macular edema, and the fluid level is, remember, is the outer plexiform layer. But CSR, the fluid is between the neurosensory and the RP. See, this is the RP, This is neurosensory. So in between is the so this is CSR and that was CME. You understand? The fluid is under the macula but at different levels. So the pathology is different. So CSR is under the macula. So the CSR is a type of actually localized exudative retinal detachment. So retinal detachment separate from neurosensory RP. Again, this one. So CSR is a type of localized retinal detachment which lies under the macula. So what are the causes? Why should you have CSR? Remember the causes of CSR. What is it? Remember typically the three main causes. One, these are people who are type A personality. You know type A personality, you've done your psychiatry. So type A personalities, you know, are people who are extremely anxious. Now the A is not for anxiety, but you can memorize this. Type A people are people who are extremely anxious. Not so they're extremely anxious people. So many of you are getting anxious about the exams, isn't it? So I must tell you that this is the time when many of the younger, because younger people between 20 to 45 years of age, they often land up with CSR. Okay, so let's look at the risk factors. They're typically type A patients, which means they're anxious and they're ambitious. Many of you are like that, anxious and ambitious. You want to score the exam and you want to do the best that life has to offer. So type A patients, this is one risk factor. Second is they have a lot of stress. Okay, again, stress, you have a lot of stress. And third is if you are on systemic steroids for any reason. If you are on systemic steroids, you know, for whatever reason, for bronchial asthma, for facial palsy, for rheumatoid arthritis, for any reason, if you are on systemic steroids, you may land up with CSR. Okay, so there are three main risk factors of CSR which develops. This is again not behaving very well sometimes. These causes, look at that, type A personality. Remember type A, ambitious and anxious. Okay, many of you like that. Stressed out. Remember, if stress leads to havoc in many conditions, not whether it's the liver or the stomach or the heart, but the stress, if there is one thing that the stress causes to the eye, it is CSR. Okay, many of you under stress, many of type A personality, and that is why often young students just before the exams land up with CSR and steroid use, the three main risk factors. Okay, so you have CSR, and then what happens because of the edema here? So there is sudden painless loss of vision again. Again, you have metamorphosis. Remember, you have this distortion of shapes. And central scotoma means you will get a central coin-shaped area in the center of the field. You will say, doctor, what is this black area which I cannot see? And sometimes because of the edema, it shifts to slight hypermetropia, say plus 1.5, because the retina gets pushed forward and the rays focus behind, is it not? So these are CSRs. So therefore, this is the metamorphosis, central scotoma and hyperopic shift. This is one it is. So please remember, so how to remember CSR? Loss of vision, metamorphopsia and scotomas. Hyperopic shift, you may not have to remember. Then on halo light, remember again on you see it. Can you see this halo? If you look at my picture, look at this swelling on the macula. It does not look the same as CME. Remember, CME looks very different because of the loss of plane. Okay? CSR is different because it looks like a blister. You know, it looks like a blister or a collection of fluid right over the macula. And Dr. Syed is saying here, this is the only class in which you didn't feel very bored. I don't feel very bored. Thank you, Dr. Syed. That really helps. If you don't feel bored, you know, that really helps. I hope you feel the same. All of you feel the same. So you get a halo light reflex like this, you get like, okay? And then once you diagnose the CSR, one important investigation here is to again do an FA, and again in this FA, remember in CME we get a flower petal, but here we get ink blots and smokestack. Look at that. The dye leaks out, again you inject the dye in the cubital vein and it goes here to the eye and the dye starts leaking out. Remember in what happens in CSR, in CME it was a flower petal appears, no? It appears like a flower petal. Like. But in CSR, you get two different. One, you get a smokestack. Look at this picture. It looks like smoke rising out of a chimney, is not? So this is one. And this ink blot. Ink blot sign means the ink leaks out like this. It's like a blot of ink like this. Look at that. This is called ink blot. Can you remember these terms? Ink blots and smokestacks. They are important for diagnosing CSR. And then you've confirmed CSR. Remember, so we give them reassurance because remember, these are basically stressed out people. So you reassure them. Tell them that this is a very temporary phenomena, to reassure them, like I am reassuring that your exams will all be fine. Just don't worry. Most of you worry unnecessarily. You've all done very well. You've all studied. It's only not to worry here. Okay? Reassure them, give them rest, and sometimes you give them anxiolytics. Sometimes they have difficulty sleeping. You give them anxiolytics to make them calm down. Okay, give them plenty of sleep, plenty of rest. This often happens to people. Remember, students during exam time. You get them in high profile CEOs who have tremendous pressure to perform. We have this hotel management executives. So often we'll get a question like this: a young male executive. Typically, remember, CSR are found in males. Okay, it's females, they have less. Type A males are, luckily, thank God, there are less type A females. It's difficult to handle type A females. So typically, young male executive comes to you with a sudden painful loss of vision. The treatment is nothing. Just give them rest. Give them anxiolytics, make them reassure them, and within 3 months, the fluid automatically, as they rest, as their less anxiety is reduced, the fluid absorbs and they become fine. Okay, this is CSR, spontaneous reabsorption of fluid, spontaneous. See, we've got a question from Ajay, which is CSR which layer? Remember, Ajay, CSR, the layer is between the neurosensitive and the RP. So there is no particular layer. Remember, neurosensitive, all 9 layers, the 10th layer is RP. So the answer is the layer is between the neurosensitive and the RP. It's a kind of localized exudative retinal detachment. Okay? Yes, sir. What next? After this, we've done CSR. So remember, the basic difference between CME and CSR is fluid under the macula with different layers, and the pathology is different because CME is some kind of leakage occurring because of diabetes or because of Irwin gas syndrome. CSR is excessive pumping of adrenaline because of the stress, because of the type A, and leaking the blood vessels into different areas of the retina. So the treatment is also different. Age-related macular degeneration, ARMD, remember, this is another macula. So we have put the 3 macular disorders together and ARMD. So age-related macular degeneration, you will have older people. The definition is above 50 years of age. Okay, at least they have to be at least 50. Of course, it occurs not at 50, but close to 70. So these are the problems with your grandparents. 50s, 60s are your cataract and glaucoma age groups. 70s and 80s, your grandparents, and they have macular degeneration. As you grow older, as we have an aging population nowadays in India, we have now rapidly increasing aging population. Now they are going into ARMD, macular degeneration. Less than 50, but the single most important risk factor, kindly remember, is smoking. Okay? These are smokers, many of them from college age, and they are 70. So remember, 50 years of smokers. All you smokers, please remember, don't puff your lives away. Be careful. As you go older and older, the smoking causes a lot of problems in eyes. Remember, smoking causes cataracts. Smoking worsens uveitis. Smoking worsens thyroid-related ophthalmopathy. But the single most damage to the retina, smoke causes to the retina, is ARMD. These are chronic smokers for years, 20, 30, 40 years of smokers, 1 pack, 2 pack, 3 packs. I had a patient long time back who was smoking almost daily, almost 3 packs of cigarettes, 30 cigarettes a day for 50 years. It's unbelievable. Smokers, hyperlipidemia, so they have hypercholesterolemia, hypertension, and white rays. So usually often seen more frequently in the whites, Americans and Europeans, not so much in ours, but we are also getting it as we get into the same kind of lifestyle diseases like hyperlipidemia, hypertension, and smoking. Okay? And so what happens is that there's damage to the membrane. Remember, it's a macular degeneration, but remember, the macular degeneration is not in the retina. It's under the macula is the choroid, and the actual damage is to a particular membrane called the Brooks membrane of the choroid. Okay, so it's the macula, but not the retinal, not the retinal plane. It is under the retina, behind the retina, which is the choroid. So the damage is actually Brooks membrane. We call, just remember, BM, Brooks membrane. And there are 2 different types. We call dry RMD, which is the more common. 90% of dry RMDs, and wet RMDs are only 10%. It is the wet RMD, however, which is more dangerous and causes blindness. Dry RMD does not cause blindness. 2 different types. And how do you have it? Gradual loss of vision with scotoma, again metamorphopsia, distortion of shape. Again distortion of shape. This is metamorphopsia. Remember, anything that occurs in the macula will have metamorphopsia, distortion of shape. Dry RMD, remember, hallmark would be drusen. What is that? Drusen? Drusen looks like a soft exudate. It's whitish in color and looks like cholesterol deposits. And these are drusen. So this whitish deposits, very similar to what the soft exudates look like, but they are not the same. Remember, soft exudates are on the retina, drusen on the choroid. And you can have geographic atrophy, where damage to retina takes the shape of some map of some country, on the atlas of geography. So it's called geographic atrophy. These are the hallmarks of dry. But wet RMD is named wet because this CNVM, choroidal neovascular membrane. So remember, These are, we call them CNVMs, choroidal neovascular membranes, also called SRNMs, subretinal neovascular membranes. It's the same thing, whether you call it subretinal or choroidal. So these are new blood vessels which develop and they cause bleeding. So these patients have bleeding on the macula, and that is why the wet RMDs are dangerous and may cause blindness. The dry RMDs do not cause blindness. Look at that. This, you can see the drusen here. There is a whitish deposit on the macula. Remember, the plane is the choroid, the Brooks membrane, where you have damage. The drusen, this is dry RMD. But wet RMD can cause blindness. So that's much more dangerous. How do we treat them? For treatment dry RMD, remember, we have to give them some lifestyle advice. So quit smoking first and foremost. Quit smoking. At that age, it's impossible to quit smoking. So I tell them to at least from a pack get down into half a pack. Slowly. Quit smoking. Green leafy vegetables, lot of spinach, lot of yellow fruits, green leafy vegetables, foods rich in omega-3 fatty acids, particularly as prescribed by the antioxidants prescribed by the ARED study. Now there is a very famous ARED study called AREDS. It stands for Age-Related Eye Disease Study. AREDS stands for Age-Related Eye Disease Study, and this told us that 6 important vitamins have to be there in the tablet which we prescribe for them. These 6 vitamins are all very powerful antioxidants, which are like copper and zinc and vitamin A and vitamin C. All these are there along with 2 things which are lutein and zeaxanthin. So these are specific tablets which prescribe to them for dry RMD. It controls the damage and does not cause blindness, but you cannot get your vision back. The wet RMD is pretty hopeless, really, because as the blood vessels, they bleed and then they become fibrosed and scar, so they damage the retina completely. The only thing we can do if they come to us fast enough is intravitreal anti-VEGF drugs. The old friends again, either bevacizumab, ranibizumab, or aflibercept. So this is ARMD. Can you remember ARMD is the most common cause of blindness in the Western countries. Western means Western world is US and all this. Because there are a lot of smokers there and they have a lot of ARMD. So the commonest cause worldwide is cataract of blindness. But if you ask for commonest cause of blindness in the Western world, specifically, it is ARMD. Okay, they don't have so much cataracts as the other part of the country. So this is ARMD, a very dangerous condition. And then retinal pigments, RP, and we'll just take a couple of subjects and then we'll take another short break before we finish up. RP, retinal pigments, remember, is a horrible disorder where it is the most common inherited disorder of the retina. Inherited, so congenital, from birth onwards. Okay, this is the most common. Can you remember, the most common inherited disorder is RP, where there is a programmed cell death of the rod. Apoptosis, a programmed cell death of the rods die out slowly, and the most common, the genetic programs, the most common is autosomal recessive. Okay, the most common is autosomal recessive. So that means these are patients who are born to consanguineous marriage. So they are parents related. So they are first cousins and second cousins parents, and their kids, they may have the genetic program which will destroy the rods. The rods are responsible for night vision. So the first symptom is, earliest symptom is night blindness, nyctalopia or night blindness. This is the earliest symptom, called nyctalopia or night blindness. So this is very handicapping for the patient. Apart from that, then you have a ring scotoma. So to add insult to injury, not only are they able to see at night, they have a ring shaped scotoma, okay, like this. So through this ring, they can see from inside the ring, from outside the ring, but through this ring shaped area, which is scotomatous, they cannot see. And slowly, this is called ring scotoma. Through this area, they cannot see. And slowly, the ring collapses over many years into tunnel vision. Now, after many years, 10, 20, and sometimes 30 years, it collapses into a tunnel vision. This is called the end. So remember, tunnel vision is also the end stage in open angle glaucoma, and it is also the end stage in retinitis pigmentosa. Okay? And then, so how to diagnose it? The famous triad of pale waxy disc. Look at the waxy disc. Remember, normal disc color is reddish orange. This is pale like wax. And the most important sign is this one. The blood vessels thin out, arterial attenuation, which means like strings, become like strings, attenuation. And the bone corpuscular pigmentation. Okay, the pigmentation, you see these pigments all over the retina. These dark pigments, black in color, like bone corpuscles, like this. This is how the bone forms. And these, when you see this classic triad, you mean you have retinitis pigmentosa, you have diagnosed it. And some associations which you should know, there's a posterior subcapsular cataract, which I have had to operate in many cases. This is posterior cataract association is there. And here the management is not much. You have to confirm between electroretinal, remember, you have to do ERG, can you remember. Normal ERG has a negative A wave and a positive B wave like this, something like this, and a very small C wave, but this ERG becomes flat RP. Just like a dead man has a flat ECG, retinitis pigmentosa has a flat lining of the ERG. It confirms that. There is no proven therapy because of programmed cell death. So what we often try anecdotal therapy, means it sometimes works, sometimes it doesn't. Very high dose, 15,000 international units of vitamin A in the palmitate form every day for life till the child is alive. He has to take it daily. Luckily, such a huge dose is not very toxic, not toxic at all. Okay, with this, you have to give lutein. Remember, this is that I was telling you the pigment that is there in the added study. Lutein 12 milligrams per day with DHA, docosahexaenoic acid, 12 milligrams per day. Lutein 12 milligrams per day. This is 1/10 the dosage. You don't have to remember the dosage. This seems to help sometimes, but sometimes it doesn't help. So it's anecdotal. So we can't do much. If there's macular edema, remember I said CME occurs in RP also, and the treatment of macular edema is carbon inhibitors like acetazolamide. Carbon inhibitors like acetazolamide. This is the drug of choice, but mostly we can't do anything for retinitis pigmentosa. This is a really horrible disorder. Okay? And the last condition of retina is retinoblastoma, the big daddy of retina. Remember, the commonest tumor of the eye in children, usually seen less than 5 years. The most common tumor of eye in children. Remember, most common tumor of eye in adults is malignant melanoma of the choroid. Here it is children. Retinoblastoma. And sporadic means there is no family history. 90% of retinoblastomas have no family history. That's worrying, is it not? Anybody can have it. And familial, with 10% of patients have a family history. So somebody in the family has this. 10% of the family. Next thing remember is unilateral is 70%, bilateral is 30%. It is the bilateral bigger part, which is more dangerous with all the problems of retinoblastoma. And the one gene that you have to remember, out of the 21,000 genes that human beings have, the most famous gene is the RB1, retinoblastoma 1, which is sitting on 13q14, the 13th chromosome, the long arm, the 14th band. Okay, 14th band, the exact location of 13, the RB1, and this RB1 is a suppressor gene. Remember, it does not cause retinoblastoma. It actually prevents retinoblastoma. It suppresses the tumor. It's a suppressor gene. But what happens to suppressor gene? That it is itself suppressed. So there's damage to suppressor gene. So it's not able to suppress the retinoblastoma which comes up. Okay? And this mutation of both the alleles, this is called Knudsen's two-hit hypothesis for my NEET PG and NEET students. The Knudsen's two-hit hypothesis, very famous hypothesis, states that there should be mutation in both the alleles of the RB1. You know, you have genes that have two alleles. You cannot have mutation to one. You have to have both. So once you have both mutations, so it causes the damage to the RB1, so it cannot suppress the tumor and the retinoblastoma rises, causing havoc. And the most common presentation in child is leukocoria. White pupil is the most 60% of cases, white pupils. Second common is squint. Remember, second common is often caused, you have asked to squint, and you have loss of vision and many other findings. But two I would like to remember is, the first is leukocoria, white pupil, and second is loss of vision. Okay? And then second is squint, first is leukocoria. Third, but are the different, remember, different diagnosis of leukocoria, we need to know only white pupil does not mean retinoblastoma in children. There are other causes also. So first is always retinoblastoma. What are the other causes? You have congenital cataract. Coats disease, remember, is the second commonest cause of leukocoria after retinoblastoma. Okay? Toxocariasis, retinopathy of prematurity. There are multiple causes. Toxoplasmosis, you can have endophthalmitis, you have Norris disease, colobomas. I want you to remember 2, 3. Number one, leukocoria in children, retinoblastoma. Number 2, Coats disease. Number 3, congenital. That's it. We don't want any of. What else? So we got leukocoria. Then remember, it's a very important question, is the most common intraocular calcium in children. Very famous MCQ, long time, even I was at the same MCQ as my PG entrance. It is the most common cause of intraocular calcification. So when in fact, that leukocoria is nothing but the calcified tumor. Okay, that's what you see as white, is the calcified tumor. So when you suspect retinopathy, all you do is a CT or an X-ray or ultrasound MRI and pick up the calcification. It's going to be retinoblastoma. Okay, so that is a very important sign. And the hallmark is the famous flexible rosettes. Look at these rosettes. These are called, we cut open the tumor in the lab. You see this kind of a stain, the rosette, the round thing. Rosettes named after the rose windows of a church. You've been to many of your churches, the rose windows, the stained glass windows, and this is the rose windows of a church. They look like that. Confirm. Okay. I remember, to pick up the calcification, sometimes we ask this question, we give you CT scan and an X-ray. Those are not good modalities. We can pick it up, but remember, because retinoblastoma often has secondary tumors, so to reduce the secondary tumors, we would like to reduce the radiation. So investigation of choice would be an MRI or even ultrasound. If you have a choice ultrasound, we would like to do that to reduce the radiation to prevent the secondary tumors that are spring up in retinoblastoma. MRI or ultrasound. And the classification is called the ICRB, latest classification, International Class of Retinoblastoma, where we divide the retinoblastoma into 5 stages according to the size, where the treatment for very small tumors, these are called stage 1 tumors, very small, where do a laser beam, focus the tumor, not on the tumor, but on the surrounding vessels. It damages the vessels, so no nutrition comes, the retinoblastoma dies. Very small tumors. Also, we have another tool called the TTT, transpupillary thermotherapy, where we introduce a heat probe through the pupil, transpupillary, and into close to that. Again, the heat kills the tumor, a very small tumor, stage A. For the EBRT stands for external beam radiotherapy. This is a very mutilating kind of a treatment. External beam, that is why we don't use it nowadays, except for recurrent disease which is not responding to any treatment. Recurrent is not responding to any treatment. Remember, the last stage is external beam radiotherapy, which may damage the face and the eye and the nose. And for chemotherapy, for bigger tumors, stage B, C, D, the bigger tumors, we have 3 different types of chemotherapy: intravenous, intravitreal, and intraarterial. Okay. Intravenous is the most common. Intraarterial is the latest. Intravitreal is more difficult. Intravenous, the drug of choice is VEC. Remember, vincristine, etoposide, and carboplatin. It was 6 cycles of vincristine, etoposide, and carboplatin. Very effective. This is chemotherapy, intravenous. Intravitreal is not very common. Intraarterial is the latest, so you inject the drug, remember, in the ophthalmic artery. Okay. That can be asked, which artery in intraarterial will be ophthalmic artery. Okay. Not central retinal artery, it's too small. And then the next thing about the treatment is if it's very large, stage 5, which means retinoblastoma size occupying more than 50% of the eyeball, then it is 50%. This is at stage 5, it is too big, we cannot do anything, we have to take out that. There's no other way. Enucleation, you have to remove the eyeball, otherwise it will cause death. You do it fast, and at least 15 millimeters of the optic nerve has to be sacrificed. It means if this is the eye, like this, so when you enucleate this, you cut, not only, you don't cut it here, you will take 15 millimeters and you cut it here of the optic nerve sacrifice, otherwise it may metastasize via the optic nerve. Okay. And then you put an implant here. The 3 main causes of death in retinoblastoma are metastasis from the optic nerve, second, intracranial tumors, and third, second tumors. They are not in that particular order. It's not as the first, second, third. It's just the cause of death. One cause, metastasis, remember, through the optic nerve. Remember, always asked, retinoplasty is the most common stage. Metastasis via the optic nerve, and it goes into the central nervous system where it seeds the CSF and kills the patient. Second would be retinoblastoma, intracranial tumors through retinoblastoma. Remember, the most common intracranial retinoblastoma, tumors through retinoblastoma is called a pinealoblastoma. Very famous, a tumor of the pineal gland, and famously called as trilateral, a combination of a bilateral retinoblastoma with a central pinealoblastoma is called a trilateral retinoblastoma, invariably killing the child, and a very dangerous cause of death. And third is a secondary tumor through retinoblastoma. The most common secondary tumor through retinoblastoma is the osteosarcoma of the femur. Okay, please remember, this is the most common secondary tumor. If they ask you secondary tumor, can you remember osteosarcoma? Pinealoblastoma is not a secondary carcinoma. Pinealoblastoma is considered very much a part of the primary complex itself. So 3 main causes of death, okay, metastasis via the optic nerve, central tumors or CNS tumors like pinealoblastomas, which may kill the child, and intracranial tumors, and third is secondary tumors with retinoblastoma, the most common of which is osteosarcoma of the femur. Okay, so this is the sad story of 13q14, unlucky 13, which causes retinoblastoma. Again, ladies and gentlemen, it's time for a short break, 15 minutes. We'll be back in 15 minutes. This, remember, that was the last stage. We'll wind up in the last. So I know that many of you are tired, you want to leave immediately, but I would want you to wait for the last stage. We'll just last for maybe around an hour. Maximum 1.5 hours, should not be gone beyond that. 15 minutes, ladies and gentlemen. Destroy your tissues with some tea and coffee and meet me again. Welcome back, ladies and gentlemen. I hope you restored your tissues. I've got some piping hot Iranian chai with some Osmani biscuits, which I want to share with you. For the last session, we're going to go a little fast because I don't want to detain you. We're going to do next neuro-ophthalmology now. Okay, neuro-ophthalmology. So we have some questions. First of all, optic neuritis and the retrovalvular. So what does that? Remember, the difference between them is that inflammation of the optic nerve. But if it's inflamed in front of the disc, we call it optic neuritis or papillitis. If it's behind, we call it retrovalvular. Okay? Retro means behind. So the only difference between them is the location of the nerve that's inflamed. If it's behind the disc, we call it retrovalvular. In front, we call it optic neuritis, papillitis. That's all. There's no other difference. So then the next thing about this is what are the most common causes. Remember, this is multiple sclerosis. MS is the most common cause. So young women between 25 to 45 women are the classic patients of optic neuritis. So remember, this can be asked in this way. What is the most common ocular manifestation of multiple sclerosis? Is optic neuritis. Okay? That's the most common cause. There's a sudden painful loss of vision. Remember, optic neuritis is always painful loss of vision, but particularly it worsens ocular movement. That means you look up, down, left, right, particularly the upward movement and the inward movement. Why these two movements? Because the upward movement, superior rectus, and the inward movement by the medial rectus, these are muscles attached very closely to the optic nerve sheath. Optic nerve sheath. So as it pulls on the inflamed nerve, there's painful. So sudden up, ouch, look up, and there's pain. Okay. The superior rectus and the medial rectus. This is a very specific sign on movement of the eye. But another very famous question is the color vision desaturation. What means all the bright colors appear light. As you can see, it starts with bright red and green. At the end of the first week, it becomes desaturated. So all the colors appear. Remember, typically the line used is as washed in water. So washed in water, desaturation. This is a very specific sign of optic neuritis, and the famous pupil called Marcus Gunn pupil, which is also called as RAPD, relative afferent pupillary defect. Okay, this is the pupil. Remember, optic nerve. Whenever there is abnormal optic nerve, anything that is optic neuritis, retrovalvular neuritis, optic nerve gliomas, AION, whatever are damage to the optic nerve, but one, not both. That's why it's called relative. Relative means only one eye. Both eyes damaged, then you won't have RAPD. You will see this condition of abnormal pupil called Marcus Gunn or RAPD pupil. Okay, but the hallmark of this condition is disc edema. Remember, disc edema, you can see how by the blurring of the disc margin. Look at that. You cannot make out where the disc is ending and where the retina is finishing. So this is the typical sign of disc edema. There is blurring of disc margins. Remember, this will be seen in optic neuritis, but not retrovalvular. Why? Because retrovalvular is behind. The inflammation is behind the disc. So the disc is paired. So there is no disc edema in retrovalvular. Optic neuritis there is because the inflammation damages the optic disc. So you will have disc edema. But retrovalvular, the inflammation is behind the disc. You do not have disc edema. So kindly remember, there is no disc edema in retrovalvular neuritis, and that is why very famous is often called a condition where the patient sees nothing and the doctor sees nothing. Patient sees nothing because the loss of vision is due to retrovalvular, and the doctor sees nothing because there is no disc edema. Okay? So kindly remember, very famously asked as an FRCS question also, patient sees nothing and the doctor sees nothing. Okay? So therefore, and the most common visual field, remember in retrovalvular optic neuritis, we have the same field effects. The two most common is either central scotoma or a centrocecal scotoma. Remember, the word cecum means blind. That's why it's called blind. The word cecum in Latin means blind. That's why this is called cecum, because it ends blindly. So central scotoma is the central area is lost to the patient, and centrocecal means center as well as the blind spot patient cannot see. Both of them can occur. One of them, of course, in visual field defect of optic neuritis, it can be central, it can be centrocecal. Any of them can occur. These are important visual field defects of neuro-ophthalmology, and the treatment, remember, is you have to memorize is IVMP, intravenous methylprednisolone. Okay, remember, I have given you IVMP because you have to remember it's always given steroid as a intravenous. Remember, oral steroids are contraindicated. Can you remember, oral steroids are contraindicated because they may cause recurrence of the optic neuritis. So you may not give anything also, because even if you don't give anything, it will recover automatically. But if you have to give steroid, you give it only as intravenous, not as oral steroids. Okay? So these steroids do not actually impact the visual acuity, only just hurry it up. They just accelerate it. There is no long-term impact. Even if you don't give a steroid, it will recover, but it will be slower. That's all. So therefore, that is optic neuritis. Then, very important thing is to how to test the pupils. Remember, the optic nerve pass is there in the pupil. So whenever there's a pupil, the optic nerve damage, the pupil will be abnormal, is not. So we test this. The simplest and the best is called the PLR, pupil light reflex, where you take a torch and flash it to the eye. And you will see there are two components. One is called the direct response, which occurs to the pupil, which is under the torch, and there is called the consensual, which is away from the other. So if you flash a light to one torch to one pupil, both will react. Both will constrict, both will react. Remember, they are always together. The pupil under the torch is called direct response. The pupil away from the torch is called consensual. Okay, both of them work together because they are connected together. So pupil light reflex is the constriction of pupil response to increased light of the retina. So I take a torch here, constriction, constriction. I take it away, dilation, dilation. Okay, they will always behave the same way. It is not possible that one will constrict, the other will dilate. That's not possible. Normal eye. So direct is in the same eye, constriction. As you can see this lovely picture here, as we throw the light here, you can see the pupil constricting here. You can see the pupil constricting here, and this is the light response, but you can see the opposite pupil also constricting there, and you see they are equally constricting, or not. So this is the direct response, this is the consensual response. Any pupil which does not behave like this, that they constrict and dilate equally, is abnormal. Okay, so this is the normal pupil light reflex. So the normal is the response because the balance between sympathetic and parasympathetic nerves, and therefore let's look at the abnormal pupils now of optic. So now we know how to test for normals. Let's look at Argyll-Robertson, very famous because the pupils seen in neurosyphilis. Okay, seen in neurosyphilis, Argyll-Robertson. And so when syphilis attacks, you see, remember there is a tertiary syphilis. So early, secondary, and tertiary syphilis. Tertiary syphilis attacks the CNS from the CNS, so that's why it attacks the eye. This is neurosyphilis. We diagnose it by the classic triad of bilaterally constricted irregular pupil. Look at that. You see both eyes are constricted and they are irregular. This is typically the classic triad. Both eyes constricted and irregular. Irregular means that the pupil is irregular. But remember, you have to distinguish from another irregular pupil, which was a festooned pupil angiovitis. Okay, how to distinguish? Because that is also irregular. Remember, this Argyll-Robertson pupil, there is a very important rule which the festooned pupil does not. It does not. It has this thing called LND. It stands for light near dissociation. That means what? When you flash a light, pupil does not constrict. When you take it away, pupil does not dilate. Light is negative. Pupil does not constrict to light, but it constricts to near vision. Remember, why would it constrict near vision? Because remember, near vision, we have three things. Remember, accommodation, convergent constriction. So this LND stands for a condition where the light is negative, the light near dissociation. That means the light and the near reactions are dissociated. They are not associated with that. When you flash a light, pupil does not constrict. You take it away, it does not dilate. Light is negative, does not constrict light. But why it doesn't constrict to light? Because the neurosyphilis has damaged the light center, which lies in the pons, the dorsal system, and it damages the light center. So the light is not constricting. But it comes to near because the near center is located at a different location. Okay, so near is center is different, the accommodation response is different. So for when you look at near object, it constricts, but when you flash light, does not constrict, called LND, light near dissociation. And this you can memorize by a mnemonic called ARP. You know, that's very famous. ARP stands for Argyll-Robertson pupil. It also says accommodation reflex present. Okay, so at accommodating, pupil constricts, but light does not constrict, and it's famously called as prostitute's pupil. Called the prostitute's pupil. This is neurosyphilis, so you'll have prostitute's pupil. These are the multiple questions of Argyll-Robertson which we need to see now. Very well. What next is the second abnormal pupil, which is called the AD's pupil. AD's pupil is easy to memorize. AD's is found in ladies. Okay, they're seen in young ladies, often very common, as you can see, with a young lady with the one pupil dilated, and often after viral fever, or it could be idiopathic also, post-trauma also. So this is a young lady comes to us with one pupil dilated, the other being normal. Okay, and this is called AD's pupil, and it is again, the problem is that again same behaviors. So when you flash a light, pupil does not constrict. When you take it away, it does not dilate. So light negative again. But when you ask them to look at near object like that, pupil constricts. So again, it is a kind of LND. So remember, light near dissociation, we have many conditions. One of them was Argyll-Robertson, another is AD's. Okay. So how to distinguish between them? Remember, the reason is different. Why LND works in Argyll-Robertson is different, and why it works in AD's is different. That is why it's different. But remember, that makes it difficult for us, because if both of them are light is negative and accommodation is positive, then how do you distinguish between them? Well, you distinguished because of the Unilaterally, see, ADs will be one eye and will be dilated. Argyll-Robertson will be both eyes and will be constricted. Okay, so look at the patient. Pupil is light negative, accommodation positive. It could be ADs, it could be Argyll-Robertson. If it's unilateral and dilated, it is ADs. If it's bilateral and constricted, it is Argyll-Robertson. Okay, so that way we distinguish that. Okay, LLD, and this is picked up by a very powerful test called the pilocarpine test. Pilocarpine 0.125%, very dilute solution of pilocarpine. You know, pilocarpine is a constrictor, isn't it? So whenever you're suspecting ADs pupil, what you do, you take pilocarpine, very dilute solution, put it in both eyes. You will find the normal pupil does not constrict, but the abnormal pupil constricts. And that is the sign it's Argyll-Robertson pupil. It's ADs pupil. Why? Because you see, why does the normal pupil not constrict after pilocarpine is a very powerful constrictor? Because it's too dilute. Remember, the concentration is only 0.125%. It's simply too dilute to constrict. But why does the abnormal pupil constrict then, if it's too dilute? Well, because of denervation supersensitivity. This is a concept which you may have read in physiology, where any tissue that is deprived of innervation, denervation means deprived of innervation, becomes highly supersensitive to acetylcholine. Okay, so in this case, remember, the nerve is damaged. The nerve is damaged. It's post-viral damage to the nerve. So what happens is, when you put pilocarpine and it reaches the nerve muscle junction, what it does, this pilocarpine releases acetylcholine, but acetylcholine is released is very little. Why? Because the solution is only 0.125. No, so amount of acetylcholine is very little. But whatever is acetylcholine, it is able to stimulate the neuromuscular junction receptors because it is super sensitive. Because super sensitive because it's deprived of innervation. So because of denervation supersensitivity, this test can be explained that the normal pupil does not constrict, but the ADs pupil does, and that confirms that it is. Remember, in the exam, they will not give you any hints. They will not say it's a young lady or a post-viral or whatever. They will just say patient comes to you with fixed dilated pupils. What is the test required? Remember, fixed dilated pupil, the test required is the pilocarpine test. Okay? So that is what the question would be. So the next thing is the Marcus gun pupil, RAPD, which we mentioned before but not discussed. RAPD, yes, Latika, that's correct. ADs is found in ladies, easy to memorize. Young ladies also. Remember, young men, it's not very common, and old ladies also not very common, mostly young ladies. So Marcus gun pupil, also called as relative afferent pupillary defect, is the same. It's called relative because, remember, it has to be one eye damage, asymmetric we call it. If both eyes are damaged by optic nerve damage, then RAPD will not occur. Okay. What is Marcus gun? Marcus gun pupil, remember, is seen asymmetric. That's why I mentioned is one eye. Damage to the optic nerve or retina, extensive damage of the retina, like CRAO, like ischemic CRVO. Okay, extensive damage. Small areas of retina damage cannot produce RAPD. Extensive areas of damage to retina or optic nerve of one side will cause an abnormal pupil, that is optic neuritis, anti-ischemic optic neuropathy, optic nerve gliomas, anything. Okay, what is that abnormal pupil? So when you take a torch to the eye, normally it should constrict, no? Well, in this case, we test this Marcus gun pupil with the test called the swinging torchlight test. We swing it from one eye to the other leg. Okay. So suppose my right eye is normal and left eye is abnormal. What will happen? See, as I go to the normal right eye, you will constrict, is it not? It will also constrict because this is normal. So then I to swing it to the opposite eye. Now, when I swing to the opposite eye, excuse me, I think I may have had too much Osmania biscuits. So when I swing it to the opposite, I see what's happening. Normally it should constrict, isn't it? But it doesn't constrict, it dilates. It dilates. And this one also dilates because remember, this dilate is consensual. Again, I come to normal, constriction, constriction. Again, I go to the abnormal, dilation, dilation. This abnormal dilatation is called the Marcus gun or RAPD. Why is it dilating? Because the optic nerve is damaged and is not conducting the impulse. So the brain thinks it's dark and dilates the pupil. You understand? So normal pupil, constriction, constriction. Abnormal pupil, dilation, dilation. When it dilates rather than constriction in response to light, we call it Marcus gun or RAPD. So this is what you see this. Normal constriction implies stimulation, but the diseased pupil dilates abnormally in light, which should not be considered pupil. This is abnormal and this is called as RAPD, also called as Marcus gun pupil. It can occur, remember, in any damage of the optic nerve, but it should be unilateral. Optic neuritis, AION, optic nerve gliomas, anything optic and retinal neuritis, anything damage to optic in one eye or extensive damage to retina, will have RAPD. We have got three abnormal pupils now. And the fourth one is the abnormal pupil. The fourth abnormal pupil is the pupil. We've done Argyll Robertson, we've done ADs, we've done RAP. Fourth is the famous Horner syndrome, which you may have studied in many other conditions, like particular Horner syndrome. Why Horner syndrome occurs? Because of OSP, oculosympathetic paralysis. Remember, I told you it's easy to memorize sometimes with just the initial letters. OSP stands for oculosympathetic paralysis, where the sympathetic system of the eyes, they get disturbed or damaged because of various conditions. And when you have OSP, so the patient lands up with Horner syndrome, which is this, which is diagnosed by the classic triad of PMA, ptosis, meiosis, and hydrosis. PMA, remember, not PMS, from which I have suffered enough. It's the males who suffer more from PMS, as you know. Ptosis, look at the ptosis, the mild ptosis, very mild ptosis, okay. Meiosis, can you see the pupil constrictor? This is normal pupil. And anhydrosis is absence of sweating, which you cannot see in a picture, PMA, okay. So why this minimal ptosis number? This minimal ptosis is only because it's the Mueller's that is paralyzed. The sympathetic system supplies the Mueller system. The sympathetic is gone, so the Mueller's cannot contract. The lid is a little bit. If you had the LPS paralyzed, then you have full ptosis, completely closed. So remember, MCQ, we often like to ask which muscle causes the ptosis in Horner syndrome. Remember, the muscle paralysis is the Mueller's muscle, not the LPS. Okay, so with the classic triad. Remember, this is the Horner syndrome called acquired. There's also one Horner syndrome called congenital Horner's. It's from birth onwards. And congenital Horner's, you have one more extra feature apart from the PMA. You have heterochromia. The two iris are of different colors. Okay. So as you can see here, congenital heterochromia, and the most reason important is birth trauma. So while delivering a child, particularly the forceps delivery, when the forceps, they clamp on the shoulder, they press on this clamped so tightly that the clamps, they damage the brachial plexus, sympathetic component, so it develops to oculosympathetic paralysis. And remember, congenital Horner's is seen from the extra is a heterochromia, that means two iris of different colors. In this case, you can see iris of same color, so there's no heterochromia, so this is acquired Horner's. Congenital Horner's, you will have heterochromia. So it's important to distinguish because the reasons are different. In acquired Horner's, the most common causes are Pancoast tumor and internal carotid artery dissection. Okay, so very dangerous. Remember, Pancoast tumor is a life-threatening condition. Internal carotid artery dissection is very painful Horner's. You can have it something scuba diving, the carotid artery ruptures. You have somebody massaging your neck, and it ruptures. So internal carotid artery can rupture very easily, and it's a very painful Horner's. Normal Horner's is not painful. When you have a painful Horner's, it's ICA dissection. Know the causes, and finally, how to confirm the test. Remember, how do we do confirm it? We confirm it as a cocaine test. Cocaine is one of the most powerful mydriatics on the earth's surface. It dilates all pupils. So whenever you're suspecting a Horner syndrome, suppose a patient is Horner, so what you do, you put a drop of cocaine in either eye. You will see the normal eye, which it will immediately dilate within 1 hour. It will all dilate fully. But the abnormal eye refuses to dilate. Remember, it is such a powerful dilator, mydriatic as we call it, and yet in Horner's pupil, it does not dilate. So remember, any pupil which does not dilate with cocaine is likely to be Horner syndrome. All other pupils dilate with cocaine, and that confirms it. Horner's pupil does not dilate with cocaine. Next condition is papilledema. Okay, so remember, next condition is papilledema. What is that? Papilledema is disc edema. Remember, the definition is important. Papilla means disc, so disc edema. But can you remember disc edema with raised intracranial tension? Okay. Is there this is a problem with the audio? It seems, is that right, friends? Please say so. We've got a question here. We have AION. Remember, we've got a question from drug of choice AION, which is AION stands for anterior ischemic optic neuropathy. Okay, so is it better? I hope. Yes, please. Somebody handle the audio. Okay, so it's clear. So some of you are getting problems there. So we have so AIN stands for anterior ischemic optic neuropathy. This is a condition when, because of ischemia, lack of blood flow, the optic nerve gets damaged. Okay, this is one of the most common disorders in older people, but it's not a part of the curriculum because we don't like to ask too many questions about this. I'm not going to go into this. And then we got a question is we've got AIN and Pancoast is correct. So we've got this. When Ram Guruji, we have from Rahul Ram, and Yeah, so we've got this, hold on. So remember, disc edema with raised intracranial tension, that means the ICT rise, or also called the ICP, intracranial pressure, it rises. So we must know what is the normal ICT. It is about 50 to 180 millimeters of water. Remember, traditionally we memorize millimeters of water, not of mercury, though you can convert it, but traditionally we teach in millimeters of water. So anybody, any child with more than 200 millimeters of water pressure, or adult with 250, we do diagnose as papilledema. Okay, so children with more than 200, adults with more than 250 diagnosed with raised ICT. So this raised ICT, it travels to the optic nerve into the two discs and causes edema. This is called as disc edema due to raised ICT. Can you remember, papilledema can only be called papilledema when you have raised ICT. What are the causes? One of the most common is ICSOL, stands for intracranial space occupying lesions. Okay, that means they are brain tumors. Okay, we don't want to call it a brain tumor because it scares the patient. So a good term is intracranial space occupying lesions. Traumatic brain injury, one of the most common causes. You get hit and there's bleeding inside. Traumatic brain injuries raises ICT. Subarachnoid hemorrhage, again, these are three most common causes of raised ICT. Okay? Remember, the brain pressure can rise very easily because the brain is a very compact structure. We have the cranium. This cranium has three things. It's very compact. 85% is the brain, 5% you have is the CSF, and 10% is blood. That's all. So there's no space. So any little addition, be it hemorrhage, be it a tumor, be it swelling of the brain, may cause raised ICT leading to disc edema. This is called as papilledema. And remember, it's bilateral disc edema. So the important way how to diagnose from normal raised ICT, normal disc edema as an optic neuritis. Optic neuritis will have unilateral. This is always bilateral because it goes to both the discs. And sometimes you have a sixth nerve paralysis, which means the lateral rectus is paralyzed. Because why? Because the sixth nerve is a very long nerve and associated with the brain. So when the brain is raised ICT, what it does, it pushes the brainstem down. Pushes the brainstem down. So the brainstem which is pushing down, it pulls on the sixth nerve. Sixth nerve is a very long nerve, and it pulls on the sixth nerve and causes paralysis. So sixth nerve palsy is an important sign of raised ICT. What else you'll have? Remember, the earliest sign of a very important MCQ is this loss of spontaneous venous pulsation. Remember, I told you, you must remember that in the body there are only two veins which pulsate. Two veins which pulsate. Normally all the arteries pulsate. What are the two veins which pulsate? One is the jugular pulse, not which pulsates. And the second one is the venous pulsation, the central retinal venous pulsations on the disc. No other vein pulsates. No other vein pulsates. So when we have disappearance or loss of the venous pulsations of the central retinal vein, when you have loss of the central vein pulsation, then it is the first sign of papilledema. So remember, that's the first sign of papilledema. But sometimes they do not give this choice. Then you remember blurring of the nasal margin disc. So optic disc is blurring, but it starts with the nasal side. Okay, so from this side the disc starts blurring. But if both are given, this is the better answer, the early sign of papilledema. Okay, very well. So what else? And then in blind, so you've got, in this case again, remember, in every type of optic nerve damage, anytime there is damage to the brain, we need a visual field effect. And the visual field effect here, most common in papilledema, is an enlargement of the blind spot. The size of the blind spot enlarges. Okay, so this is a very popular question. What is the commonest visual field effect in papilledema? Is the enlargement of the blind spot. So this is how papilledema. And so the treatment is not ours, because basically we refer it to the neurosurgeons, because after all, raised ICT is their concern, is not our concern. The visual pathways, so you all know the 7 stations. As I flash a light to the eye, see the 7 stations which they pass through, you all know that, I hope. Okay, okay, so we have got a question here. It's working. Yes, Pavitra, being up from so many days, not my fault, Pavitra. I've been around, you must not have been attending my classes. Hi to you. And we've got glaucoma. We use, sir, for glaucoma use, see, glaucoma, I'm not getting question, what is millimeter? Yes, we glaucoma, we millimeters of mercury, right? So we, in glaucoma, remember I said the 10 to 21 millimeters of mercury, but remember that was intraocular pressure. In intracranial pressure, we use millimeters of water. Okay, that is one. And which is the drug of choice for glaucoma with cerebral edema? Glaucoma with cerebral edema would be mannitol. And the answer is correct. Somebody already given it. Latika has given the correct answer. Puneet, absolutely right. Okay, very well. Now, the next thing, so what you have is a You take a torch and flash to the eye, and so look at what will happen. It will first hit the foveal, isn't it? So it goes to the foveal. But that is not a part of the visual pathway. The visual pathway begins when the information reaches the optic disc. That's the first. So it goes to the optic disc, and you can see from the disc goes to the optic nerve, then crosses over the chiasma, goes to the optic tract, goes to the lateral genital body, goes to the optic radiations, and then the primary visual cortex, which lies in the occipital lobe, is it not? In the occipital lobe, it lies in the, remember the location of the primary visual cortex, area 17. The PVC is in this area called the calcarine fissure, is not? It's called the calcarine fissure or the calcarine sulcus sometimes. So this is the location of the exact, sometimes like to ask, where is the PVC or the primary visual cortex located? On the calcarine sulcus. Okay? Sulcus is a better term, I think, rather than fissure. So again, to summarize, from the disc, nerve, chiasma, tract, genital body, radiation, and occipital lobe. Okay? 7 stations. So any damage anywhere, remember, why would the damage occur? Because of strokes. They are all the brain, no? So often these are areas of less vascularity, so they often have strokes. They could be hemorrhagic, they could be thrombotic. So when you have strokes, what happens? These particular structures get damaged. So the disc, nerve, chiasma, tract, etc. So, and when you have damage to these structures, so we have this visual field effects which you pick up. Okay, so we can look at the visual field effect and tell the physicians and the neurosurgeons where the damage lies, because the visual field is characteristic of this particular damage. Okay, so let's look at the important visual field effects which are asked in your exams, ladies and gentlemen. So look at that, and we have this. Remember, if it's a monocular balance, if you have only one eye, patient comes visual field in one eye, then it means the damage has to be before the chiasma. So which means optic disc or optic nerve, which optic nerve is the much more common. This is not pre-chiasm. Then a very common is the famous bitemporal hemorrhage. Look at that. Both the temples are gone. Bitemporal hemorrhage, we all know that is the optic chiasma that is damaged, mostly the pituitary adenomas which cause the optic chiasma lesion. So this is very commonly asked. This is the bitemporal hemorrhage. Another popular question is the visual field effect of the homonymous hemianopia. It's not homonymous hemianopia means that the half the field, okay, half the field, but homonymous means they should be of the same side of the field. So look at this. Homo means same, no? So this is a left eye, this is a right eye, and you can see that both the right halves of the field are destroyed. Both the right half. This is also right half, this is also right half. So that's why it's called homonymous. So whenever you have homonymous hemianopia like this, it is the optic tract lesions that are caused. This is another popular field effect. And off late, they are asking this one, the famous macular sparing. Know that? Macular sparing means that you see the macular sparing. This is a homonymous hemianopia again. If you see, it's a left homonymous hemianopia, but the macula is spared. The macula is spared here, so you call it the macular sparing. Okay, very famous field effect here. The occipital lobe is damaged. Okay, so I want you to remember these 3 particular: the bitemporal hemianopia with optic chiasmal lesions, the homonymous hemianopia, optic tract, and the macular sparing is the occipital lobe due to dual blood supply. Okay, so visual field effects is visual field effects which are important for us. And then so now we've done enough neuro-ophthalmology, and let's talk about the next condition, which is going to be the next. The harvest is squint. Squint, strabismus is the next condition. So let's talk about squint strabismus. Meanwhile, if we have any questions here. Is correct. Which side of tract effect? Which side of tract effect means you mean to say that supposing, okay, so this question is from Ravicharan, and see what I said is in this condition you have this right homonymous hemianopia, is it not? This is right homonymous hemianopia because the right side is gone. So optic tract is always opposite to the left optic tract. Can you remember all homonymous hemianopias? Can you remember all homonymous hemianopias? The lesions are on the opposite side. The right optic tract, the right homonymous, left optic tract. Left homonymous, right optic tract will be always opposite sided. Anything that crosses over will be opposite sided. The next thing is squint strabismus, and we are needing to hurry up a little bit because we don't want to extend all night. The strabismus or squint. So let's look at the harvest. What we have. So first of all, a quick summary of the 6 muscles: superior rectus, inferior rectus, middle rectus, lateral rectus, superior inferior. So we have these 12 muscles which move the eyeball. We call them the extraocular muscles. And what are the, remember of this, the 2 simplest actions are the medial rectus and lateral. The lateral rectus pulls the eyeball out, we call it abduction, and the medial rectus pulls the eyeball in, called as adduction. So they are the simplest muscles because they are absolutely straight. But the other muscles, they are not like, superior rectus is not like, it's slightly like this. Inferior rectus is not like this, it's slightly like this. And obliques are of course angled. So because they're angled, so each of these actions, superior rectus, inferior rectus, superior oblique, inferior oblique, these four have three different actions. Okay, and how to memorize is the famous mnemonic which we called as SYNRAD, is not? So SYNRAD's mnemonic to memorize, it stands for superiors intort and rectus adduct. Yeah, this is the easy mnemonic. Superior muscles intort, syn, and rectus muscle called adduction. And with that we can like this. So look at that, superior rectus, inferior rectus, superior oblique, inferior oblique, we have these four, each of them have three actions. So first let's superiors intort. So what are the superior muscles? We have the superior rectus and the superior oblique. Okay, so the superior muscles, they will both cause intorsion, is it not? They will cause both intorsion. So therefore, if the superior muscles intort, what will the inferiors do? They will extort, and that's correct. So we have, see, superior, superior rectus, superior oblique, they intort, and the two inferiors, the inferior rectus and inferior oblique, they cause extorsion. First part over. Second is rectus muscles. Rectus muscles cause adduction. So what are rectus? We have superior rectus, inferior rectus, they will both cause adduction. So what will the obliques do? They will cause abduction. If the rectus adduct, then the obliques will abduct naturally, and that's exactly what happens. Look at that, superior rectus, inferior rectus, they both cause adduction, but the two obliques cause abduction, is it not? So that's an easy mnemonic, SYNRAD. You just practice it and it'll be fine. Okay. Now, what is left is the elevation and depression, and that is ruled by the name. Look at that, superior rectus. Superior means up, so look up. So superior rectus will elevate. Inferior rectus, look down. Okay, so it will depress, infinite. Now in obliques it is it's being reversed, because it's oblique. So the obliques do not obey the simple rules. It does exactly the opposite. The superior oblique, remember, instead of superior, it goes down. It does depression. In inferior oblique, instead of down, it goes up. Exactly the opposite happens. It causes elevation, and that's it. So superior rectus elevates because rectus muscles obeys rules. Inferior rectus depresses, it obeys rules. Superior oblique, becoming oblique, does not obey, does exactly the opposite. It depresses, and inferior oblique elevates. In fact, superior oblique is a very important depressor. That is why when the superior oblique muscle gets paralyzed, remember, the eyeball moves up. Because the depressor is paralyzed, so the elevator pulls it up, is it not? The fourth nerve palsy, that the eyeball moves up because the depressor is paralyzed. Very well. So we have this in that mnemonic, and then we need to know the primary actions. All these actions, one is called primary, all these three, one is called secondary, one is called tertiary. Primary action is the action in primary gaze. That means when I look straight ahead, see, this is the primary gaze. You know that we have 9 gazes. One primary, head straight, eye straight. 4 secondaries, up, down, left, right, the 4 secondaries. And 4 tertiary, up and left, down and left, up and right, and down and right. Is not. These are second and tertiary. So we want to know sometimes the primary actions. That is the action of the muscle in primary gaze. That's easy to memorize. Remember, for superior rectus, look at the muscle superior. So the primary must be elevator. The primary action superior rectus is elevation. Okay, remember, just look at the name. Similarly, inferior rectus, inferior. So the main action, primary action, is depression. Superior oblique, remember SYNRAD. SYNRAD, so superior oblique is intorsion. It's intorsion, and inferior oblique is extorsion. Okay, so this is how you can remember. So sometimes they do ask primary action. They all have these actions. Primary action is just the name given to the action in primary gaze when you look straight ahead. So superior oblique is a primary intorter, inferior oblique is an extorter, this is a depressor, and this is an elevator. Okay, so this is how you memorize the actions of the drugs. Not easy. And the next thing is what terminology is. Okay, terminology, let's talk about tropias and phorias. Okay, remember, tropia means manifest. What is squint? Squint means the eyes, it's either turned in or out. Okay, when the eyes are not parallel. When the eyes are parallel, we call it orthophoria. If it's turning inward, outward, or upward or downward, it's called squint. So when you have tropia, it means manifest squint. Manifest means you can see it. But phoria is latent, that you cannot see. You can see that. This lady has squint, and coincidentally, she's also from Hyderabad. Okay, so remember that these eyes look parallel, but they're not parallel. They're not parallel. They are actually phorias, and they're controlled. Why? How they control? This is called latent. That's why it's not seen, because the two muscles, they're balancing each other. Okay, the two eyes. So if one eye is going like this, the other will also go like this. You can't see it. One eye moves like this, the other also moves like this, trying to balance it. So these muscles eyes, they try to balance each other. Okay? If one goes up, the other will not go down, it will also go up. Try to balance it. This muscle effort to keep the eyes together is called as fusion, okay, or binocular balance or fusion. So the eyes always try to balance each other. So you can see that the eyes are being balanced, so you cannot see the squint. There is a squint. Okay. So how do you see the squint? We have tests for that. We have to break the fusion and then we can see the squint. So then let's go to other terms. Remember ortho, I told you, ortho means straight. When you have straight eyes, we have orthophoria, and heterophoria means squinting eye. That means if eye is inward or outward, upward or downward, we call it squint. So there's another name for squint or strabismus is called heterophoria. Okay. So kindly remember there are multiple names. So orthophoria means straight eyes, but heterophoria means squinting eyes. Okay. And then some other terms, exo means outward deviation. Ezo means inward deviation. Hyper means one eye is above the other eye. This is hyper. Look at this. This right is hyper. Hypo means one eye is below. Okay. So that's quite simple. So exo means out. Ezo means in. Hyper above. Hypo means below. So these are 4 different types of squints that we can see. And tropias and phorias. Remember, phorias are easily, so big one. Tropias are easily visible, so there's no need to do anything. We can see the squint. But phorias are, we have to, we need to, battery is running low. There's no charging happening here. Seems. And we'll come to the current slide. Okay, ladies and gentlemen, sorry for that short break because there was some problem in charging. So we're back again. I hope you're still there. And yeah, so we have this question. So we have this terminology again. So kindly remember, tropias, you can see, we are not in a problem. Phorias, we cannot see, we have to have a test. Then you have ortho means straight and hetero means squinting eye. And you have outward, exo, inward, ezo, hyper is above and hypo is below. Is it not? So we have these things. The next thing about this is the term after terminology is phorias. Now we talk about phorias. Remember, phorias means that you cannot see them, right? Because you cannot see them, so there's a bit of a problem. So we have to have a certain test for that. So these phorias, they become visible. So you cannot see them. When do they become visible? When the eyes are tired, you know. because there's a fusion to be maintained, the balance is to be maintained. So, but the eyes cannot be always at the peak of their performance. So they get tired, exhausted, irritated. When you are exhausted, tired, irritated, angry, hungry, frustrated, and all these emotions which many of us suffer from right now in this class, the eyes, they cannot balance each other. They cannot balance each other. So suddenly one eye goes out like this and the other eye does not follow. So immediately the mother notices that the child is good squinting. Suddenly fine, one eye moves out, but the other eye doesn't move, it's too exhausted, and the foria becomes tropia. So foria converts into tropia, and then we can see that. So this is called fusion disruptors. So the forias are visible to us when you are tired or exhausted, irritated or frustrated. So this is tropia and foria. Next thing, so why do they come to us? They come to us because of the eye strain, because of the strain of maintaining the balance. The two eyes always trying to maintain. So the eyes get tired. So often these patients come to us for foria. Symptoms are of exhaustion, of asthenopia, of heaviness of the eyes, dullness of the eyes, because of the effort of trying to maintain the balance. So they get headaches and eyes. The forias, they come to us like that. The next one, so what we need a test to detect this foria, and the detect to this foria is a very powerful test called the cover uncover test, where you cover one eye. So look at that. So what you do, you cover one eye and uncover it. You cover and uncover and look at the eye, and you will find that there is a squint here. Look at this. Look at the top picture. You have the two eyes are parallel here. This looks perfect. But as soon as I cover this, if you look at this, see under the cover, the eyeball is moved in. Why? Because you have broken the fusion. So with one eye covered, you have broken the fusion. The eye has taken its normal position, which is esophoria. Okay. You cover the other eye, and you see again it's gone in. So this is esophoria now being manifested as tropia. Okay. But if you look at the first picture, she looks absolutely normal, is not? So this is the famous cover uncover test, where you cover and uncover the eye, cover, uncover, look at this eye. Then you look at the other eye, do the same. So in a normal eye, if the eyes are balanced, the cover uncover test will break the fusion and it will manifest the squint which was hidden. So from foria, it converts into tropia. Very powerful test for picking up the foria. Otherwise, you cannot diagnose. Look at that. For instance, in this picture that I showed you of the foria, you cannot make out that she has squint, isn't it? So how will you diagnose that? Well, you will only diagnose if you do a cover uncover test. So then when you move the cover, you will find the eye has gone in or out like that. So cover uncover is the only test to pick up the foria. Otherwise, you will be fooled into thinking that she has normal eye. Okay. So forias, can remember, very powerful test called the cover uncover test. But for tropias, it's much easier. We do something called the Hirschberg test. We do something called the Hirschberg test. So the Hirschberg test is what you ask them to take a torch and flash to the forehead like this. Take a torch, flash to the center of the forehead, and ask the patient to look at the torch. And because the light reflects off the cornea, and the two corneas behave like perfectly polished convex mirrors, so you will see if the two eyes are parallel. You see, as you see in this eye, you will see the reflection right in the center of the pupil, is not? You see exactly in the center of the pupil, you see the reflection. So this is an eye which is parallel. But if this is eye, if you had a squint, suppose you had a squint, and this is the cornea, this is the limbus, this is the pupil. So suppose the patient right eye is normal, so the reflection will be seen here in the center. But suppose this has squint, and then the reflection will be somewhere seen not in the center, but either outside or inside, because as the eye goes out or in, so reflection will be visible. You will see the reflection somewhere here. So what you do to measure the squint, you measure the distance from the center of the pupil, where it should be, and where it actually is. Okay. It should have been in the center, but is actually here. So you measure with a scale, with a normal scale, in millimeters of displacement or decentration. Center means away from the center, is not? So in millimeters of decentration, remember each 1 millimeter of displacement, each 1 millimeter of displacement is equal to 7 degrees of squint. And remember, squint is measured in 2 units. One is degrees, the second is prism diopters, like kilometers and meters and all. So squint is measured in 2 units, one is degrees, and how do you equate them? Is that every 1 degree is equal to 2 prism diopters. So 1 minute displacement is 7 degrees, which means 14 prism diopters. Okay, so be careful. We can ask you the question either in prism diopters or in degrees. It depends on what is more comfortable. For instance, I prefer prism diopter most of my friends do in degrees. Okay, so 1 displays 7 degrees, which means 14 prism diopters. That is how you calculate the squint. Okay, amount of squint you calculate like this. And now tropias, once you've diagnosed the tropias, once we have diagnosed the tropias, so we classify into two different types. Remember, comitant and paralytic. Remember, the word comitant means together. The word comitant means together. It's congenital and the eyes move together, so comitant. The second is paralytic squint. So what happens here? Let's look at the types of comitant and paralytic squints. And so let's look at that. The first one where the comitant means together, and remember, it means the eyes are moving together. It's from birth onwards. And here, see, angular division between two eyes remains constant. What does that mean? See, supposing that I have a squint from birth on. So we look at you in the primary gaze, suppose my eye is like this, okay? The angle is 5 degrees. Okay, so when I look here, secondly, so it moves, this is also 5 degrees, this is also 5 degrees. So why? Because the two eyes are moving equally, is it not? If this eye is moving 10 millimeters, this eye is also moving 10 millimeters. So if this in primary is 5 degree, this moves 10 millimeters, this also moves 10 millimeters, so still 5 degree. When it looks there, this also moves 10 millimeters, this also moves, so angle 5 degrees is not. So comitant squint is defined as a type of squint in which the angle in the two eyes remains constant in all 9 gazes. 5 degree, 5 degree, 5 degree. All 9 means 1 primary, 4 secondary, 4 tertiary. Okay? So because this is that's why it's called comitant, because it's together. It's together, and this is the definition of comitant squints. This is a patient who does not have a problem. He does not have a problem except cosmetic. So they have no functional. They may have a cosmetic problem, you know, that it's not liked by their partners, but they do not have a functional problem. There's no diplopia. There's no problem, no headaches, nothing at all. Okay. This is no double division, and this is the type of squint which is very common. Usually from birth onwards, the two eyes are together. We call it comitant. Here, one question can be asked that the primary deviation is equal to second. What does that mean? The primary deviation, kindly remember, means the angle between the two eyes with the normal eye fixing. Okay, normal eye looking at the target. And secondary deviation means the angle between the two eyes with the squinting eye fixing. Okay, so in tropias, in comitant squints, they are equal. Okay, what does that mean? Suppose you have like this. Okay, remember, this is the normal eye, this is the squinting eye. So when I look at you with the normal eye, angle is 5 degree. Okay, but when I move the eye like this, such that the squinting eye is looking at you, see, it's like this, no, and they move equally. It moves like this. So even if the squinting eye looks at you, this eye moves equally. So this is 5 and this is 5 also, is it not? Whether I look at you in the primary eye fixing, the normal eye fixing, or the squinting eye fixing, the angle is the same. So this is what means that the two angles are same. This is a very important property of comitant squints. It means the primary deviation is equal to the secondary deviation. This is an important finding. Very well. What else about comitant squints we should know? There are two types of comitant squints. One is called accommodative, and second is called non-accommodative. What's the difference? Accommodative and non-accommodative. Let's look at the differences, and you can make it out very clearly. Accommodative squint is a type of squint which is seen due to uncorrected refractive error. Remember, I told you today that when you have uncorrected hypermetropia, you have convergence squint, and when you have uncorrected myopia, you have divergence squint. So whenever you have a squint due to uncorrected refractive error, this is called accommodative squint. And when the squint is not due to refractive error, called as non-accommodative squint, is it not? So this is the definition. It's quite clear. Let's look at the accommodative squint first. So this is the type of squint where you have refractive error and not wearing glasses. Okay. So this is, remember, hypermetropes develop convergence squint because of constant accommodation and convergence, and myopics, uncorrected myopics, they have divergence squint because they don't accommodate and they don't converge, so they diverge. Okay. So this is accommodative squint, and so what the treatment will be? Treatment as is uncorrected hypermetropy with convergence squint, uncorrected myopia, you will have divergence. Treatment, we have to give them glasses, obviously, because look at that, you can see this massive convergence accommodative ISO corrected immediately by wearing glasses. Wearing glasses, so the treatment of, and remember, accommodative squint is always glasses because it's the absence of glasses that is causing the squint, right? What about non-accommodative? Non-accommodative is squint which is not due to refractive error. You can see we have given them glasses, but the patient has not improved, no? So that's because he doesn't have a refractive error. We are just trying to force glasses on him, but he does not improve because the squint is not because of the refractive error. So here the treatment is we have to do surgery. Here the treatment, we have to do surgery here. And so accommodative squint is glasses, non-accommodative is surgery. What is the surgery? The surgery, remember, we have to do a combination of resection. Resection, it's a combination of weakening the muscle and strengthening one muscle. So you suppose I have an exo like this, see, suppose this is exo, no? So how will I make it straight? What I do, so right is exo. So I would make the right medial rectus stronger, so it pulls the eyeball in, okay? And or I could make the right lateral rectus weak, so this stops pulling. What we do both. Not only may I make the right medial rectus stronger, so it pulls it in, I also make the right lateral rectus weaker, so it stops pulling out. So both cases it becomes like this. So we do a combination of weakening one muscle and strengthening the opposite muscle. Okay, how do we do that? For weakening the muscle, we do a surgery called recession. Recession means to go back. Okay, the word recession means to go back. So pull the insertion back, and we can do resection, means cut. Every time we cut a muscle, it strengthens the muscle. Remember LPS resection we did, strengthening the LPS. So we want to resect a muscle, it strengthens the muscle and weaken the opposite muscle by recessing. So kindly remember these terms, recession always weakens, resection always strengthens the muscle. So this is important for us. The non-accommodative means surgery, accommodative means refractive error. What next? So we go to the next type of squint, which is the paralytic squint, is not. The paralytic squint, remember, there is paralysis of what? Paralysis of either the neuromuscular junction or the muscle. It could be muscle paralysis, could be due to what? Due to the third nerve, the fourth nerve, or sixth nerve. Okay, so you could have neuromuscular junction paralysis, where this is like myasthenia gravis, or third nerve, fourth, sixth nerve, which supply the various muscles of the eye. So you could have a combination of like this. This is paralytic. Why would they paralyze? The most common causes of paralytic squint, remember, we call them vasculopathic causes. The uncontrolled diabetes and blood pressure. Can you remember the most common paralytic squints? Remember, these are not congenital, these are acquired. They come after birth, and the commonest causes are uncontrolled diabetes and blood pressure, vasculopathic causes. And here, remember what happens here, the paralytic squint is completely different because the angle changes in every gaze depending on the gaze. Look at that. What happens? Suppose I have a right sixth nerve paralysis, okay? God forbid. But suppose right sixth nerve means lateral rectus gone. The right rectus gone, so what will happen means the right rectus gone. So medial rectus forces the eyeball inward like this, okay? So when I look at you in the primary gaze, look at this. This is about 5 degrees. When I look here, this eye moves fully. But this eye cannot move because it's touching the nose. So since this eye moves and this is not moving at all, the angle changes from 5 to 10. Remember, they can only remain the same if both the eyes move equally. But this is not moving equally because one eye is paralyzed, it is hitting the nose, the other eye is moving. Okay, so this is how, look at that. You can see it here, the right sixth nerve gone. So the lateral rectus paralyzed, the medial rectus pulls the eyeball inwards. When this patient looks outward like this, so this eye cannot move because touching the eye, there's no space. So it will be 5 here, it will be 10 degrees here, 15 degrees, 20 degrees, 25 degrees, 30 degrees. Why? Because the angle changes every gaze. The angle changes every gaze. Why? Because the two eyes are not moving together. They are not moving equally. They are not moving 10 millimeters each. Okay, it depends on the squint. So one eye, the unparalyzed eye, is moving fully. The other eye is paralyzed, is moving a little bit. Sometimes 1 millimeter, sometimes 2 millimeters, sometimes 3 millimeters. The angle changes in every gaze. Okay, and because changes in every gaze, so they land up with 4 major problems, none of which are seen in competent squint. The 4 major problems are diplopia, double vision, which is the most difficult problem. Abnormal head posture, they hold the head abnormally in a head tilt, or a neck chin lift, or head posture. Vertigo, so they have this dizziness sensation where they feel dizzy, vertigo, and disorientation. They do not know what time it is, what day it is. As many of you have forgotten what class it is also, I think you are also disoriented. With the 4 major symptoms: diplopia, abnormal head posture, vertigo, and disorientation, none of which are seen in competent squint, but all of them are seen in paralytic squints. Why? Because the eyes are moving in different angles in every case. Okay. Also in this case, remember, there's an important MCQ. The secondary deviation is greater than the primary deviation. Remember, in competent squints, they were the same. If you remember, in competent squints, they were the same, angle was same, but in this case, it's different. You see, secondary deviation. Look at that. Why? Suppose in this case, we took this example of this lady. Let's go to that. Look at that. So I have an eye like this, okay? So see, when I'm looking at you with the primary gaze, so this angle is 5 degrees, right? Remember, second division would be what? Second division is with the squinting eye. So squinting eye fixing, that means that I need to move this eye, okay? But because this is paralyzed, so to move this eye will make a tremendous amount of effort. This effort that I use to move the eye, look at you, will be conveyed to this eye because of a law which says that the two eyes should move equally, Sharrington's law. So this is Herring's law actually. So as I move it like this, the tremendous effort is conveyed to this. So this tremendous effort is conveyed to the other eye. So this moves more. So the angle between the two angles, the eyes changes, okay? And the secondary angle is much more than the primary. So this is important for us to remember. In paralytic squints, the secondary deviation is greater than the primary deviation. In competent squint, the primary is equal to the secondary deviation, okay? This is an important differentiation. And as I mentioned before, they have the same, the four major problems: diplopia, abdominal head posture, vertigo, and disorientation. Okay, so these are the problems of paralytic squint. So of this, so the diplopia is most important. Remember the doubling of vision, which is seen with both eyes. Remember, we call this binocular diplopia. Both eyes open, will see diplopia. If you close one eye, so diplopia will disappear. Okay, if you close this eye, it will disappear. With both eyes, it will there. Okay, but if you close one eye, it will go away. It will be one. Close this eye, it will become one. With both eyes become two. This is called diplopia. This is a sign of squint. Okay, binocular diplopia. If you have diplopia with one eye, that means you close one eye, you see two things. But you open one eye, both eyes, you see one. Remember, one eye closed, you see two. This is called monocular diplopia. Monocular, one eye, double vision. These are different causes like cataracts, like refractive error, like astigmatism, like dry eyes. So monocular diplopia has different causes. Binocular diplopia, the main causes squint. Okay, so this is two different kinds of diplopia. Remember, diplopia is the single most distressing problem for the patient. They really suffer because there's two of everything. What else? The other one was the abnormal head posture, and it depends on the plane of the paralyzed muscle. Okay, so we have three different types of abnormal. They hold the heads like this. Sometimes you have a head. This is called the face turn. When the face turns to one side, when the face turns, it means one of the horizontal rectus muscles paralyzed, like lateral rectus, medial rectus. Or you could have a chin lift or chin depression like this. It means the vertical muscles are paralyzed, superior rectus, inferior rectus, hold your head like this. Is a compensatory gesture trying to eliminate the diplopia. Or if you're the most is a head tilt, where the head tilts one shoulder like this, hold like this, and this means one of the obliques are paralyzed. When the obliques are paralyzed, so you see the abnormal head posture tells us of the various plane of muscles. Face turn is the horizontal muscles, chin lift, chin depression is the vertical muscles, and head tilt is the oblique muscles paralysis. Okay, so these are the multiple things that we have here that we need to know about. I know squint is a little tough for us, but don't worry, we are about to finish this, and then we go to the last topic, which is very straightforward. So how do we manage paralytic squint? Remember, according non-according, we give glasses, we do surgery. What about paralytic squint? You have to first treat the underlying cause, which is what? The vasculopathy causes, the blood pressure, the blood sugar, isn't it? You have to make first treat that. This takes about 2-3 months. While you are waiting for it to stabilize, remember, we have to wait for 6 months. Why? Because as the underlying cause is overcome, okay? So the sugar, blood pressure is now normalized. So the nerve muscle starts healing, and slowly the muscle starts recovering, but it takes almost 6 months to recover. It takes 6 months to recover, and during these 6 months, patient has double vision, which you cannot tolerate. So while we are waiting for the nerve muscle to recover, we have to manage the diplopia. We have to control the diplopia. It's not easy. How do you do that? The simplest is to close one eye. Remember, it's binocular diplopia. You have double vision with both eyes open. You close the squinting eye. If you close the squinting eye, then the other eye is normal, and they will not have doubling at all. See, this is the squinting eye closed. So with one eye, she's normal. She's perfectly happy. Okay, or you can manage. Apart from patching, for younger patients, we give prisms. Okay, because patching is cosmetically unacceptable to the younger patient. Like, you would not like it if I gave you a patch like that, looking like Captain Jack Sparrow of Pirates of the Caribbean. You wouldn't like that. So for younger people, see, older ladies, old women, old men, they don't mind. But young people like you would definitely mind. So for you people, for managing, we give prisms. So these are glasses made of prisms. They shift the focus onto the fovea, so they can now fuse, and there's no diplopia. This is manageable. And third, you can give botulinum toxin, which paralyzes the eye for about 3 months. So this can also manage the diplopia. So these are 3 ways of managing diplopia while we are waiting for the nerve muscle to recover. Okay. So finally, let's look at the examples of the third nerve, fourth nerve, and sixth nerve palsy. Third nerve paralysis. Remember, third nerve supplies all the muscles except two: LR6, SO4, R3. You all remember the formula? LR6, SO4, R3. So only these muscles, lateral rectus 6, managed by the sixth nerve, and superior oblique by the fourth nerve. These are the only two muscles which are spare when the third nerve gets damaged. Only lateral rectus, superior oblique, the only muscles which are still working. So this patient typically lands up with the diplopia. Obviously, all paralytic sequence diplopia is the most chief complaint, and the famous down and out eye, as you can see here. The lateral rectus takes it out, and the superior oblique takes it down. Remember, superior is depressor, so this is down and out. We call it the boxing position because, like a boxer, we also go down and out like that. Okay, so this is down and out and ptosis. Why ptosis? We're lifting by ptosis because remember, LP is also supplied with third nerve. So down and out in ptosis is how they present to us, third nerve palsy. Okay, and then we have two different types of third nerve. One is called pupil sparing, which means pupil is normal in size. It's called medical third nerve. Why? Because these are caused by diabetes and blood pressure. Remember the vasculopathic causes. But there's one more cause of type of third nerve. This is called pupil involving, which means pupil is dilated. Why should it dilate? Because remember, the parasympathetic fibers are also passing to the third nerve. So when the third nerve is damaged, the parasympathetic fiber is also damaged, so they cannot constrict the pupil. Pupil dilates. Okay, and this is surgical. We call them surgical third nerve because the cause is surgical, because this is a very dangerous cause. It could be aneurysm about to rupture, which damages the third nerve, or a intracranial tumor damaging the third nerve. So both of them extremely dangerous and may be life-threatening. So whenever you have aneurysm, it may rupture. We have to immediately do CT MRI to pick up the aneurysm and tumor before we start treating them. Remember, sometimes this is what is the most common site of tumor causing third nerve palsy. You have to remember easily PCA IC junction. The aneurysm is most commonly at the junction of the posterior communicating artery with the internal carotid artery. Okay, posterior communicating artery, internal carotid artery. These are the two junctions, and one junction, sorry, PCIC, posterior communicating artery with the internal carotid artery. So watch out for this. Third nerve, remember, first diagnosed by how? Down and out in ptosis. Okay, then look at the pupil. If it is normal pupil, it's a medical cause. Do a blood pressure, blood sugar, check it. That will give you the cause. If it's a pupil dilated, it's a surgical cause. Do a CT MRI and try to treat it as fast as possible, because this may take the patient's life. Look at that. So look at this picture. Look at, compared to this eye. Can you see the dilated pupil here? This is a pupil involving third nerve, and this guy has a dangerous intracranial aneurysm which may rupture any time and take his life. So we do a CT MRI fast and try to treat it. Okay. So you have, can you remember, pupil sparing and pupil involving. Treat the underlying cause. How to treat third nerve? So treat the underlying cause. If it's diabetes, blood pressure, treat that. If it's the aneurysm or the tumor, treat that. Okay, you treat the underlying cause. Wait and watch for 6 months while we correct the diplopia. So while we correct the diplopia, wait for 2 months, and as the correction is applied, the nerve muscle recovers and the patient becomes fine within maximum of 6 months. Okay, that's sixth nerve palsy. Third nerve. What is the full recovery it gets after 6 months? What about the fourth nerve palsy? Fourth nerve is a unique nerve. It's one of the most commonly asked questions because anatomical peculiarities that is there. Remember, it is the longest intracranial nerve. Remember, it's the longest at 76 millimeters, 75 millimeters is the longest intracranial nerve. Okay? The thinnest cranial nerve. That's why it gets damaged easily in trauma, and the only one to cross over. Okay, remember, the right fourth nerve supplies the left superior oblique. Left fourth nerve supplies the right superior oblique. Remember, no other nerves behave like this, crossing over like. Okay. So multiple weirdities of the fourth nerve. Longest, the thinnest, the first to be affected in trauma, and the only one to cross over. Okay. So this is the fourth nerve palsy, and remember, typically you have the complete diplopia. Remember, all paralytic screens come to diplopia, isn't it? So these guys, they come to diplopia in the downward inward gaze, particularly while reading. So when you read like this, they have a vertical diplopia or an oblique diplopia. Look at that. This is how it appears, reading like that. So anything when you're looking downwards and inwards, like reading or walking downstairs also. Remember, this was asked recently. So when the patient is walking downstairs, he finds the stairs appearing double vertical diplopia. This is a sign of fourth nerve palsy. So this is how the chief complaint, diplopia on walking downstairs or reading. Okay, and on examination you will find the eye has moved up. Why? Because remember it's a depressor, so you see this eye has moved up. Look at this carefully. One eye has moved up because superior oblique is depressed, it's paralyzed, so the elevator muscle has pulled up. So eye is upwards and the head tilt on the opposite shoulder. Remember opposite shoulder why? This is the left eye, so it will be on the right shoulder. You can't see the head tilt here, but it's there. Okay. You can remember fourth nerve diagnose how the patient comes with diplopia, vertical diplopia on looking down and in, and the position of the eye is upward like this with the head tilt on the opposite shoulder. So right eye, left head tilt, left eye, right hold sheltered because of the crossing over. Okay. So this is the fourth nerve palsy. And again in children, remember it's congenital, adults trauma. Remember it's the most first in trauma. No? So fourth nerve is unique in that it's not vasculopathic causes the most common. Most common is the trauma. You get hit in that. The traumatic cause in adults, but children could be congenital, and therefore the treat the underlying cause, whatever it is, treat the trauma and wait and watch for 6 months while controlling diplopia recovers completely by 6 months. Then the next last nerve palsy is the sixth nerve palsy. Remember sixth nerve is the longest subarachnoid course. Can you remember fourth nerve is the longest intracranial, but the sixth nerve is the longest subarachnoid under the arachnoid mater. That is why it's intimately associated with a lot of intracranial problems. Sixth nerve palsy, remember, particularly in children, may be a dangerous sign of intracranial tumor. Okay? Of course, it has vasculopathic cause also, sixth nerve. But remember, in children particularly, it could be related to a particularly to the central nervous system because it is the longest intracranial nerve. Subarachnoid, sorry, not intracranial, subarachnoid. So what will happen? Remember, sixth nerve gone, so lateral rectus paralyzed. The eye will move inward. No, medial rectus is pulled inwards. So esotropia and horizontal diplopia. So double in vision will be horizontal. So you place one place pen, you'll have two pens like this. Horizontal diplopia, and it's a face out. Okay, so this is a thing where they're trying to eyes in. So in trying to compensate with diplopia, they'll move the face out. Called eye in, face out. This is like the present to us like this. And the causes will be, remember, as I said, in adults, it could be vasculopathic or even a lumbar puncture. LP is a common cause of sixth nerve palsy. But in children, these are pontine gliomas, okay, serious things. As I said, CNS tumors. It could be a pontine glioma. So this is the problem we have of sixth nerve. The cause is again the same thing. Treat the underlying cause, correct the diplopia, and wait and watch for 6 months, and they will be. So we have done the 3 nerve palsies, third, fourth, and sixth. And now the last thing is left is the neuromuscular junction of squint. Neuromuscular junction is the myasthenia gravis, a great mimic. It mimics a lot of disorders. Be careful about myasthenia. So myasthenia, you know, the most common disorder of neuromuscular junction occurs to young ladies and old men. We have antibodies, autoimmune disorder. It forms antibodies to acetylcholine receptors, is it not? So at the neuromuscular junction, there are antibodies to acetylcholine receptors. At the neuromuscular junction, the acetylcholine swims across from the synaptic cleft but cannot find its receptors. So the nerve impulse is not conducted and it cannot cause contraction of the muscle. So this is characterized by muscle weakness because it cannot contract. And this particular weakness, muscle weakness, particularly worsens with exhaustion. So as you go more and more, so from the morning itself, you're trying to fire, and as it fires more and more, trying repeatedly, so it depletes the whatever acetylcholine is being formed. So this characteristic of the myasthenia is that worsens with exhaustion. As the day passes, it gets even more weak muscle, and the first ocular muscle is the LPS, levator palpebris superioris. So you get ptosis which fluctuates. So you have fluctuating ptosis and diplopia. Worse in the evening because, as I said, it increases in the evening because as you go more tired, so the neuromuscular junction is even less responsive to acetylcholine. So, and here you see the fluctuating ptosis and diplopia worsening at night. Okay, fluctuating ptosis and diplopia, it is worsening at night, which means that it is as evenings, morning the eyes are open, but in the evening it becomes ptotic, it increases, the ptosis becomes worse and worse and worse till it closes. Why diplopia? Because remember the medial rectus superior rectus muscles, they are also voluntary muscles, they are not contracting, so they are not able to keep the eye aligned with the other eye, so you have diplopia. So doubling of vision and ptosis worsening in the evening is a sign of myasthenia. Okay, so this is important. And look at this picture here, you see the severe ptosis. the slit-like eyes here. Look at the gloomy expression, the sad, depressed expression, as if she's listening to my class only. But this is the expression not because of my class. Depression, the gloomy expression not because of my class, but because all the muscles are not contracting. So this peculiar look is the droopy eyes and the sad expression of myasthenia. Okay, because the muscles are not contracting. And here the important sign, remember the pupils of the accommodation is paired because myasthenia only attacks the skeletal muscles. Okay, it does not attack the involuntary muscles. So the pupils and the accommodation is paired, which is how differential from the third nerve, and the third nerve will involve the pupil also and the accommodation also. We talked about that, no? So this is when the accommodation is normal and the pupils are normal, it's myasthenia. If the pupils are abnormal, it could be third nerve. Otherwise, they look similar. That's why it's called the great mimic. And we do the tensilon test. Tensilon test is adrophonium, which reverses the blockage. So immediately the ptosis improves, the gloomy expression disappears, all the muscles start contracting. Tensilon test is positive. But the investigation of choice, remember, is acetylcholine receptor antibodies. So when you want to do the most important investigation for confirmation of myasthenia, then you have to do the acetylcholine receptor antibodies. You have to take a serum, and that is the best investigation for as myasthenia gravis. The treatment of choice will be pyridostigmine and oral steroids. Okay, with that we finish the squint, and the next topic, ladies and gentlemen, is going to be conjunctiva and cornea. However, we have just a small break, 5 minutes. Ladies and gentlemen, sorry back. You thought the class is over. It's not over by a long chalk. We still have about half an hour to go. Again, we had some charging issues. You see, the more I charge you up with my ophthalmology and your responses, the less the laptops and all they get, they become discharged. You guys are getting charged up. I'm getting charged up. The laptops are discharged. So we get back, and I know that you're tired. We have another 20-25 minutes. Okay? So please give me that time. Those of you still there, no, and remember, I always keep my promises, except one girl to whom I did not keep my promise. But apart from her, I have always kept my promises. Let's talk about conjunctiva and cornea. And what is the conjunctiva? Remember this: it's a semi-transparent membrane, membrane which covers the entire eyelids and comes the sclera. Okay, so back surface sclera. What is the function of the conjunctiva? Why should it exist? Lubricates and protects the eyeball. Very important, particularly there is a cell in the conjunctiva called the goblet cell, which produces the mucin. Okay, it produces mucin, and this mucin is very important for the tear film stabilization. Okay, we some of you are thanking for the session. The session is not yet over, my friends. Just let me in this good evening, Kajal, and for squint, Maddox rod, etc. We'll answer this. Identify yolk muscles also will answer this, but let me just finish this first. Okay, then we can have a few questions also. The goblet cells produce mucin, important for tear film stabilization. Okay, so we have the tear film. Let's look at that, and the dry eyes. So what happens? Why do you get dry eyes when there are no tear films? And tear film is a three-layered sandwich. There are three-layered sandwich. What is that? The outermost layer is a layer of the lipid layer, which is secreted by the meibomian glands. So that is why the outermost layer is also called the meibum. And why it is lipid? Because it prevents evaporation. It's so hot outside that within a few minutes, if you go outside, the tears would evaporate. So to prevent evaporation, is a layer of lipid which is secreted by the meibomian gland. The second layer is the most important layer, the middle aqueous layer, which is secreted by the lacrimal glands, and it contains all the important nutrients required by the cornea, the glucose, the oxygen, the electrolytes, and the lysozyme. Okay? And the innermost layer was the mucin layer secreted by the goblet cells, which I'm mentioning, and they keep the tear film stable. Tear film stable means what? That it keeps the tear film anchored to the eyes. So have you wondered why the tear film does not drain out of the eyes and into the cheeks? Would be very, very irritating all the time, tears draining down. That's because the goblet cells, the mucin, it anchors the tear film to the conjunctiva. Okay? Right. So the three, and so absence of any of these layers or all of these layers lead to a dry eyes, which you can see here. Look at the congestion. The eye looks very dry and ugly, isn't it? This is called the look of a dry eye. It looks congested, it looks dry, it looks burning sensation. Very, very major problem for us. So let's look at the causes of why should we have for dry eyes. The most common is advanced stage, particularly female patients after 60 because of menopause. At India, as menopause strikes 50-55, estrogen goes down. So female patients have all our older female patients, all our mothers and grandmothers have dry eyes. Males also, but not so much. The lack of estrogen is a major stimulus for tear production. Then a very dangerous cause, Sjogren syndrome, Sjogren syndrome, which is a combination of three things: dry eyes, dry mouth, and rheumatoid arthritis. Please remember the triad. Prolonged contact lens wear. Many of you wear contact lens for hours and hours and sleep with it. This may cause dry eyes. For young people, dry eyes is the most important cause, prolonged contact lens wear. Okay, drug induced. You can have drug induced dry eyes. Okay, certain drugs, particularly antihistaminics, anticholinergics, and antidepressants, they can dog dry eyes. Trachoma, because destroys the conjunctival goblet cells, cannot produce mucin, cause dryness. Vitamin deficiency again damages the goblet cells, cannot produce mucin. And meibomian gland, MGD stands for meibomian gland disease, where the meibomian gland gets damaged, so they cannot produce the lipid layer, and again you have dry eyes. Okay, this is the main cause of dry eyes, of which you should remember age. Remember the Sjogren syndrome classic triad, prolonged contact lenses, okay, and trachoma. These are many important causes. What are the symptoms? Remember, the most common symptom are foreign body symptoms. Okay, foreign body. So the patient already has something, as there's something in the eye, sandy, gritty, burning. Typical says is burning sensation. Jalta hai, they say. So foreign body sensation, burning sensation, worsening in the evening. Why in the evening? Because evaporation takes place the whole day. By the end of the evening, everything's dry. The red eyes, you can see the congestion here. Blurring of vision because there's no tear film on the cornea. The surface of the cornea becomes irregular. This causing blurring of vision, ocular fatigue. Tear meniscus height decreases. All these are signs of dry eye. Okay, so this is how we do it. And how do we diagnose it? By certain tests. And look at the famous Schirmer's test. Schirmer's test. This is how we do it. But before that, we need to know the Rose Bengal test or the Lissaminian. These are stains which test for conjunctival dryness. So Rose Bengal is a pink colored dye. You touch the conjunctiva with it. If it's normal, it won't pick up the stain. If it's dry, it will become pink. This is Rose Bengal dye. We can use a Lissamine green also. This green color. With both of them will stain if the conjunctiva is dry. Okay. However, the more advanced test is the fluorescein stain or corneal dryness. Remember, conjunctival dryness is not a problem. Corneal dryness is a big problem for us. So fluorescein stain, remember, stains the cornea dryness, and these Lissamine and rare Rose Bengal stains the conjunctival dryness. Okay. Then I mentioned the certain tests, particularly the Shermer's test. Remember, so we place these filter paper strips in the eyes for 5 minutes and ask patient to sit in a room, no fans, no ACs, blink normally. After 5 minutes, take out the filter paper strip and measure how much of it is wet. Okay, see, measure the tears supposed to have rolled down the eyes and wetted the paper. If it is less than 10 millimeters in 5 minutes, it's called dry eye. Most of us, we have immediately within a minute, the entire filter paper becomes wet. Tear breakup time, this is the time, tear breakup time. If it's less than seconds, normal tear breakup time is 10 seconds or more. If you have dry eyes, it will be less than. So in 5 seconds, your tear breakup time will again renew. So less than 10 seconds for tear breakup time, less than 10 millimeters in 5 minutes is Shermer's, both 10. Okay, all these are of dry eyes. Treatment, we have to give tear film supplements, and which is methyl cellulose, because once the tears are not produced, nothing can induce formation of tears. We have to give tear film supplements, also called artificial tears, which is methyl cellulose. Okay, and sometimes use cyclosporin eye drop. Also remember, cyclosporin sometimes when there's an inflammatory component of dry eye, we add cyclosporin. Remember, is an anti-metabolite. No, so we have cyclosporin eye drops. This seems to work in several cases of dry eyes. So if they ask for a treatment of dry eye, remember the only treatment is cyclosporin, because tear film supplement is not really a treatment. We are not treating the disease. We are just mandating to supplement it. Okay, so this is the tear film supplements. Xerophthalmia, remember, xeros is dryness, ophthalmia is dry eyes, but xerophthalmia is a term for the entire spectrum of disease in the eye due to vitamin A deficiency. So we have, when you have vitamin deficiency, the World Health Organization classified into 8 stages. We have 8 stages of xerophthalmia, dry eyes, starting with 1. So let's look at the 8 stages of xerophthalmia. First one is XN. You all remember this well, I hope. XN, early stage is night blind. You all know that the earliest symptom of vitamin deficiency is night blind. Then X1A, conjunctival cirrhosis. X1B, white dot spots, very famously asked because you see this foamy white on secretions, foamy white elevation in the conjunctiva. X2 becomes corneal dryness. X3, the corneal or collagen starts melting away, so develop small corneal ulcers, and they coalesce together, they collect together, and the entire cornea melts away, called keratomalacia. X3A, less than 1/3, X3BA, more than 1/2. XS, corneal scarring, and finally XF, xerophthalmic fundus. Okay, so remember, likely most of the time you get white dot spots as a pictorial question. You have to identify them. So 8 stages of dry eyes: XN, night blindness; X1A, easy to memorize, not difficult, as it increases in vitamin A deficiency severity. XN, night blindness; X1A, conjunctival cirrhosis; X1B, white dot spots; X2, corneal dryness; X3A, keratomalacia, less than 1/3; X3B, more than half; and finally XS0, which is called scarring, and xerophthalmic fundus. Okay, all you have to remember is the management is to give vitamin A into one particular dose. You have to remember for any child or adult more than 1 year of age, more than 12 months. You have to remember at least one. You give 3 doses of 2 lakh international units of vitamin A. Okay? 2 lakh, 2 lakh, 2 lakh. First day, day 0, 2 lakhs. Second day, day 1, 2 lakhs. And 14th day, 2 weeks, 2 lakhs. 2 lakhs, 2 lakhs, 2 lakhs international units of vitamin A. So it will cure. Or if for children smaller than 12 months, we have to half the dose. These are oral dosage where we require more than 20 micrograms per deciliter. That's, you don't have to memorize the figure, just for 3 doses, just for academics. 20 micrograms per deciliter is the ideal vitamin A, serum vitamin A. Remember, so we test for serum retinol. Remember, how do you test for vitamin A? You serum, ask for serum retinol. The lab, if it says vitamin A, they won't understand. It's not, it's retinol. So then we go to the conjunctival degenerations, the most famous of which the triangular degeneration of conjunctiva. Look at the conjunctiva climbing over the cornea like a triangle, like a bird's wing, which is called the pterygium. The name bird's wing, the pterygium means like a wing, like wings of a bird. It climbs over the cornea and causes loss of vision by astigmatism. Okay, because it pulls the cornea here and there. It may cause astigmatism, loss of vision, or it may climb over the pupil and cause blurring of vision. Okay, so but the more invisible cause and the more common cause of loss of vision is astigmatism by pulling the corneal line. What else apart from this? You can get the Stocker's line. So there is a line here at the head of the Sometimes it's visible, not always. This is a very popular question. Stocker's line is a line at the advancing leading edge of the pterygium. The deposition of iron. Iron comes from the tears. It pools there. This collection of iron on the leading edge is called the Stocker's line. Okay. And treatment, we have to excise this, but because the recurrence rate is so high, we have to borrow conjunctiva from the other eye. So we have pterygium in the right eye. I first shave it off, excise it, and then borrow conjunctiva from the other eye, borrow that and stick it here, either with sutures or with glue. We call this conjunctival autograft for the same patient with the least recurrence. So remember, we like to ask this question because pterygium excisions have a lot of recurrence, okay, 70% recurrence. So to prevent this recurrence, the best surgery is to excise and borrow the conjunctiva from the other eye and put it here. So this is the least amount of recurrence. The least amount of recurrence. This is what happens. So you have to know the surgery. What else? Then the pterygiums are done. Then we do inflammation of the conjunctiva, which is conjunctivitis. Inflammation of the conjunctiva is conjunctivitis. Look at that redness of the eyes. So what you have? You have a bright red color, which is painless, and there is some discharge, okay, which means the secretion that comes out of the inflamed conjunctiva. We divide them into 3 different types of discharge. It can be serous, which means clear water. This is in viral condition. It could be bacterial. In that case, it is purulent. So purulent discharge, bacterial, serous discharge, which is viral, or it could be a mucoid discharge with stringy and elastic, which is a allergic conjunctivitis. So remember, out of all the conjunctivitis that we have 2 different types. One is called infectious, one is non-infectious. Infectious can spread very fast, and the most common is viral conjunctivitis. Remember, bacterial conjunctivitis is not very common. Viral, of which the most common is caused by adenovirus, which causes the adenovirus. This is the most common. I'm not. No, this is adenovirus, the most common. Okay, or you can have the most common adenoviral conjunctivitis, the famous is called EKC, is caused by, I'll continue, no? So EKC is epidemic keratoconjunctivitis. EKC, which is the most dangerous because it spreads like an epidemic. It's caused by adenovirus, remember, called pink eye and Madras eye because of the color. There's nothing to do with Madras, okay? So my friends from Chennai, I'm so sorry, but this got nothing to do with Chennai. So Madras eye, this is the most dangerous of all conjunctivitis, spreads like rapid fire, like wildfire, and typically identified by persons in the same community. So people working same office, the same hostel, the same dormitory, same office, the same family. Okay? A 7-year-old girl comes with red, painless eye. Last week, her sister had the same condition. What is the diagnosis? Because her sister had it, so it means she had EKC. The same community, EKC. The second type of conjunctivitis you should know is the AHC. This is known as acute hemorrhagic conjunctivitis, which is in younger people and caused by enterovirus 70. Remember, this is not Apollovirus, it is enterovirus 70. It is not adenovirus, sorry. It's caused by enterovirus, also called as Apollovirus or Apollo 11 virus. Okay. Remember, EKC is the most dangerous, caused by adenovirus. AHC is also infectious, but not as much as EKC, caused by enterovirus, also called as Apollo virus or Apollo 11 virus, not because of Apollo hospital, but because of the Apollo 11 moon landings. Okay? So these are 2 different types of viral conjunctivitis. These are infectious. Then the most dangerous, of course, of all infectious conjunctivitis is the trachoma. Look at that. Again, you can see the congestion. This is actually keratoconjunctivitis. That means cornea as well as the conjunctiva both are inflamed. Trachoma is caused by chlamydia trachomatis and the serovars A, B, B, A, and C. 4 serovars. Okay. Remember, they are from T till K, then L1, L2, L3. So trachoma is caused by these 4 A, B, B, ABAC. Okay. Remember, there's a back. They cause trachoma caused by chlamydia trachomatis, and it is the most common infectious cause of blindness. You know, this is the common infection is caused by corneal scarring. And what are the risks? Why will you have conjunctivitis, trachoma? Because of areas poverty. Okay, remember, these are poor people, overcrowding, poor water supply, poverty, endemic areas, lack of hygiene, lack of toilets, people living together. Those they are seen in the poorest, the marginalized people living in slums. Typically they have trachoma. Disease of overcrowding, lack of sanitation. Okay, and you see the same redness and photophobia and watering that you see in normal conjunctivitis. There's nothing specific here. And And remember, the children of women are put first. First, number one are children, and women's number two. Why? Remember, children are the least neglected or the most neglected, beg your pardon, in a poor community where children are most neglected because they do not contribute to the family purse. So they are number one, and victims, women, number two, because they are with the children. The men have no idea of their families, so they do not get affected by trachoma. The hallmark is the famous sago grain. Remember follicles, sago grain, sabudana. Follicles, the follicles look like white sabudana grains, which many of you may have seen. And the Herbert spits, remember the upper depression, the upper lid depression. Ask the patient, look down, you will find these black depressions on the upper limbus called Herbert spits, very specific for trachoma. Remember, Herbert spits are seen in trachoma. And the famous Arl's line, look at this white line on the upper palpebral conjunctiva, the Arl's line. Do not confuse this with the Arl's triangle of keratic precipitates and anteuveitis. Arl's line is the fibrotic scar seen in trachoma, isn't it? So these are multiple questions here. And then trachoma has the late sequelae which causes the blindness, the trichiasis, which is the posterior misdirection of eyelashes turning inwards. It goes trichiatic cilia, the tylosis, which is thickening of the lid margin, tylosis, thickening of the lid margin. This is tylosis, madrosis, loss of eyelashes, you lose your eyelashes, okay? And many of you are losing your temper with me also because the class is not finishing, but we have another 10 minutes to finish. We'll do that fast. Madrosis. Madrosis, the loss of eyelashes. Okay, if you have madrosis. Multiple problems, and entropion, where inward rolling of the lid margin. Okay, inward rolling of the lid margin, so the eyelash rubber gets. So both, remember, trichiasis is just the eyelash rubbing against the cornea, but this is entropion, is the inward rolling of the lid margin, which turns the eyelash inward, rubs against the cornea, because of which these opacities are formed. Nebula, macular. Nebula is the most superficial. It's very hazy, very superficial opacity. Macular opacity is named when it's half thickness opacity, and leucoma is given name as full thickness opacity. Okay, three kinds of corneal opacities. Leads to dryness of eyes because damage to the goblet cells cause dry eyes in trachoma. And the classification WHO Fisto classification, remember, stage 1, follicles more than 5, number 5 follicles more than 5 in the upper tarsal conjunctiva, called grade F. Grade 2, I for intense inflammation, where 50% of blood vessels are obscured inflammation. So then, when the intense sufficient to scar obscure 50% of tarsal vessels, this is grade I. S for scarring with the appearance of the Arl's line, which signals the healing process. T, even if one eyelash turned inward, trichiasis is T, and O for corneal opacity, nebula, macular. The Fisto classification, remember, the most blinding stage is the stage of when it turns intense, when it turns inward, leading to scarring, and trichiasis. Trichiasis is the stage which is most dangerous because this may cause blindness by impairing corneal opacity. But overall, the most highly infectious is the intense phase, I phase, where it becomes 50% vessels are obscured. So Fisto. And then finally, trachoma, also called the Egyptian ophthalmology, remember, one of the rare diseases to be named after a country. And the drug of choice is azithromycin. Remember, a trachoma is one drug, very wonder drug, one drug, oral drug, only 1 gram azithromycin. If you want a topical, 1% tetracycline twice a day for 6 weeks. This is the old treatment. People who cannot afford azithromycin, is a little expensive. We give 1% tetracycline ointment twice a day for 6 weeks. Okay? This is a trachoma. Safe strategy, remember, S for surgery for trichiatic cilia. So you either pull out the eyelashes or do electrolysis. S for surgery. A for antibiotics, remember, drug of azithromycin. F for face washing. If you keep your face clean by washing with water, you remove all the crusts, and it prevents trachoma. E for environmental sanitation. Keep environments clean. So remember, no dirty, no lack of sanitation, no fecal matter lying around, then there will no trachoma. So safe strategy, wonderful strategy for preventing trachoma, which has eradicated trachoma in a lot of countries. The blanket therapy, which is 1% tetracycline twice a day for 5 days, or once a day for 10 days in a single month. Okay, so remember, this is an interrupted therapy. So what you do, 1% tetracycline ointment twice a day for 5 days, or you can give it once a day for 10 days. It's the same thing. Twice a day for 5 days, the same, once a day for 10 days, but for only 10 days in a month. So January 1st to 10th, and then from 10th onwards, no tetracycline. Again, February 1st to 10th, then next 20 days, nothing. March 1st to 10th. So it's interrupted. First 10 days in a month for 6 months. Okay. This is called the blanket therapy, also called the mask therapy, which is used to eradicate trachoma in endemic zones, hyperendemic zones. So then the next conjunctivitis, the last conjunctivitis of the lot, okay, this is the only one that is the allergic one. Okay, remember the others are all infectious. This is non-infectious, allergic, and of which you call spring catarrh. Remember the word catarrh means inflammation. It occurs in the spring, but it's not really spring because we don't have spring in India. We have only summer and winter, and in the south we have three climates: hot, hotter, and hottest. Isn't it? So it's in the hot summer months of India, or in Africa it's also found from the hottest months, right from April to November. April to October, 6 months is a highly allergic conjunctivitis of the kids. Remember, the children. It's seasonal and recurrent. That means it occurs again in this particular season, which is the hottest months from April to October. These children start itching their eyes. In the hot summers of India and Africa's Mediterranean countries, these kids start rubbing their eyes. Itching is the single most important symptom here. For redness, photophobia, tearing, it's a terrible condition. Okay? Always a child is rubbing his eyes. Many of you have had this thing as kids. You know, as you grow up to be teenagers, it goes off. Okay? Allergy burns off. The hallmark is the famous cobblestone papillae, giant flat papillae. This is the hallmark, just like trachoma had Theogran follicles, they have cobblestone papillae. The Horner Tranta spots are white dots on the limbus, which are collections of eosinophils. An allergic condition will have eosinophils. And the shield ulcer, the ulcer shaped like a shield like this. Okay, very famous ulcers. In VKC, you call VKC also, vernal keratoconjunctivitis is the same as vernal catarrh. Remember, these allergic, but not in spring, in summer. Shield ulcer treatment is to be treated with initially mast cell stabilizers, which are anti-allergic drops, and later on we can give topical steroids. If it doesn't work with sodium chromoglycate, which are mast cell stabilizers, then the second step is topical steroids. But remember, steroids can cause for long-term use after we can get cataracts and glaucoma, so watch out for that. That's spring catarrh. And then we come to the Vision 2020, which is a program envisioned which will start in 2000, ran for 20 years from 2020. And the aim of Vision 2020 was that everybody should be 2020 by 2020, which means by 2020, everybody should be 6 by 6. Remember, 20 by 20 is what they write in US, or 6 by 6, because they measure not in meters but in feet. So 6 by 6 is 20 feet by 20 feet. It means that everybody should be 6'6" by 2020, which could not be achieved because it's already 24 now. It will extend to 2030 now. So how do we reach 6'6" by everybody by 2020? By eliminating the 5 major causes of blindness: cataract. By how? Getting operated. Trachoma, by safe strategy, you should eliminate that. GET 2020 refers to global eradication of trachoma by 2020, which could not be achieved. Now it's been pushed to 2030. Even now, 50 countries almost still have trachoma. Okay? Trachoma by safe strategy. Vitamin A, childhood blindness, eradicate by vitamin A supplementation. Refractive error by wearing glasses, many of which you do not wear glasses. And onchocercus river blindness, which is not in India mercifully, is found only in West Africa. How would eliminate that? By giving ivermectin. So, billions of dollars of ivermectin were distributed freely in trying to eradicate this, could not be done. In India, we don't have onco, so Indians have a different response of a variety of Vision 2020. In this scenario, we have, instead of onchocercuses, we have corneal blindness, we have glaucoma, and we have diabetonopathy. These are the 3 things the Indian government has taken on itself, trying to eliminate instead of river blindness, which thankfully we do not have in India. Okay? So this is Vision 2020. Now we come to the last few topics of cornea. And with that, the tragedy is going to end. So we're going to just, if you have another 10 minutes, ladies and gentlemen, I know that many of you are taking off your shoes, to throw at me. Cornea, with the 5 layers of cornea, remember, we have these 5 layers of individuals. So the outermost layer is the epithelium. Okay, the outermost layer is the principal refractive surface, the protective barrier, and it is the thinnest and remember 540 microns average I told you, which is thickest in the periphery, central is thinnest. Power of 43 diopters, mean optical level, remember 70% contributed to the power of the eye. 5 layers of which outermost epithelium, and which is region by stem cells. Remember, stem cells region the epithelium, and which are lying in the limbus. So kindly remember, where this is a possible MCQ, the limbus carries the stem cells, and these where exactly in the limbus, called palisades of Vogt. This is for NEET PG and NEET set, gentlemen. Palisades of Vogt are these vertical columns which are in the limbus, and they are the exact location of the stem cells of the limbus, which they degenerate the epithelium. Okay, and if you lose the limbus, then you cannot have conjunctiva regeneration again. So you damage epithelium, it will not grow back again. Okay, so please remember, epithelium is very important, the outermost layer, because it prevents the entry of all the microbes, acts as a guard to prevent corneal ulcers. The epithelium should always be intact. Okay, so that is the epithelium. The second layer is the Bowman's layer. B for second, bow, A comes B comes A. Bowman's layer, remember, cannot repair itself, leads to corneal scar. Very important. Which destruction of which layer causes corneal scarring is Bowman's layer. Third layer is the 90%, the stroma, which contributes the framework of the cornea, is 90% is the stroma. Remember, this is the principal infrastructure of the cornea on which the cornea is built, thickest layer. The fourth layer is the Descemet's membrane, which is one of the strongest layers of the cornea, allows only a fungus. Remember, only fungus can paint the intact Descemet's, all others cannot paint Descemet's. And the innermost layer is the endothelium, which is the most important layer of the cornea. The innermost layer is the endothelium. Why the most important? Because it is the one which maintains transparency, because it contains the endothelial pumps. It contains the endothelial pumps. The endothelial pumps. It maintains the transparency. And how? Because these endothelial pumps, remember, which are sodium, potassium, ATPase pumps. These are sodium, potassium, ATPase pumps, and they pump the aqueous out. So that is why they maintain the corneal transparency. This is the single most important job of the cornea, is to maintain transparency. That's why endothelium is the most important layer. But unfortunately, endothelium also cannot regenerate. So if you have damaged endothelium, the aqueous would enter the cornea, cause irreversible corneal edema. Remember, so there are two important irreversible membranes in the eye. Okay, there are two important membranes in the eye. The stroma, the endothelium, which causes corneal edema, and the Bowman's membrane, which causes corneal scarring. Okay, so there are two membranes. And about 10 years back, another new layer was discovered in between the Descemet's layer and the stroma, because lying between the Descemet's and the stroma, it was called the PDL, the pre-Descemet's layer, also named after its discoverer, called Dua's layer. It was discovered after Dr. Harminder Singh Dua. Okay, so we have some requests here. So we have good evening, Abhishek. We have Terragems, and we will provide the PDF. Yes, remember, the PDF will be provided after the class on Dr. Banu's Telegram channel. Okay, so you will get the PDF here. And we have an expression for NEET set after the NEET. Okay, very well. We'll do a session for NEET set, and the PDF will mention. Okay. So how many questions, Dr. Sayed? I mean, that is only Khuda can answer that. I cannot say. But you should have majority of your questions being answered by this particular PDF. Okay. Then, remember I told you, two irreversible cornea, Bowman's membrane causes corneal scarring, endothelium causes corneal edema. The rest can repair itself, not these two layers. And the endothelial count, remember, we have to count number of endothelium cells. You have to remember 3 count. 3,000 cells are present. There is a single layer of endothelium cells, which are 3,000 cells per square millimeter. And each year we lose some cells. So if the number of cells reach 500, this is called as critical density. Why? Because less than 500, there are not enough endothelium cells to pump the aqueous out. So the aqueous would enter the cornea and cause irreversible corneal edema. So remember, we can ask this condition. This question is, which is the minimum number of cells which can keep the cornea clear? The minimum number of cells to keep the cornea clear is 500. This is critical density, and for corneal donations, we need at least 2,000 cells per square millimeter. For corneal donations, at least, remember, if you want to donate your corneas, you should have at least 2,000. Less than that, we will not take your corneas. Sorry. Okay. And then, so we come to keratoplasty. So what happens? Suppose there is damage to the endothelium. The number of cells are less than 500. So the aqueous humor cannot be pumped out. So all the aqueous rushes into the cornea, causing irreversible corneal edema. The only way, because endothelium cannot regenerate itself, the only way to do this is to replace the cornea, called as keratoplasty. Keratoplasty can be done for two different types. Okay, one is for optical keratoplasty, which means for vision. You have penetrating keratoplasty, PK, or lamellar keratoplasty, LK. Penetrating means all 6 layers are transferred. Remember, now we have 6 layers because of Dua's layer. Penetrating means all 6 layers are transplanted. Lamellar means only the outermost layer transplant. Okay? Only the outermost 3. The inner layers are the patient's own. Remember, corneal transplants are all successful, but the most successful is LK. Much more successful than PKs or LKs. Why? Because the maximum rejections take place against the endothelium. Okay. Remember, so if you do have rejections, remember cornea is the highest transplant success rate because it has no blood vessels, avascular, so there are no blood vessels and there are no lymphatics. So it cannot reject, but it does reject sometimes. And most of the case rejection is against the endothelium. Can you remember that MCQ? Most rejections take place in the endothelium. So PKs can still reject because in PK, even the endothelium is donated from somebody else and the eye is somebody else's. So endothelium can reject. But LKs are reject very rarely because the innermost 3 layers are the patient's own. So you cannot reject against yourself, is it not? So LKs are more successful because of the rejection against the endothelium. The LKs are more successful, but they're also more difficult for us. And for most common indications for keratoplasties is pseudophakic bullous keratopathy, where you have damage to the cornea because of IOL implantation damaging the endothelium. So you develop, this is the world's most common, we call it PBK, pseudophakic bullous keratopathy. Okay? While implanting an IOL, you damage the endothelium. And in India, we have corneal scars and non-healing ulcers. They're the most common in India, but you can have keratoconus also. So this is the optical keratoplasty of the 2 types, PK and LK, but we have another keratoplasty called therapeutic, where we transplant the cornea to save the eye so that the eyeball is not lost. You see, sometimes you have active infection, it may cause corneal perforation, everything would come out, the globe would be lost. To save the cornea, we have to, or to repair the structural defect as in a corneal melt, we sometimes replace the cornea, which does not give much vision, but it protects the structure of the eye by sealing the eyeball in so that you do not lose the globe. This is for therapeutic keratoplasty. Remember, the most common indication is for microbial keratitis. When you have a corneal ulcer which is perforating the cornea, then we may have to do a therapeutic keratoplasty. This is not meant for vision. Most common need for therapeutic keratoplasty, as I said, is microbial keratitis, bacterial infection, which is unmanageable. So a quick word to corneal donations. I hope all of you donated. If not, please start donating, all of you, because we have very few donors in India and we are waiting. There's a waiting list, a huge waiting list of these corneal blind people. So no age limit for donation, but less than 75 years are the best corneas. Children can donate, adults can donate, old people can donate, but best corneas are less than 75 years of age. Within 6 hours of death, you have to donate because after that the endothelium starts dying out. Endothelial count, as I mentioned, has to be more than 2000 cells per square millimeter, otherwise we cannot take the cornea. And we preserve the eyeball in a media called MK media, which stands for McCarry-Kaufman media, which preserves the eyeball for 4 days. This is the most common media, but we have other media also like Optisol GS and Cornisol, which are longer duration, 7 to 14 days, but they're more expensive. The most common in India we use is MK media, which has a shorter duration of preservation of the eyeball. And contraindicated donation, remember, you cannot donate your eyes if you have death because of HIV, hepatitis B, rabies, septicemia, Creutzfeldt-Jakob, retinoblastoma, and death of unknown cause. So if patients we do not know the cause of death, we cannot take their eyes because we do not know what they may have died of. Okay, so these are certain contraindications of keratoplasty, which will not take that. Then a quick word about keratitis, bacterial keratitis, corneal ulcers. So remember, bacterial keratitis, and this is how it looks like. The risks of are trauma to the eye, contact lens wearing, loose stitches, dry eyes, exposure keratopathy. All these are vitamin A dose. I've got a question from Karthik Sahu on please type in vitamin A doses. Vitamin dosage, we talked about this. Okay, let me just finish this first, then we'll go back to these questions. We'll take it in 10 minutes. Okay, we'll take these questions because we need to finish this first. So this is the why trauma, contact lens wear, exposure keratopathy, etc. No, so these are problems we have. And what is the bacterial keratitis? Bacterial keratitis, remember, the most common cause worldwide is Staph aureus followed by Pseudomonas. Okay, Staph aureus and Pseudomonas are the most common cause. But in India, remember, the commonest cause are not Staph. It is Streptococcus. So kindly, sometimes we ask India specific questions. We have staph. This is Streptococcus pneumoniae. Strep pneumoniae is India's most common cause, also called as pneumococcus, and we also call it as the ulcus serpens because it moves like a snake. The progress of the ulcer is like a snake, sometimes called ulcus serpens, also called a hypopion corneal ulcer because it causes a lot of hypopions. Remember, hypopion corneal ulcer is not any ulcer with hypopion. Hypopion corneal ulcer is specifically the name for a streptococcal ulcer. This is the name for that. Okay, so these are bacterial ulcers, and the most common contact lens induced ulcer, kindly remember, you all know that, is Pseudomonas. That is the most common contact lens induced ulcer. That is Pseudomonas, we have them. And the bacteria penetrating the intact epithelium. There is, normally you have an injury and then you can have bacteria, isn't it? But bacteria penetrating intact corneal epithelium, there are 2-3 which you must remember: Corynebacterium and Neisseria, both meningitidis and gonococci. Remember, Corynebacterium is what we like to often ask you. This is the same thing causing diphtheria, which can penetrate intact epithelium. So without an injury, you may have a corneal ulcer. Very dangerous, is it not? Drug of choice are we have the fourth stage, there's a classification. We have the fourth generation fluoroquinolones, which is moxifloxacin and gatifloxacin, which are those drops when you use them. For bacterial keratitis, for acanthamoeba keratitis, look at the famous ring-shaped ulcer. You can see the ring-shaped ulcer here. And it is the most common is a contact lens wear. After Pseudomonas, contact lens wear induces keratitis, but you can have it by washing in tap water. Okay, particularly if you wash your lens in tap water, or exposure to contaminated water. Taking a bath in contaminated water, streams and ponds which have been contaminated by the animals moving into them. And also remember a history of suspected HSV carrier. Remember INSET question, please remember, whenever you have contact lens wear, you suspected that looks like a herpes simplex virus but is not responding to antivirals, think of it as a acanthamoeba. It looks very similar to herpes simplex, and contact lens wearers, whenever you don't heal to HSV suspected carrier with acyclovir, you have to think of this very important MCQ. Acanthamoeba. Remember, all dendritic ulcers in contact lens wear should be suspected. Dendritic, they look like dendritic ulcers, so we think they're virus, but they're not virus. They're actually acanthamoeba because they're contact lens wearers. And the pain, they're very severely painful. They're the most painful ulcers. We call them pain out of proportion. Look at this famous ring-shaped ulcer and radial keratinuritis. That's why they're painful, because the nerves are infiltrated with acanthamoeba. It's called radial keratinuritis. Nerves infiltrate with the corneal nerves are infiltrated with the acanthamoeba, and epithelial stippling, which means appearing like this, small white dots on the cornea. And you can see pseudodendrites. Remember, in acanthamoeba we have pseudodendrites. Again, NEET PG friends, pseudodendrites, true dendrites are found in viral keratitis, pseudodendrites are found in acanthamoeba, herpes zoster, contact lens wearers. But true dendrites are found only in herpes simplex. Okay. So these are acanthamoeba keratitis questions. Drug of choice PHMB, polyhexamethylene biguanide. You have to make it in a laboratory. Propamidine and chlorhexidine. Okay? We like to ask you polyhexamethylene biguanide. This is the drug of choice. And what about fungal keratitis? The famous, you can see the satellite lesions here. Note the satellite lesions here. Fungal keratitis drug, the ones that cause most common organisms fungus are Fusarium and Aspergillus. And they are filamentous fungi. They are found, remember, most in South India because of warm climates, a lot of rainfall encourages fungal growth. So the typical risk factor is organic vegetable matter, injury with organic vegetable matter. So you get a rice husk falls into the eye, you rub your eye with the leaf of the tree, some flower gets into the eye, get hit with the cotton, whatever, injury with organic matter, or prolonged topical steroids. You've been provided 1 week, but you put it for 1 month, you will get a fungal ulcer. Okay, these are 2 risk factors. Remember, signs more than symptoms, because there are no symptoms. There's no pain, redness, watering, loss of vision. Okay, pain is very comfortable, no symptoms. But the signs are visible to the ophthalmologist. You can see the infiltration, the famous finger-like projection. See the finger-like projection is like somebody's digging fingers in the surrounding stroma. Finger-like projections, feathery margins, fluffy feathery margins like a feather, and the famous satellite lesions. Okay, look at that. Small nodules of ulcer surrounding the main ulcer, satellite lesions. Diagnostic of fungal ulcer always asked as a question, remember, because we have so difficulty treating them. Drug of choice natamycin, and you have discontinued all steroids. Remember, steroids, you have to, there is a steroid, which is prolonged steroids, which is the cause of the ulcer in the first place. You have topical, discontinue all of them, taper it off. Okay, the fungal keratitis. And the last one is the herpes simplex keratitis. Look at the famous dendrites, like the branches of a tree. Remember, I said herpes simplex virus causes only 2 dendrites. Okay, the type 1 herpes, they usually can be either primary, but most commonly they are reactivated. That means you already have herpes in the body and it's reactivated, okay, because of stress, contact lens wear, trauma, or sun exposure. So you already have herpetic somewhere in the body. It's reactivated by these kinds of stress or contact lens wear. Okay, and they are famous. There are 3 types: epithelial keratitis, stromal keratitis, and endothelial. But it is the epithelial keratitis that we like to ask most and the most common. And this is called as dendritic ulcer. Look at the dendrites, like the branches of a tree. Remember, branch of a tree. They are the only 2 dendrites. Can you remember? I just mentioned herpes simplex has 2 dendrites. Herpes zoster has 2 dendrites. Acanthamoeba pseudodendrites, contact lens wear pseudodendrites. But the only 2 dendrites are in viral keratitis. This is herpes. So I can remember all the 4 names of the shapes. Okay. So no, fungal causes finger-like projections with fluffy feathery margins with satellite lesions. Herpes has dendritic ulcers like the branches of a tree. Acanthamoeba has ring-shaped ulcers, and bacterial has alcocerbs. Kindly remember, the shapes are important here. Always important, but particularly here. Loss of, a very important question, loss of corneal sensations. Again, there is some voice problem, it seems, friends. Is it okay? I'm getting a thing that there is आवाज नहीं आ रही again, you know. खुदा की आवाज आ रही है, but मेरी नहीं आ रही. No, I'll just adjust this. The loss of corneal sensation. No, so when you touch the eye, there is no sensation. You compare with other eye, you can feel it. Okay, this is a loss of concentration. Remember, this is a very important characteristic of herpes simplex. Treatment, topical acyclovir. Okay, so drug of choice, we've got that. And what about the other herpes, which is herpes zoster? Very, very dangerous herpes zoster ophthalmicus. But remember, this is not caused by the same herpes simplex virus. It is caused by the varicella zoster, which is the one that caused chickenpox. We've all had chickenpox. It's lying dormant within your body. It's healed. It's lying dormant in your body. Now, like lying dormant like Kumbhakarna, and one day it will rise again and attack as herpes zoster. Okay. So it is reactivated in which kind? Why will it rise again like Kumbhakarna? Because it is immunocompromised patient. People with diabetes, with HIV, with radiation therapy, and they're older patients, okay, above 60, so they have poor immunity. So zoster is primarily a disease of immunocompromise. People with normal immunity will not have zoster. Okay, so older patients, and so people with radiation therapy, with steroid therapy, with cancer therapy, diabetics, older patients, they develop zoster. What happens if zoster in a young patient? Can you remember? Kind of HIV. Very important. Whenever you see a zoster in a young patient, which is less than 45, you must do a HIV test like Tridot or Western blot or ELISA. Mandatory FDA guidelines, we have to test for HIV because this is the most common immunocompromised condition of young people nowadays is HIV. How do you diagnose? By unilateral, one side only, because of dermatomal distribution, painful vesicles along the dermatome of the trigeminal nerve, is it not? Very, very famous. The famous sign Hutchinson's, you can see. I hope I have a picture. Yes, we have a picture of the zoster here. Look at that. Only one side affected, never the other side. Dermatomal distribution of the 5th nerve. And we have these vesicles, blisters. And Hutchinson's sign is the tip of the nose affected. The eye will be affected also because of the nasociliary branch serving both the tip of the nose and the eye. Okay, this is the Hutchinson rule, Hutchinson sign. And the, remember, very dangerous condition called PHN, post-herpetic neuralgia. One of the most painful conditions known will occur if you delay the treatment. The risk of PHN, which occurs if you treatment, unless treatment within 72 hours, if you delay treatment for more than 72 hours, the chances of development of HZO become very high. Okay, 72 hours. This is a very, very painful condition which occurs usually after 3 months of zoster. We call it PHN, post-herpetic. Treatment, very high dose of acyclovir, 800 milligrams, 5 times a day for a week. Which is very, very dangerous. So zoster, you can see how dangerous it is, particularly for younger people where it is a sign of HIV. Okay, the zoster ophthalmicus. And we're about to finish now. So after zoster, what is the harvest coming up? And I think this is really the last slide coming up. I mean, last conditions, but please do not go. I'll answer your questions that have been asked in the last few minutes, and we can ask me further questions also. Keratoconus, one of the most dangerous, where the cornea becomes conical. Instead of being a spherical part of a sphere, the cornea becomes conical. But why? Because it is very thin. So the two problems of keratoconus, it is thin and it is weak. So because it is thin and it becomes weaker, so it becomes conical. So not only is it to become thin, it also has to become conical. Both have to be there. Keratoconus occurs, it's a non-inflammatory, remember there's no inflammation here. Bilateral, progressive corneal ectasia with central thinning. Ectasia means protuberance of the eye in a like this. So whenever the cornea becomes more protuberant, we call it ectasia with thinning. And the most important risk factor is rubbing of the eye. Some of you are rubbing your eyes in disbelief as looking at the length of this class, but that's not the rubbing I meant. Allergic rubbing, okay? When you rub your eyes too much, then it may cause keratoconus. So stop rubbing, even in disbelief. And adolescence, so usually it occurs around 15, 16 or so. It occurs 15 years of age, and it can progress until the mid-30s. So where it becomes thinning and thinning and thinning, cause blurring of vision with repeated change of glass. Remember, that is the clue. Patient complains of frequent change of glasses. So those of you who are frequent change of glass, at your age you should change glass only once a year or once in 2 years. If you're changing your glass every 3 to 4 months, this is a sign of keratoconus. Okay, sign of keratoconus, frequent change of glasses, it's a very important sign. And you have irregular astigmatism and asymmetric astigmatism with scissor reflex. Scissoring means on retinoscopy. Remember, we talked about retinoscopy. We have against movement like this, or we have with movement like this. Scissoring means the reflexes like scissoring like this. Okay, called scissoring. They behave like this. Scissor reflex. This is one of the earliest signs on retinoscopy of keratoconus. And irregular astigmatism. Remember, it can be controlled with keratoconus. I told you contact lenses, so that's irregular astigmatism. Asymmetric means the cylindrical axis completely off. Okay, so this is astigmatism. And Munson sign, a very important sign, ask me to look down like this, and you will see notching of the lower lid. See the cone, but push the lower lid like this. It pushes the lower lid like this, and it causes a notching or wedge-shaped defect of the lower lid. This is on looking down. Okay, so this is the keratoconus. Vogue striae. Remember, the second striae finally reappears. I told you Hab striae was the parallel railway tracks in congenital glaucoma of ophthalmos. Here, Hab striae are the vertical folds like this. These are Vogue striae in keratoconus. So Vogue striae is keratoconus, and in this is the Hab striae in congenital glaucoma, Vogue striae in keratoconus. Can you remember two striaes in ophthalmology? Next thing is the famous Fleischer's ring. Remember, epithelial ring on the base of the cone. Surrounding the base of the cone, you have an epithelial ring called the Fleischer's ring. Do not confuse the Kayser-Fleischer ring. KF ring is Wilson's disease. Fleischer's ring is keratoconus. So be careful about these three important Wilson's, Vogue's, and Fleischer's ring. And then how the treatment is 3-step. First, to start with glasses. Okay, because they have frequent change of glasses, you keep changing glasses, but after some time you have to resort to contact lenses because the cornea is so conical that glasses cannot help it. And the contact lenses are not the soft contact lens that you wear, because if you wear a soft contact lens, they're so soft they'll take the shape of the cone. So in contact lens we have lenses called RGP, rigid gas permeable. Rigid gas permeable, they do not shake over the cone, and they make the cornea again spherical. So this is the RGP lenses. And finally, if you have corneal scarring, then we have to do keratoplasty. The 3-step management. Latest treatment now you have to remember is the collagen cross linking with riboflavin called CXL, also called C3R. This is the 3 C's, where we radiate the eye with ultraviolet light. Okay, so with light, and we have to put riboflavin drops. So this combination of the riboflavin and the ultraviolet light, it creates more bonds in the cornea, so it becomes more stiff. So it does not progress any further. So why it becomes conical? Because it's thin and it's very soft. So by introducing more bonds, we make it stiff and it stops the further coning. But remember, it cannot get it back again. So this is the latest treatment, which is called the C3R. And with that, ladies and gentlemen, we have had enough classes, enough elongation. If many of you feel like clapping like this lady here. Yeah, this is. Thank you very much for patient listening, and I'll just take a couple of minutes to answer your questions. If you have any further, please write to me. I hope this has helped you. And all that you have to do is to revise this quickly. And I think that of the 15 to 20 questions that are expected in FMG, you should be able to identify most of them from here. Okay? But remember, you need revision. If you have one mantra, it's revision, revision, revision. You have to keep revising all the time. Okay? So a few questions. How many questions from predict? How many questions were from the session? I'm so sorry, Dr. Syed, I can't predict it, but I think that you should get around, if you have say 15 questions entirely ophthalmology with the pictures and all, and this you should say around 60% should come from here. Okay? That is my prediction, but really not being God, I cannot say that. And then we have vitamin A therapeutic dosage. Okay. And prophylaxis doses. So vitamin A, remember, we talked about this. The only one dosage that you have to remember is for children, which is more than 12 months of age. No, when that means 1 year of age. For anybody more than 12 months of age, we have oral doses of 200,000 or 2 lakh international units on 0, 1 and 40, is it not? Now, this, if it is a child is less than 12 months, that is less than 12 months, that means between 6 to 12, okay, between 6 months, 12 months, then you make this half a dosage, which is from 200,000 becomes 100,000, okay, it becomes 100,000, 100,000, 100,000, okay, and if you have child less than 6 months of age, then you half it, okay, so there's 50,000, 50,000, 50,000, okay, so it's easy to memorize, because we just make it half, we just keep making half. So more than 1 year of child, 2 lakh, 2 lakh, 2 lakh, between 6 to 12, 1 lakh, 1 lakh, 1 lakh, less than 6 months of age, you need half of that, 50,000, 50,000, 50,000. Okay. So this is the doses according to age, which you will find also in this thing. And so then we have the vitamin dose, then we have, yes, we've got Dr. Syed saying polymegathism and polymorphism, excellent. That is correct. He's talking about polymegathism and polymorphism, which is the property of the hexagonal cells of the endothelium. Okay, so polymegathism is the size and polymorphism is the difference in shape. You're quite right. PDF, yes, I will share the PDF on Dr. Banu's Telegram channel, so don't worry about it. And so we have some other questions which I have missed out. Anisette, yes, we will try to do an Anisette session also for this. I would like to do that if you are interested. And if there are any questions, I think that we have done most of the questions. Meibomian glands, somebody has asked me. Vivan has asked about modified sebaceous glands. Okay. And Meibomian glands, yes, remember the Meibomian glands are a modified sebaceous gland. Okay. The only sweat glands is the glands of Moll. The glands of Moll, which are sweat glands, modified sweat glands, modified sebaceous glands, Meibomian glands, and they're also the Zeiss glands. Okay, the Zeiss glands also, they are also both the Zeiss glands and the Meibomian glands. They are both modified sebaceous glands. Okay, so that is quite correct, Vivan. You have got this right. And then we have Dr. Charan asking how to identify yoke muscle. Remember, yoke muscles, we just use the initial. So suppose you get a right yoke muscle, right superior oblique. What you do, just reverse the initials. The right becomes left, superior becomes inferior, oblique becomes rectus. Oblique becomes, okay. So remember, right becomes left, left becomes right. Reverse the initials. Superior becomes inferior, inferior becomes superior, oblique becomes rectus, rectus becomes oblique. That's all. So to identify yoke muscles, just reverse the initial. Right becomes left, left becomes right. Right, left, then superior becomes inferior, inferior becomes superior, rectus becomes oblique, oblique becomes rectus. A very simple way to do it. And any other questions? I think yes, that is all that we have got. I've got most of the questions covered here. And we have okay, we've got a question from here from Puneet, which says, which anti-glaucoma drug has side effect of heterochromia with growth of eyelashes? Yes, please remember, very important. These are the prostaglandin analogs, is it not? Remember, the prostaglandin analogs are famous for their heterochromia, which means they will hyperchromia, actually not hetero so much, hetero means different, hyperchromia, they will darken the color of the iris, So prostaglandin analogs particularly will cause heterochromia and cause which is known as enlargement of eyelashes. Okay, so that is also called as, that is the typical prostaglandin analogs. But if you want to know one particular drug, it's again the drug which causes the maximum lowering of intraocular pressure. Bimatoprost is famous for causing trichomegaly. Trichomegaly, enlargement of the eyelash. So if you want long dark eyelashes, you put on bimatoprost. So that is one. So we have these questions. And what about the weight of less than 8 kg and more than 1 year child? Of what? I'm not getting this question. I'm so sorry. Weight is less than 8 kg and more than 1 kg. Less than 8, more than 1 is falls in the more than 1 kg group, please. More than 1 kg group. So 200,000, 200,000, 200,000. Okay, that is what it happens. And therefore, ladies and gentlemen, with that, I think that's enough. And I'm so sorry for keeping you so long. Please write because I hope you have gained out of this. And my ladies and friends, may you have the best of luck. May you all pass the exam with flying colors, which I am 100% sure that you all will. Thank you very much and all the best.